therapy at Kasturba Hospital. Coming to the introduction, generally patients with HIV, they are with low immunity and all. So they will be having several comorbid conditions and opportunistic infections. So they will be giving with several multiple drugs, and these multiple drugs leads to the drug-drug interactions. These days, drug-drug interactions are the biggest concerns for clinicians to deal with. So increasing awareness of these interactions helps physicians to provide them more good therapy by preventing drug interactions and by selecting appropriate drugs. So most of this can be prescribed safely either by dose adjustments or by substitution with the other medications. My study objectives are to evaluate all possible drug-drug interactions with different classes of highly active antiretroviral therapy, and to estimate prevalence of drug-drug interactions with hard combinations, to identify all possible risk factors for occurrence of drug-drug interactions with hard combinations. Study design and methodology. My study is an retrospective observational study, and it was carried out during August 2015 to February 2016 with an institutional ethics committee approval. Sample size is 240, and inclusion criteria is patients with either sex diagnosed with HIV and who are prescribed with heart therapy, and rest all come under the exclusion criteria. My sources of data collection are individual case record forms and drug-drug interaction documentation forms and all the required reports and all for the study. Coming to operational modality, first all the prescriptions of 240 patients were reviewed and they have monitored, and relevant information were collected and assessed for drug-drug interactions using Liverpool database and Micromedics database. And these were classified based on the onset severity documentation and significance rating through Micromedics. And statistical analysis was carried out using SPSS version 50, and a p-value of 0.05 was considered as statistically significant. Coming to the results, first is what are the possible drug-drug interactions that can occur. As patients are with more comorbid conditions and opportunistic infections, cotrimoxazole is the major drug that it is often prescribed for the prophylaxis in those patients. So it has more interactions with lamivudine, ampicillin and zidovudine. These are the heart regimens. The most commonly prescribed regimen and the most common regimen which is associated with drug interactions is lamivudine, zidovudine and nevirapine. And coming to the individual ARV, efavirenz is found to be more prone to drug interactions, that is around 49 out of 267 interactions. And NRTIs, nucleoside reverse transcriptase inhibitors, are most commonly associated with drug-drug interactions with a 50.6%. And in this you can see that CD4 count with less than 200 cells per mm cube are more prone to interactions, and people who are having 2 or greater than 2 comorbid conditions are found to have greater interactions. Assessment according to Liverpool database. In this you can see that a red flag indicates the number of drug interactions which would be contraindicated, and rest all the drug interactions are which need dose modification or we can substitute with some other drugs. This assessment and significance rating is by Micromedics. You can see the time of onset, severity, documentation and significance rating of the drug interactions. Most of them are delayed in time of onset and minor in the interactions and probable in the documentation, and level 3, that is minor, suspected or greater of interactions. Coming to the classification, most of the drug interactions are pharmacokinetic interactions and only 11% of them are pharmacodynamic interactions. Prevalence of the drug interactions, out of 240 patients reviewed, only 107 patients are having drug-drug interactions and rest 133 are not having drug interactions. Okay, these are the risk factors associated with drug interactions. interactions with a p-value of less than 0.05. So psychiatric disorder, respiratory tract infections, diabetes mellitus, hypertension, ischemic heart disease, cardiovascular attack, and pneumocystis carotidium pneumonia. These are the different comorbid and opportunistic infections which are associated with PPIs. And my conclusion is that in every patient, potential drug-drug interactions are very common, and as you increase the use of heart therapy, drug-drug interactions goes on increasing. So clinicians must concentrate on preventing these interactions either by substitution of the drug or by dose modifications. Actually, there are not enough studies establishing in the Indian setting on this particular drug-drug interaction. So my study might provide some help to the lacking data on the prevalence of drug interactions in the Indian setting. I would like to acknowledge AIDS Society of India, President and Scholarship Coordinators of Asicon, and my co-author, guide, co-guide, and Kasturba Hospital and Manipal College of Pharmaceutical Sciences for giving me opportunity to do this project and present here. These are the references. Thank you.
Yeah, good presentation, Doctor. I would just like to ask, have you tried to compare them with CD4 count, whether any higher CD4 gives lesser or any higher than?
I did that. We have taken the CD4 count of the different patients, and then we checked the drug interactions with them. So we found that patients who are having the less CD4 count are they have more interactions.
More interactions.
Yeah.
Group NITs or NITs, anything like that, so you compare? Sorry? You compared which group is having NITs while having the
I compared it, I can show you.
Yeah, that's okay. Any questions?
As per your presentation, it told that NRT has more drug interaction than the PI.
Yeah.
As per literature, PI has more interaction than the other drugs.
Yeah, but
see, possible is that only 4 patients, I'm getting only 2 patients, 50%. That is perfect. The number of patients on the NRT is much more than PI.
That's what in my study.
So you cannot people compare that particular group.
Yeah.
So for example, 100 out of NRT patients will be 70%. That's 70%.
Yeah.
But 4 out of 4 all will give 100% PI. So
Yeah.
that is selfish, not possible.
The thing is, in my study, generally PIs are more prone to interactions. But in my study, as I see the prevalence, like 135 patients are prone to interactions who are prescribed with NRTIs.
Your number 44 patients. Out of that, almost all got getting PI interaction.
No. That is just the interactions number. It's not the patients prescribed with heart.
44 patients of PI got interaction.
Yeah.
How many patients with the PI? That's what you want now.
Okay. I haven't done it, like how many patients are prescribed.
Nice presentation.
Thank you, ma'am.
What do you think that drives CD4 count less than 200? What is the reason? Did you find that patients that want
Generally, patients with HIV, they have low immune response, and they do have CD4 less than 200 if it is severe, like in case.
reason, like mechanism? Does it affect the pharmacodynamic, kinetic, CD4, low CD4? How you can explain that?
Ma'am, actually, it's not a significant risk factor for drug-drug interactions.
Exactly. That's why I'm asking.
A good presentation. This actually gives us an insight to look into whenever there is pharmacy, we use multiple drugs in various ways that you said. I think probably what actually is the driving force is because there are multiple drugs used for different challenges that we have clinically. That actually adds on. Now again, it's not very certain whether the CD4 is the driving force or it is the polypharmacy which determines the tendency for drug interaction. Because unless we do studies on pharmacogenomics, we really cannot get to understand. But it definitely gives an insight that we need to be really open-minded and get to understand more and more about it. On the question of PIs, probably the number of patients who are on PIs must have been small. That's why your percentage also reflects. Suppose like what Azhar is like, suppose you were to categorize them into PI group and NRTA group and taken the percentage, you have thrown clear cut.
But actually, all these patients are prescribed with combination therapies.
Yeah.
Right. Those are not
That's quite
individual.
understandable because considering multiple OIs and other
Yeah.
comorbid conditions, which will add on the number of drugs, it will definitely be a impact for that. Thanks.
Thank you.
Thank you. We should proceed with the second one. Please.
Very good morning to everyone. I am Dr. Kailas from Prayas, Pune, presenting my study on about the treatment outcome of people living with HIV, the experience from the private sector clinic, Pune. As we all know, there are 2.1 million people living with HIV in our country. Around 81,000 number of patients on first line and around 10,000 patients getting the second line ART, according to the annual NACO report. There is randomly increase in the second line failure rate. That's why there is increased number of patients require the third line ART. And there are very less data available on the third line ART outcomes. Coming to the background, my study platform is a Prayas Health Group from Pune, which working in the HIV related issues since 89, and till date around 8,000 patients registered at that clinic. Of these, around 5,000 patients ever initiated first line ART, and currently there are 2,000 patients in active follow-up. Around 250 patients are on second line ART and 33 patients on third line ART. Coming to the methodology, my study objective is to describe the treatment outcome of third line ART at the clinic base. And the method used in the study is retrospective cohort study. The secondary analysis of data are collected during the clinical follow-up of all patients. And in my study, I took the all adult patients and who take the minimum at least 6 months of third line ART. Coming to the cases included in the analysis, the total number of patients on third line ART is 33, out of which 5 died, 2 lost to follow-up, 1 transfer out, and 2 sensor in data within the 6 months of third line ART. And remaining 24 patients are included in my data analysis who have completed at least 6 months of third line ART. Coming to the results of the study, the demographic and clinical details. My sample size is 23, all patients infected with HIV first. The median, the total men are 74 and 26% are women. The median year at the third line ART patients was, at the time of initiation, is 45 years. Coming to the previous history of ART, the prior duration of first and second line ART is 57 and 34 months. The commonly used regimen at the time of first and second line ART was 2 NRTA plus 1 NRTA, and at the time of second line ART, 2 NRTA plus boosted PR. There are various substitutions during the first and number of substitutions during the first and second line ART. Approximately 70% had at least 1 substitution during the first line ART, and 43% had at least 1 substitution during the second line ART. The most common reason for the substitution are the drug toxicity, changes in program strategy, drug interactions. In the slide, there is a data available for the various exposure to ARV drugs. Coming to the third line regimen, the mostly third line regimen used is RGB plus ATVR and RGB plus DRVR, and all the regimen combinations used in third line ART was based on the drug resistance report. Coming to the virological and immunological outcome of third line ART, the median viral load at the time of initiation of third line ART was 28,000, and this goes to the zero low detection level after the 6 months of third line ART. Same as in immunological outcomes, the median CD4 was 161 and goes to 326 after the 6 months of third line ART. These are the virological outcomes of the third line ART in 23 number of patients. Same about the immunological outcome of third line ART in 23 number of patients. Come to the treatment outcome of third line ART. The sample size is 23, out of which 15 patients are in regular follow-up, 2 patients is lost to follow-up, 2 patients expire, and 4 patients are transfer out. All cases were followed for median of 33 months. The time to death and loss to follow-up was 11 months. The reason for death was PML and cardiac arrest, and both patients had poor adherence during the third line ART. Coming to the conclusion, the third line ART regimen succeeded in achieving improved immunological outcomes and virological suppression in majority of people living with HIV. Thank you.
On prevalence of metabolic syndrome in HIV positive patients on antiretroviral therapy. As we all know, a great number of endocrine and metabolic disorders such as ART associated lipodystrophy and metabolic syndrome are seen in the context of HIV infection. This may be a direct consequence of HIV infection, secondary to opportunistic infections or neoplasm, or related to medication side effects. In keeping this in mind, determination of the contributory factors and effective steps towards prevention and control are the need of the hour. I aim to study the prevalence of metabolic syndrome in HIV positive patients on ART, and also to compare the effect of zidovudine and tenofovir based ART regimens on metabolic syndrome. After obtaining Institutional Ethics Committee approval, an observational cross-sectional study was conducted over a period of 12 months comprising of 145 HIV positive patients fulfilling the inclusion and exclusion criteria of the study. An appropriate statistical tests were used for analysis. I included HIV positive patients attending virology OPD or admitted in medical wards of tertiary care center who were more than 18 years of age and were willing to give informed consent. Pregnant patients, diagnosed diabetic or hypertensive patients on respective medications, patients taking steroids, and patients on known hypolipidemic drugs were excluded from my study. The study subjects were divided into 3 groups, those on zidovudine based ART, those on tenofovir based ART, and those who were yet not started on ART. Metabolic syndrome was defined according to the harmonizing criteria. Here are the results of my study. 1/3 of the patients in the zidovudine group comprised of females, whereas almost 2/3 of the patients in the tenofovir group comprised of females, and almost an equal number of study subjects in the ART-naive group were males and females. A maximum number of patients in all the 3 groups belong to the middle age, that is 30 to 50 years. CD4 counts of study subjects at the initiation of ART in both the groups maximum number of patients had CD4 counts less than 200. At the time of recruitment, when we looked at the CD4 counts, in the zidovudine group, almost equal number of patients belonged to the, had CD4 counts less than 350, 350 to 500, and more than 500. Whereas in tenofovir group, there was a slight greater number of patients having CD4 counts in the range of 350 to 500. Whereas in the ART-naive group, a significant number of patients had CD4 counts less than 350. When we measured the BP of the patients, it was found that in the zidovudine group had a higher prevalence of high BP as compared to the tenofovir and the ART-naive group. An equal number of patients in all the three groups had central obesity. When we measured the fasting blood sugar levels of the patient, it was found that the patients in the zidovudine group were more likely to be having fasting hyperglycemia as compared to the tenofovir and the ART-naive group. More number of patients in the ART-naive group had low HDL cholesterol as compared to the tenofovir and the zidovudine group. Patients in the zidovudine group were more likely to have hypertriglyceridemia as compared to the tenofovir and the ART-naive group. When we looked at the number of criteria that the patients satisfied, it was found that although patients, more number of patients in the tenofovir and the ART-naive group satisfied one or two criteria, the maximum number of patients satisfying three or more criteria of the metabolic syndrome were found in the zidovudine group. This is the prevalence. 14 patients out of a total of 48 patients in the zidovudine group fit into the syndrome of metabolic classification of metabolic syndrome, whereas only 5 patients out of a total of 47 patients in the tenofovir group had metabolic syndrome, and 9 patients in the ART-naive group had metabolic syndrome. When we looked at the gender distribution of metabolic syndrome, it was found that 3 patients in the zidovudine group, 1 in the tenofovir, and 5 in the ART-naive group had metabolic syndrome. When we looked at the metabolic syndrome in male patients, it was found that metabolic syndrome was very much highly prevalent in the zidovudine group as compared to the tenofovir and the ART-naive group. The patients on ZLN and ZLE regimen were more likely to have metabolic syndrome as compared to the TLN and TLE regimens. Using multiple logistic regression, no significant difference was found between nevirapine and efavirenz group. So I conclude that amongst the NRTIs, tenofovir-based regimen is safer in terms of metabolic syndrome as compared to zidovudine-based regimen, although recommended lifestyle modifications have to be maintained to control metabolic syndrome. And these are the references. Thank you.
Have you seen any association of change in metabolic syndrome with diet and the weight of the patients to start with? Diet, food?
No, sir.
No.
No, sir. No, we have not studied that. We have not taken that as a criteria.
Okay.
Any questions from the audience?
In these two groups, both the groups, the patients were exposed to the drugs in the number of years. It was equivalent? I mean, same number of months or years they were exposed to zidovudine or tenofovir?
Yes, ma'am.
How many years?
Around 3 years.
All
3 to 4
you
years.
checked after 3 years?
Yes, ma'am.
Thank you.
Thank you, Dr. Karan. We'll call our last speaker for the day, Dr. Ashwini Deshpande from Pune. She'll be
On this
presenting.
platform, and of course for the scholarship. Today I'm going to say about the characteristics of HIV-infected children initiated on ART at Manavya. Before going to the main topic, let me shortly introduce Manavya and our residential setup Gokul. Manavya is a pioneer NGO working in the field of HIV, which gives residential care and a rehabilitation home to HIV-infected orphan children and women. It was founded by late Vijayata Ilavate on 18th June 1997. It established Gokul on 25th November 2000. It offers shelter, education, vocational opportunities, nutritional diet, medical treatment, and ART assistance to 50 HIV-positive orphan children and 3 destitute women. Today, we have 3 doctors and a residential nurse for close monitoring and medical care of the children. We ensure regular and supervised ART leading to 100% adherence. We have a hospital in campus to treat minor illnesses. We provide them a healthy, nutritious, and high-protein diet distributed in 6 times over a day. We make them do yoga, exercise, and pranayama to make them a good health twice in a day. So after establishing this basic setup, now we are looking forward to broadcast research, and with our analysis, we are here today. Our objectives are to describe the characteristics of HIV-infected children who are initiated on ART from Manavya. This is a retrospective study of children residing with us from August 1999 to March 2016, and who were initiated on ART. The demographic, clinical, and laboratory data was extracted from the NGO registers. Total 91 children were registered, among which 28 were already on ART, and 63 were totally ART naive. Among these 63, 12 remained ART naive, and 51 were initiated on ART. We were getting the ART from some private agencies, from Prayas, from Cipla, pharmaceutical company earlier, and later on we got registered at the government ART centers, first DJ and now BJMC. The median age at entry of Manavya was 6 years. Their median duration in NGO was 10 years, contributing to 340% years of follow-up on ART. Their median age at ART initiation was 8 years, and the median CD4 count at ART initiation was 398 cells per cubic millimeter. 10 children had tuberculosis at baseline. Average time at the entry of leaving Manavya was 18 years. 55% children were started on zidovudine-based regimen, 33 were having stavudine-based regimen, and 12% with some other regimens. There was a significant rise in the CD4 count at the end of 5 years, which comes down to 809 cells per cubic millimeter. A total 14 children showed failure to a first-line regimen, and the median duration of time to failure was 7.5 years. There were total 59 hospitalization in 26 children, and the hospitalization rate was 17.6 per 100% years of follow-up. 8 children died, and the mortality rate was 2.35 per 100% years of follow-up. When we compared our studies with some other studies, we saw that the rate of failure to treatment was lower than that done in a study in Uganda. Theirs were 23 and, ours were 23 and their percentage was 34. Our median time to first-line failure was longer, 7.5 versus 26.4 months in their study. Though overall failure was higher in our study than in Africa, 23 versus 12, but the time to failure was much longer in our study as compared to them, 7.5 years versus just 9 months. Our mortality rates were lower than that reported from a study in Bangalore, 4.9 deaths per 100% years. They are also lower than that report in sub-Saharan Africa, 3.4 deaths per 100% years. We could not find much significant data for comparison on hospitalization rates in India. I know there are some limitations to our study, like at the time of institutionalization, the height and weight of some patients is missing, as we are struggling for the shelter and changing places continuously till we got to Buga. We have missed some data. Viral loads are done only for management purpose and are not included in this study. But I would like to speak about the education and psychosocial support we are giving to our children. Due to discrimination from society, our children were not allowed in regular schools and they could not take formal education in the early phase. Hence, Manavya started a school in its premises in 2002. First, it was started under Mahatma Phule Shikshan Hami Yojana with just one teacher, but I'm proud to say that we have a ZP school in our premises and the nearby villages are accompanying our children today. We encourage them to take vocational courses like in computers, in ITI, in agriculture, bakery, electronics, and various such courses which enable them to be self-sufficient earlier. We support their extracurricular activities like dance, music, painting, art and craft, tailoring, everything they like, so as to explore their hidden talents and to take them their career paths. As Dr. Priyanka and many other speakers yesterday elicited rightly yesterday that the psychosocial support is equally important in HIV patients. Hence, we provide them with counseling sessions. We have got residential social workers, superintendent, and very strong staff which continuously keeps on counseling on adherence, on adolescent problems, and many more. We encourage them to have a positive attitude towards life. We make them live a normal life. I would like to say that now 20 of our children have completed SSC. They are taking the further educations. 3 of our children are married. 2 of the girls have conceived and looking forward for their issue. We also conduct Vadhuvar Medava for other HIV patients also. It's an yearly event in which not only Maharashtrians but other states are also joining us for this event. We conduct a Umed mobile clinic through which we provide medicines to the community at very low cost. Our prime aim is to decrease the stigma in society via conducting awareness programs through street plays, rallies and lectures and many other modes. We also provide home-based care project in which we encourage children to live at home with their parents. We just provide them nutritional and educational support. So, our children today among 51, 25 are yet in institution and taking their education. 18 children have left Manavya, 1 of them was lost after a year. But 8 children are working and are self-sufficient. 3 children are working and taking the further education. 6 are taking their further education, and we are supporting the children beyond 18 years also through Unnati Support Group, which is created in 2009 for the educational, nutritional, and medical support. So to conclude, our children responded well to ART as we had 100% adherence. The time to failure of first line was also longer. Irrespective of being orphan, these children are getting good opportunities today and are being self-sufficient. So ours is a unique residential setup for HIV-infected orphan children. These are the few references for our comparison studies. I thank Dr. Arundhati Sardesai, our President, Managing Trustee, Mrs. Ujwala Lavate, and of course, I mention my sincere gratitude towards Dr. Vidya Patil, who is the medical officer working with us since day 1 of Manavya's establishment and even today. I thank NARI team for their kind support and their guidance in the research and this abstract also. I thank Sassoon General Hospital and all the seen and foreseen hands who have been helping Manavya to be here today. I thank you all for patient listening.
Thank you, Dr. Ashwini. I really congratulate you. That's a commendable work you're doing.
Thank you.
Any questions from the audience?
It was a wonderful talk from you.
Thank you.
I am from Manipur. I salute your institution.
Thanks.
I have 2 questions to you.
Yeah.
In your talk, it was some 18 persons left. No, the residents were allowed to leave at the age of 18. Did I hear you correctly?
Sorry, I couldn't get your question.
The residents, your residents
Yeah.
go out of your institution at the age of 18.
Yes, up to age of 18.
What could be the reason for them to leave your center? Means how do you, what are the reasons for their leaving your center?
No, actually, these all are court-committed children. We get them through the CWC, that is Child and Welfare Committee, and hence they are allowed only till the age of 18.
Right. Another question is,
Yeah.
You have 100% adherence of ART of your children.
Yeah.
And you still say that after the 5% went into drug failure, am I right?
Yeah, after 7.5 years, we get the first line failure, but I guess it is a normal course as far as my knowledge says.
But I think if you are 100% adherent, the rate of failure is much lesser than your percentage. That's what I want to tell you. If a person is 100% adherent to the line of ART to which they are taking, the percentage failure rate which you are quoting is a bit higher.
The percentage might have been high, but what we do is we provide our ART at 8 a.m. and at 8 p.m. every day in front of the residential nurse. If she is not there, in front of the superintendent or the social worker, we ensure one person being and observing them taking ART.
That is usually what we do also, but we find that the resistance or failure rate looks to be a bit higher from our center.
I think we will have to study more regarding it. Why is it
Thank
so?
you.
Thank you for your suggestion.
Thank
Yes,
you
sir?
for that excellent presentation.
Thank you, sir.
And I remember that many of the children were actually started on treatment under my care
I know,
back.
sir.
And one of the answers to his question is that initial period when they were not in the government setup and when the organization was moving from place to place, probably there was non-adherence earlier on. So majority of the failures of the children who failed after 7 years were older children. And I would like to also tell the audience that it's so nice that the children who have moved out of the institution, one of them has actually joined our organization and is leading a peer support group now of HIV-infected children.
Thank you, Kulkarni sir. Thank you all.
Thank you. We should close.
Thank you.
Dr. Gilada and Asicon for this opportunity to present the changing ART guidelines in India. And I'll be just giving you an overall view of how the guidelines have been evolving globally. What are the current recommendations? What are the current national guidelines? What it takes to change the guidelines. When we are saying changing guideline, we cannot immediately change as soon as we get the global guidelines. So what it takes, what are the preparatory requirements, what is in the pipeline, and what are the future directions in terms of antiretroviral therapy and HIV/AIDS in general. But I would like to give a very loud and clear message. The recommendation is to treat all those who are diagnosed with HIV, but ensure that they adhere to the treatment. They do not stop treatment because of side effects, because they have not been prepared well. So when you take this treat all recommendation, there are a number of things attached to it. I think this is a very learned audience. I don't have to give details, but for summarizing, for some of the new people, some ART medical officers, I'll just give you how the guidelines have been changing. We know that we cannot cure HIV as of now. There are reports, you must have read some few days back in London also, and you read about the German patient also, Timothy Brown. But our goal presently is to prolong the life, improve the quality of life, suppress the virus as far as possible, as long as possible, and also to reduce transmission. That is a very important goal of antiretroviral therapy. Just to give you an overview of WHO guidelines, WHO guidelines are basically for low and middle income settings, more for concentrated epidemics or generalized epidemics, but they take feasibility, equity, and resources into consideration when the guidelines are made. They follow a public health approach, that they are simplified, standardized approaches with the widest possible coverage, and health equity and human rights are also maintained while these guidelines are maintained. I will not go into details, but there is a big process which takes 1 to 1.5 years on the WHO guidelines development, right from constituting the guideline develop group, formulating questions, getting the systematic reviews, quality of evidence, and which is graded according to its strength. And if some of you happen to read that guideline, you must be reading somewhere, it is a strong recommendation, low quality of evidence. You might be a little confused why it is low quality of evidence, why the recommendation is strong. So basically, quality of evidence is dependent on what level of evidence you have. It is a randomized control trial. Definitely it's a high quality evidence. It's an observational study. It could be moderate to low quality of evidence. Strength of recommendation can be basically strong recommendation based on confidence that benefits of intervention outweigh the risk. So even sometime when you have low quality of evidence, you may have a strong recommendation. And WHO guidelines give you not only clinical guidelines, they are for program manager also, give operational service delivery, which may not be of much benefit to private practitioners, but definitely in the national program, these are very useful. This is just an overview. It's 8 chapters, 475 pages guidelines with 51 sections, more than 1,000 bibliography. There are 7 new recommendations on diagnosis. There is 1 new recommendation on ARV for prevention, that is PrEP. There are 22 new recommendations on antiretroviral therapy. You can just, the slides will be available to you after the conference. You can just go through that. But the key message is treat all. That is the message. Also, the message is that there should be phased introduction of new drugs, which may include TAF in place of TDF, maybe dolutegravir. So there would be a phased introduction of new drugs, but this might take maybe 1 to 1.5 years as these drugs are in. There is a new concept which has come for public health basis, a differentiated care package. I'll go to that in detail later on. We know guidelines have been changing. Some of the people who started their HIV involvement earlier knew about David Ho. He said that hit hard, hit early. But then we went to guideline of 200, 350, 500, and then now treat all. So very quickly, 200 was a cutoff taken because most of the AIDS defining opportunistic infection happened when CD4 count was less than 200. That was the basis for cutoff, just like what is basis for treating hypertension at 140/90 or diabetes guidelines. But then came a trial, CIPRA HTO2 is the history, but just to say that basically this trial provided evidence that there is a 75% reduction in rate of death and 50% decrease in incidence of tuberculosis if you provide ART at CD4 count less than 350 instead of 250. So the guidelines changed to 350 cutoff. Then came two landmark trials. One was HPTN 052, in which there were 2 study sites in India, also in Chennai, YRG Care and Nari Pune. And then there was SMART trial basically again, which showed that there is a moderate quality of evidence for lower risk of death and progression to AIDS with these studies. And these changed the guideline to 500. That was 2013. Then there were 2 more trials, African Temprano trial, which had 4 arms, not 2 arms. It was deferred ART with isoniazid preventive therapy, early ART, and early ART with IPT. Again, I will not go into details, but very clearly it was a 7-year study which showed that HIV starting treatment at CD4 above 500 reduces the risk of serious illness and death by 44%. It also showed that providing 6 months of IPT also reduced the risk of developing TB by 35%. So it was a randomized control trial which provided a strong, high quality evidence. Again, START trial, which was strategic timing of antiretroviral therapy. Again, this trial was in 215 sites in 35 countries, including 2 sites in India. And again, the trial showed that there is a 53% risk decrease in risk of developing serious illness or death by providing ART at more than 500. And there were additional benefit of providing IPT as well. So it was on 30th September 2015 that there was a news that offer antiretroviral therapy to all patients living with HIV, all persons living with HIV, and also offer antiretrovirus additional prevention choice, that is the PrEP, for people who had substantial risk. And this will actually lead to averting more than 21 million deaths and 28 million new infections. So WHO in September 2015 itself, though the guideline, full guidelines were released in June 2016, it said all people who are infected with HIV, all age group, all populations are now eligible for antiretroviral treatment. So this is an overview how the guidelines have been changing right from 1995 to 2015 as the evidence became available. So in 2015 guidelines, that is 2016, it says treat all. It says moving towards earlier initiation, treat all, continue with fixed dose combination of single pill of tenofovir, lamivudine or emtricitabine with efavirenz. But new options are in pipeline, that is dolutegravir and 400 milligram of efavirenz instead of 600, and also the TAF. Again, there are more options on the second line, and WHO says provide third line drugs also, and monitor all patients started on ART with viral load. I think that is all. So in 20 years time from 1996 in Vancouver, when HEART was introduced in 2015, basically it became HEART for everyone. So no other science has moved forward so quickly and with strong evidence in just a period of 2 decades. Also WHO recommended that CD4 count is important at baseline and in case of failure, but CD4 count needs to be phased out. It is no longer required because we are treating everyone. But viral load facility should be available for regular monitoring. Unless you have viral load facility regularly available, which is not available in the program at present, we follow a targeted viral load approach. I don't know, it's going on its own. So basically, if you have a viral load facility, then CD4 testing needs to be phased out. So the benefits of early antiretroviral treatment are well documented. Reduction in mortality, decreased T cell activation, prevention of HIV transmission by almost 96% among serodiscordant, and more robust immunological response if you start early. Coming to Indian guidelines. Indian guidelines, like any other program, follow a public health approach. The present guidelines are that test and treat is available for all HIV TB co-infected patients, all HIV hepatitis patients, all HIV Kala-Azar co-infected, which may be in 4 states, more pregnant and breastfeeding women, children less than 5 years. So the eligibility criteria is treat all of them irrespective of CD4 count. Also all those with stage 3 and 4. So you only those criteria left which patients which are in clinical stage 1 and 2 that you follow the CD4 criteria 500. So we are almost 80% towards treating all. That is the current status as of now. The national program has been using single pill of tenofovir, lamivudine, efavirenz right from the beginning. In fact, India has been using fixed dose combination right from 2004 when they started the program. I think these are advantages. Treatment failure, there is no change in the guideline as of now. We are doing a targeted viral load only. That is, those with immunological failure get a viral load presently. That is, immunological failure is fall of CD4 count to pre-therapy level, 50% fall from the peak value, and if it is persistently below 100 and it's not rising, or if there is a WHO clinical stage. Definitely we are diagnosing patients with failure late because we are not doing a viral load. We are doing only a 6-monthly CD4 count as of now. But once the targeted viral load is done, if it is more than 1,000 copies, person has to be changed to second line ART, and second line ART will depend on what was the first line, because there are patients, almost 4 lakh patients on zidovudine based regimen. All new patients are initiated on tenofovir based regimen, but those who are on zidovudine based regimen continue to be on them. So if they are on zidovudine based regimen, they go to tenofovir based NRTI backbone along with their boosted PI, that is atazanavir, ritonavir. And if there is toxicity to atazanavir or HIV2, then it is lopinavir, ritonavir is the drug of the choice, as in addition to NRTI backbone. Third line regimen has also been introduced now in the program. We have procured drugs for 1,000 patients, but we just have 70 or 75 patients currently on third line. It is darunavir, ritonavir and reltagravir based combination, which is available presently at centers of excellence only. PPTCT guidelines, since January 2014, we have been providing lifelong ART to all pregnant women. Though we are not able to diagnose all 38,000 positive pregnant women that are estimated to be with HIV, we are able to diagnose only 13,000 or 14,000 pregnant women. That is because the total number of pregnancies is 29 million in our country, and we are just able to reach out to 12 million. PEP regimen has been revised, that we also provide the similar tenofovir, lamivudine, efavirenz. But if the patient is on ART, then naturally it has to be a PI based regimen or maybe even reltagravir based regimen. This is how the guidelines have been changing in India. We started with 2000 CD4 cutoff in 2004. In 2010, we moved to 250. We moved to 350 in 2012, and now we are at CD4 count of 500. Last part of my talk is what it takes to change the guidelines. Why we have not started treating all, or why it took 2 years to move from 350 to 500. We have moved to 500 just in May 2016 when the guideline came in 2013, and we decided in 2013 that we want to go to 500. So basically, country needs to adopt these guidelines. WHO very clearly says treat all, but puts clearly that sick is to get priority. Though that is not the situation in our country, we have enough drugs. This may be for some other countries where there is a limitation in terms of drugs. Countries need to adopt WHO guidelines. There is a technical resource group. It is a group which is headed by a private practitioner, not by a government official. It is a balance of national experts, international experts, network of positive people, and also representative from Indian Association of Physicians and IAP. TRG meeting was held soon after the release of guideline in June 2016. Some of the TRG members are in this audience also. TRG did recommend there is a strong evidence from these trials to treat all. So country needs to move to treating all. That was the very clear recommendation. Also the recommendation was we need to expedite the viral load monitoring and move quickly on the drug resistance surveillance also. Because presently we don't have an idea about the drug resistance to first line or second line drugs. So this was agreed. So what is the next? I think it is important for you to understand, because we keep on questioning why NACO is not moving to 500 or why it is moving late. So the second program part is increase load at ART center. Once you move to 500, there are additional 1 lakh patients which are already with us. If you move to 500, there are additional 1.5 lakh. We have certain quantity of drugs procured. The next cycle of drug procurement, according to new numbers, takes almost 8 months of time. It also requires the additional resources. So that is additional CD4 testing required, or maybe viral load monitoring required. So with 1.15 lakh patients who are already with us, have more than CD4 count of 500, they need to come into the bracket. So we need to think whether we need to prioritize or need to give it to everyone. Budget may not be very big, 80-90 crores is not a very big budget amount, but we need to prioritize. If we cannot have 1.1 lakh patient coming with CD4 count of 500, now another 1.15 lakh coming, though there is a definite benefit. There is no denial on that. So we are thinking of prioritizing key populations, because all new infections, most of new infections come from the key populations, then serodiscordant couple, and then treat all. But still, even if we are moving to 500, basically we will have 12.5 lakhs on ART. We have 21 lakhs estimated with HIV. So where are these? So we have to find out these people to provide them. Treat all is possible only when we are able to diagnose all 21 lakhs. So those we are diagnosing, yes, immediately they should be put on treatment. But we are now in new phase of testing guidelines, basically community-based testing, reaching out to PHCs, partnering with public sector, private sector, maybe self-testing guidelines which have just been released. So also the last part is differentiated services. Basically, this is on the stable patient. WHO recommend that we should be now prioritizing stable patients who are coming to ART center every month. They need not come to ART center every month. There can be less frequent visits. We already have those guidelines, link ART centers. We are sending stable patient to link ART centers. There are 80,000 patients who come to ART center once in 6 months only to get their CD4 count done. Otherwise, they get their drugs at link ART centers. So the guideline WHO, which has given now in 2016, basically India has been probably following it since 2008 when we started the ART program and we started when we started the link ART center. Lastly, WHO also recommends less frequent clinical considerations. Basically, we moved out to 2 months drug dispensation in 2011, but somehow we are not able to maintain it. But now the new procurement cycle is actually putting up a buffer of 3 months stock, and we are going to soon move to 3 months dispensation to all stable patients on ART. This is just to give you the scale up. We have second largest ART program in the world with 9.8 lakh patients. Soon we are moving to we'll be having 1 million patients on ART. So key points to summarize are basically we are moving towards treat all, because early treatment there is definite reduced markers of systemic inflammation, immune activation, prevention of transmission. One single regimen, ART initiation with a simple pill. Routine viral load is also to be in place soon. The tender for routine viral load in first line ART for 8 lakh patients is already on the website, and by end of this month we will get and it is going to be public-private mix. We are actually asking on a PPP model that it is totally outsourced, right from collection from each ART center to transportation to lab and giving the report within a period of 7 days. That is one of the conditions of this. Drug resistance surveillance has already been planned. It was approved just 2 weeks ago, and NARI is going to do a drug resistance surveillance. Both were required and pre-treatment, ADR and PDR, and ADR at 12 and 48 months. This is a document available on NACO website in case you are interested, how the ART program is performed in India over a decade. Thank you.
Thank you very much, Dr. Rewari, for giving the glimpse of evaluation of ART and monitoring of the patients. My few questions are there. What is the possibility of start treat all patients at NACO level in near futures?
Yes, as I said, we have already agreed in principle because there is strong scientific evidence. And when we say treat all, that is why I showed there is a limitation in terms we cannot start it now. We decided now we have to procure the drugs for additional 1.1 lakh patients, and drug procurement cycle is an international competitive
logistic basically.
But it is in pipeline. We are going to move immediately for key populations, meaning thereby female sex worker, MSM, IDUs who are more at risk of transmitting. Immediately we are going to start treat all for them.
Secondly, the viral monitoring at ART centers or routine monitoring for the viral monitoring.
I have to admit that this is a weak point of the program. There is no doubt on that. We are still on immunological failure and targeted viral load approach for those who are having CD4 decline, and that definitely leads to delay in the switch of the patient. As I informed, viral load monitoring, we are doing almost 12,000 viral load tests every year, and for doing it for everyone we require 800,000, 8 lakh to 9 lakhs every year. So we have put up a tender on website. It is already floated. So we may get by end of this month the potential basically people who can do it, maybe some of the diagnostic laboratories or some other people. The money has been earmarked, so I hope that we'll be able to do the regular monitoring.
And third question is the genotyping at least second line failure. Genotyping in second line failure patient.
Second line failure, again, we have some evidence from ART centers that there could be around 5% of patients who may be failing on their first line ART. But the number presently is only 15,000. So some of the ART centers definitely are not looking into CD4 regularly, and there is a delayed confirmation of second line failure. And this is a issue we are focusing on priority, that every patient whose CD4 is done, at least it is looked at properly and he is immediately referred for second line. We have expanded provision of second line ART center to 120 centers across the country out of 520.
My question is, can you do genotyping? Genotyping
No,
in
genotyping we have not
at
decided.
least in few patients, at least in second line failure.
You have a point, there is no doubt on that. But WHO guidelines say when you have a basically pre-treatment drug resistance of more than 5%, only then this is recommended as a policy. So this drug resistance surveillance that we are planning with Nari will tell us whether we need really a, but definitely those who are failing on second line, we need that. We need that.
Any questions?
The questions will be taken at the end of this session. All question answers at the end of this session. Thank you.
Thank you.
Thank you.
At the outset, I would like to thank conference organizers for giving me opportunity to present on effectiveness of antiretroviral therapy. And what I'm going to do now is I'm going to present a study on effectiveness of antiretroviral therapy in 4 program clinics in Pune city. We had wonderful discussions now with Dr. Revari, and this study is basically focusing on viral load monitoring, and it has generated data on viral load monitoring, requirement of viral load in the program setting. As we know, initiated on 1st April 2004, there has been a substantial scale-up of antiretroviral treatment services in India. Over 500 ART centers are providing services to more than 9 lakh people living with HIV and AIDS. With maturing program like ours, it is essential to assess effectiveness of ART by estimating virological suppression. World Health Organization has recommended viral load as preferred monitoring, but our program, as Dr. Revari has mentioned, mainly relies on immunological and clinical monitoring, and targeted viral load testing is offered for those who are immunologically or clinically failed for confirmation of treatment failure. There is sparse data on effectiveness of antiretroviral therapy and also the predictors of failure in PL-HIV initiated on ART in the programmatic setting, because we need to generate evidence for having routine virus load in the program setup. So this study was done with primary objective to assess effectiveness of antiretroviral therapy at 12 months after initiating among people attending ART centers in Pune city. And the secondary objective was to describe determinants of virological failure at 12 months. This was cross-sectional study. It was carried out at 4 antiretroviral therapy centers in Pune city between June 2014 and August 2014. These 4 ART centers had different setups, like one was located in a tertiary care hospital, another was in the research institute, third one was a public-private partnership, and fourth was Armed Forces Medical College. The study was approved by National AIDS Control Organization, as well as Scientific Advisory Committee and Ethics Committee of National AIDS Research Institute. The national and operational guidelines were followed for all patients in these 4 ART centers, and ART was initiated as per the guidelines in 2014, that is CD4 count of less than 350 or clinical stage 3 and 4, and the preferred regimen was ridovidine, lamivudine, and nevirapine. The inclusion criteria were age over 18 years, documented evidence of HIV infection, history of initiation of ART 10 to 12 months back, and those who are willing to provide informed consent. The exclusion criteria were HIV 1+2 and HIV 2 infections, history of receiving antiretroviral therapy prior to enrollment in the ART center, except for those who received it for PPTCT. The sample size calculation was based on assuming virological failure of 15%, precision of 2.5%, alpha error of 5%, and anticipated non-participation as 10%, and it came to about 863. Consecutive patients who were initiated on antiretroviral therapy in these 4 clinics and had completed 1 year of their follow-up were enrolled in the study. The window of ±2 months was considered for enrollment. The data on baseline and follow-up visits were abstracted from the program cards. ART adherence of patients were measured at each visit as more than 95% or less than 195%. And for this particular analysis, the data from last 3 months was considered as a part of for analysis. The blood sample for viral load was drawn at the time of collection of CD4 count at yearly visit, as is done in all ART centers. The collected samples from these centers were transferred to Nari Virology Laboratory within 4 hours of collection for further processing. Viral load testing was done using Abbott real-time HIV-1 assay, and virological failure was defined as viral load more than equal to 1,000 copies per ml in a single testing. Chi-square test and Mann-Whitney test were used to examine the association of clinical and biological characteristics with virological failure. The median increase of CD4 count was calculated by Wilcoxon sign rank test. Binary logistic regression modeling was used for calculating adjusted odd ratios to find out the predictors of virological failure. And all the analyses were performed using XPace's 6.0 version. Coming to the results, total 844 individuals were recruited between June 2014 and August 2014 from all the 4 clinics, and they underwent viral load testing at 12 months. Of these 844 patients, 52% were females, 42.5% were above 41 years, and 65.5% were married. The employment rate was 64.5%. The route of HIV acquisition was heterosexual in majority of the participants, that is 90%. 80.7% individuals were on zidovudine-based regimen. Tuberculosis was the commonest clinical condition in around 21.2% individuals. The overall median count at baseline of all the participants was 213, which significantly increased to 379 at the end of 1 year. Suppression of plasma viral load to less than 1,000 copies was achieved by 740, that is 87.7% of individuals, and 144 of 844, that is 12.3% showed virological failure. We also did logistic regression analysis to find out factors that were associated with virological failure, and we found that CD4 count at 12 months and marital status were significantly associated with virological failure in all the participants. Also, ART adherent turned out to be an important factor that was associated with virological failure. Those who had less than 94% of adherence had high chances of virological failure at 1 year. Other factors like CD4 count at baseline, NNRTI or NRTI regimen at the time of failing, or any drug substitution within 1 year were not associated with virological failure. We also analyze other factors like women who have received single-dose nevirapine, patients who have attended public-private partnership clinic versus those who have attended other clinics, and among concordant couples who both were taking ART and those who were not. But we found that these factors were also not significantly associated with virological failure at 1 year. More interestingly, what we found was those who were 740 participants who were virologically suppressed. Among them, 58, that is 7.8 participants also showed immunological failure, of which 50 had CD4 count below baseline, 17 participants had CD4 count below 100 cells per cubic millimeter, and both these were present in 9 of the participants. Among 104, the most important finding was among 104 virologically failed participants, only 32, that is 30.7%, showed immunological failure. So, discussing our findings, virological failure rate in our study was higher than that showed in Vietnam, where it was 6.5% in participants from 13 clinics. It was also lower than Sub-Saharan Africa and Southeast Asia reports, where it was 11.1%. It was lower than 9 cohorts in lower middle income countries and the study which is published from Kenya. And when we compared this data with the studies conducted in India, it was lower than that conducted in Chennai, Mumbai in 2012. And last year there was publication from Southern India by Anita et al. It was also lower than what was shown in this particular study. Data on association of virological failure in patients with lower adherence is consistent with reports elsewhere nationally and internationally, and highlights the need for strengthening of adherence counseling as shown in number of studies published so far. Our finding that those living without partner had higher risk of virological failure highlights importance of familial support, and additional counseling of individuals and support groups will be useful in such cases as we have already discussed yesterday. In absence of virological monitoring, individuals with immunological failure, that is immunovirological discordance, would be misclassified as a treatment failure. But the most important finding that only 30.7% patients showed immunological failure highlight the need for plasma viral load testing for early identification of treatment failure and avoid development of further drug resistance mutations in our population. This particular study provides evidence to support routine viral load testing for the program and also draws attention to important gaps between immunological and virological monitoring strategies. In this study, viral failure was diagnosed. There were limitations for this study. In this study, virological failure was diagnosed by single plasma viral load estimates where 2 tests are preferred. ART clinics involved in this study were located in a large city catering to urban population, and therefore findings may not be nationally representative. Those who were lost to follow-up or deaths were not included in this study, which may have underestimated our numbers. So in conclusion, I would like to say that timely ART initiation and optimal adherence are extremely important. Psychosocial support of partner is useful for improvement in virological outcome of people living with AIDS. And the most important bullet is implementation of viral load monitoring into a program is a long-standing priority. And just now Dr. Rewari has mentioned that it will soon be implemented in all the ART centers, which will help to diagnose virological failure at early stage and monitoring them by viral loads. This study was published recently, a couple of weeks back in Journal of Medicine. And we would like to thank WHO for the funding support, MSACS and NACO for their support to the study, ART Center staff of VJART Center, AFMC, YCM, and National AIDS Research Institute, and all the NARI staff who helped us in data collection and data analysis. Thank you for your attention.
Thank you, Dr. Gate. We'll take questions at the end of the session. The next speaker for the session is Dr. N. Kumar.
Enthusiasm for sustaining our Asicon conference. So thank you so much. And also, good morning to many of your luminaries who are all here, and including Dr. Ribari. I might be indirectly attacking you, so please don't get offended. So now the topic given to me is, so what India will lose if we don't treat everyone? Already we are running 3 years late, right? So a couple of weeks back, it's been recommended to initiate treatment at 500. From WHO guidelines, me being part of the guidelines, we recommended in the year 2013, many programs, adapted that, but we are already running 3 years. I'm going to tell you, and I don't know how long it will take again. Dr. Ribari many times said soon, soon, soon. We need to define the definition of soon for India. So we need to, I'm going to here say that what the major consequence, India will be, paying over a period of time if you're not going to treat everybody. You saw this again and again. I'm sure you would have seen yesterday and today again and again. So this is a new WHO recommendations, and 2015 launched, and 2016 became a recommendation of UN declaration. So today, we have to treat everybody. If you don't treat, it's a malpractice. So we always have to go either follow WHO guideline or you should go up. If you say that we are not going to follow at that standard, I think we may have to pay a lot of consequences. Why I'm talking about this is, so I participated in this process from the scientific perspective. The first thing is, I like to tell you that, so what's the study, which make these changes to happen, and as a result, what are the public health consequences if you're not going to adapt, all those will happen. So 5 years back, our group published this HP10-052 study, again in India, Chennai, VRG Care, and Nari Pune heavily participated in this trial, where we showed 96% reduction in HIV transmission if you put people on treatment. You're able to see that in their serodiscordant couples. So we continued this study, and what the changes we found is we wanted to prove the durability of this prevention effect by these antiretroviral drugs to those serodiscordant couples. So after 2011, Data Safety Monitoring Board asked us to put everyone on antiretroviral treatment. You all know that in HP10-052 we had 2 arms. One arm received immediate therapy, another one delayed up to 350 or whatever the country guidelines. Some countries adapted 250. So after this 2011, the interim results, everyone have been offered treatment. So what we found now the paper is now again we published in the England Journal of Medicine a month back. What we have shown is consistently more than 90% effect. This is a great effect. We have a durability in prevention, sexual prevention of HIV following this antiretroviral treatment. But again, others in this session stressed about the importance of adherence and the continuity of the treatment. That's again is very important when you talk about prevention in the context of ART. So if you ask me a question, who are those transmitted? We found 8 linked transmission in HP10-052. Out of those, 4 infections likely occurred either before or soon after the index partner started on ART. That means they're not on sufficient amount of time, so on ART to suppress the virus, and 4 infections occurred after the index partner failed ART. This very clearly shows that if there is some virus, they can transmit HIV. So this is very clear. So that's the major consequences which I'm trying to say. So this study, HP10052, very clearly a landmark study, after 10 years of conducting this trial, very clearly we showed ERT is highly effective in preventing sexual transmission of HIV. So what, the consequence for India? So this is our latest figures, which you all have seen. So now given by UNAIDS and NACO, we have got 2.1 million people being infected with HIV, estimated. And out of those, which we all believe, more than 90% to sexual transmission. So when we have a study data showing that ERT prevents sexual transmission of HIV, if we don't implement, in a country where we got 90% transmission through sexual route, how we are going to contain this HIV epidemic? Just sit in a corner of a room and calculate yourself how much transmission will be happening every day if you're not going to put people on treatment. Again, our data shows out of the 2.1 million estimated, in India, only around 43% still receiving treatment. So again, the numbers will swell up if you're not going to put the proper guidelines of, treat all. I think this has been, developed based on the threshold of 500. This very clearly shows that if you're not treating, exponentially, the HIV transmission continuously swell. We may talk about other ways of prevention. So this is, again, a data where it shows where we have mapped all the various interventions in one slide. If you have a vaccine, again, we don't have a vaccine, it is 31% efficacy. If you treat STIs, which we all did for years and years, which still continuously do, but only 42% effect in reducing transmission, and PrEP in MSM almost around 50% now going up, and PrEP in heterosexual 63%, PrEP in serodiscordant couples 73%. And if you put on ART, the transmission is 96%. So in a country like India, sexual transmission is a majority mode of transmission. If you're not putting on ART, and if you have been keep looking at other mode of intervention, you're not going to prevent transmission in our country. It may swell beyond 2 million soon. So you may ask that, so this is for a public health benefit. Now, why should you harm someone putting on treatment at a higher CD4 where they don't need a treatment? You may ask this question, so what's the individual benefit? That was very clearly shown by START study. I'm not going into the detail. I think last year I presented the START study results to the audience here at the Asicon. So START study, again, it was been carried out in 120 centers. In India, Chennai, we participated. We are the second highest enrolling site across the globe. And where we have two arms, one received immediate treatment when the CD4 is more than 500, and another one arm, we waited up to 350, or if they develop any one of those age-defining illness. I'm not going to the details of the START study, but just to show that if you're not going to put treatment to everybody, what will be the consequence? So in this study, very clearly we have shown, and we are able to prevent both serious AIDS events and as well as non-AIDS complications. So if you see this, if it's an immediate effect, there are 14 individuals, and in the deferred arm, 50. And if you look into these non-AIDS complication, 29 versus 47. This very clearly shows that by putting on treatment, there is enormous individual benefit. Again, if you ask me what are those individual enormous benefit, TB, a country like India, sitting in Mumbai, where TB epidemic, if you don't put on ART, you're not going to prevent TB. We talk about IPT, still not fully been implemented. I think it's a great opportunity, test everyone, put them on treatment, you're able to prevent TB. And lymphoma, in the developed world, where they have seen reduction in lymphoma if you start treatment early. And in sub-Saharan Africa, where Kaposi sarcoma is very high, where they're able to prevent by putting early on treatment, and also all the other opportunistic infections. What about non-AIDS complications? So in India, we are sitting as an epidemic of NCDs in the general population, where again, HIV will fuel that because of a lot of inflammation due to HIV. So now again, by putting on treatment, we are able to prevent non-AIDS cancers, and cardiovascular disease, and various other renal and liver. We are not able to see this on a long run because now everyone, in START studies on continuing on treatment. We are not delaying anyone because after the interim results, everyone on treatment. So even still, we are able to find that we are able to prevent various non-communicable diseases. So there is enormous individual benefit. It's not just a public health benefit. So in India, if you're not testing everyone and put them on the treatment immediately, we will lose a great opportunity of denying this public health benefit as well as individual benefit. There's no doubt in that. Science says, I'm not saying. They're following all these guidelines moving to treat all. So next step is now in the 2016 guidelines, we also have some of the new drugs like dolutegravir and also reducing the dosage of efavirenz 400. So you may ask a question, someone with 1200 CD4, perfectly fine. When I put them on various efavirenz containing therapy, they have dizziness and they have a lot of other complications, how will I do that? So for these reasons, now we have other alternate drugs. Again, what is a good thing about alternate drug is, again, so this is a single trial, which is a study which compared between efavirenz and dolutegravir, where you can see the x-axis showing the duration of weeks on treatment, and y-axis is a proportion of patients who have got suppressed viral load. The green curve is patients who are on efavirenz containing therapy, and the lighter white color curve is patients who are on dolutegravir-containing therapy. So this data very clearly shows that patients who are on dolutegravir, they got a higher virological suppression as compared to efavirenz-containing therapy. And very importantly, particularly for India, if you're not going to adapt this newer guidance, and where if you see this, you are able to see this virological suppression very early on if you are on dolutegravir. I think this is very important, especially in a country like India, where we got a huge sexual transmission. If you're able to put people early on treatment with dolutegravir-containing therapy, we'll be able to suppress this virus enormously, where we'll also have an enormous prevention benefit by suppressing the virus very early on as compared to efavirenz. This is something where I think India should move on as soon as possible. Any delay will have a huge penalty we'll be paying to our public and to the program. And also, in this single trial, also been shown that there is very little psychiatric events as compared to efavirenz, where we all see and in our clinic population. So today, if you put everyone on treatment, where you have enormous public health benefit, enormous individual benefit, and also adapting the newer drugs, will have a much super effect on this. Then program managers might ask you a question. Hey, it might cost so much money. Dr. Rivari, in one other slide, he said several crores rupees is going to cost India. So to answer this, we have done some modeling exercise. So this is a modeling exercise our group did in collaboration with the Harvard group on the HPT and O52 data. So what we did in this is we used HPT and O52 data, and also we saw the effectiveness, and also we had seen the various effects of ART on putting on treatment at higher CD4, as well as on the prevention effect. What we found is both in India and South Africa, putting treatment at a higher CD4 will be cost effective as well as cost saving. So this is something where we cannot debate. This is something we had to sell to our program managers to get this for our population. Next thing I'm going into there is science. So today we are all talking about cure. A couple of days back you read about the news clipping from UK about a patient nearly been eradicated. Again, how this is possible? You all know that someone who is HIV positive today is not the question of viremia and in the blood, but also every day they are also been setting up reservoirs. So this is a curve which shows that someone who is being viremic, when you put them on antiretroviral treatment, the virus goes to an undetectable level. You're not going to eradicate from the blood, from any of the organs. You have been going to suppress in the blood, but still it's sequestrated into various organs. We call it as reservoirs, which is in the CSF, which is in the genital tissue, it's in the gut, and as a result, they can still multiplying there. So if you're not going to start treatment early, the reservoirs will start setting not here, from here. So that means you are allowing your patients to start setting up more and more reservoirs. So today, if you're not going to eradicate, what will happen is if you've got more reservoirs, there could be considerable residual viremia, which can lead to more chronic inflammation, which can also lead to a lot of other non-communicable diseases like cardiovascular, kidney disease, faster evolution of hepatitis and cancers. So today the way we, researchers are finding a cure is to identify all those reservoirs. If you are making a patient to set up more reservoirs, again, it will be very difficult when we have a real cure. So today, the primary question is, what is the full extent of latent pool? How do we eliminate it? So for that, the first quick answer should be start treatment early. If you don't do that, you'll not be able to eradicate one day, even if you have an eradication tool with you. So to answer this, at our center at YRG Care, in collaboration with the University of Miami and with the grant support from NIH and as well as ICMR, we started a very large project a couple of years back to understand the immune activation and reservoir size in Indian HIV-infected people who have started at a CD4 of 200, 350, 500, and more than 500. So again, this is a work in progress. I'll not be able to show the full data, but we just submitted to CROI. But I'd like to tell you that the initial results very clearly shows that if you're not going to start treatment early, especially in the Indian population, you'll have a lot of immune activation, which will cause more harm, and as well as the reservoir size will go up. And as a result, you'll have a lot of consequence, and also you'll deny a great opportunity of eradicating your HIV-infected patients. So if you don't start treatment, they'll have a huge reservoirs. You'll hear more on this at CROI if you're able to attend and if you have an opportunity to get accepted, and we'll be disseminating this soon. Next thing is, so how we are going to find these people? So till now, even in our ART centers, as well as private clinic, people who are coming are very sick. Either CD4 is 200, now it has gone to 350 or 400 median CD4. So how we are going to find everybody, 1,000 CD4 or 1,200 CD4 or soon after they are acquired HIV? So we did, again, a modeling exercise in collaboration with the NACO and the CPAC group in Harvard, where we used incidence from our NACO data and as well as the cost for HIV testing and counseling and linking to the care. So what we found in this model is, if you want to identify everyone who have been HIV positive in India, how we are going to do this? You have to do a voluntary HIV screening among our national population every 5 years, which will offer substantial clinical benefit and will be cost effective. And also annual screening will be cost effective among high-risk population, especially among injecting drug users, MSM and female sex workers, and in migrant population, and as well as in certain high prevalent districts in Northeast India, and as well as in Andhra Pradesh. So this is something what we have been now done a model, and we have been negotiating with NACO, how we can effectively implement to find all these people, link them to the treatment so that we'll have both public health benefit, as well as individual benefit, and as well as a cost benefit, as well as scientific benefit. By concluding, why again we need to treat all? This definitely will prevent sexual transmission in India, which is a major mode of HIV transmission. No doubt it will prevent morbidity and mortality, especially tuberculosis and non-communicable diseases, and will be cost effective, any amount of models. This afternoon, I'll be again talking to you on impact of WHO 2016 guideline on more cost-effective analysis. And very importantly, we'll also prevent loss to follow. Today, a lot of data coming up, especially from sub-Saharan Africa. If you test some, if you don't link them to care and put them on treatment, you will lose some, which will be very expensive, or they might be transmitting infection to more people, or they will come to be in a very sick and morbid condition with 5 or 10 CD4 or with pneumocystis pneumonia. It might be more expensive to treat. So again, by testing everyone and putting them on treatment very early will prevent loss to follow, will be cost effective. I think that's my last slide. Thank you very much, and happy to take any questions.
Thank you, Dr. Kumar.
Thank the organizers for giving me this opportunity. And I always enjoy speaking after Dr. Rewari and Dr. Kumar, because Kumar and Rewari present the same data, but Kumar had so many adjectives: tremendous, terrific, excellent, and remarkable, etc. So let's have a reality check. It's for getting to zero. We were saying that there has to be 90% reduction in new HIV infections, 90% reduction in stigma and discrimination, 90% reduction in HIV-related deaths. And for getting to zero, we are now all talk of the town is getting to 90, 90% diagnosed, 90% on treatment, and 90% virologically suppressed. HIV care continuum is largely spoken of in terms of patients who are HIV infected. And it is like test HIV positive, engage them in care, pre-ART, then retain in counsel and put them on ART and keep them virologically suppressed. However, there has to be another continuum which is of prevention and care, because we have to keep all the negatives also negative. And that will be achieved to a certain extent by treating all, but of course there will have to be other efforts for prevention also. And there will have to be other modalities used, and we'll have to integrate both HIV infected and HIV uninfected people into biomedical, behavioral, and structural interventions. A broader perspective of HIV care continuum, therefore, is like HIV testing. Those who are negative, keep them negative, put them back into the HIV care continuum. Then largely we are always talking of people on ART, and they should be adherent to ART and continued in care, but there have to be a lot of linkages also, and which need to be, actually that care continuum also has to be maintained when we have to have something like 2.1 million people on ART. If we test all and treat all, there would be 2.1 million people, and there will have to be a PMTCT care of co-infections and comorbidities, because the comorbidities, even if they are less if we start early, still there are going to be a lot of comorbidities, as well as TB care. What we are expecting is that when we move, whenever, maybe 3 years down the line or 4 years down the line, or maybe 2 years down the line, I don't know. Kumar is always asking Dr. Rewari to cut short the lag period, and so we'll expect someday that not eligible for ART will go. So anybody who is diagnosed would go on treatment, and we'll have that. But what happens in reality? Now this is the data from United States. 87% diagnosed, 39% received care, 36% prescribed ART, and only 30% of that on virological suppression. UNAIDS targets 90-90-90. There are 36.9 million people in the world, probably. So at 90%, there will have to be 33.2 million on ART diagnosed, 29.5 million on ART at least, and 26.9 million virologically suppressed. Target one is, yes, we'll have to have 90% diagnosed on ART and suppressed. But what happens actually? What is happening is that there is a 53% drop in the breakpoint 1, there is another 41% drop in breakpoint 2, and another 32% at breakpoint 3. So there is a distance between the cup and the lip. There are 90% diagnosed. We know that a significant proportion of adults in most parts of the globe with advanced HIV disease, we know that even what we are seeing is that majority of the diagnosis is even increased, is around 200 CD4 count, 230 CD4 count. So yes, Kumar says that we will have a national, 5-year national screening of all people, maybe all 110 crore people maybe, every 5 years, and then diagnose all and put them on treatment. But there is a lot of investment needed to be done in that. 90% on ART, less than half of PLHIV from sub-Saharan Africa not yet eligible for ART are retained in pre-ART care, and only 2/3 are initiated on ART. Virologically suppression, 71% PLHIV from low and middle income countries are initiated on ART show virological suppression. And just now Dr. Ghate also showed that people put on ART at the end of 1 year, so many people were failing on the regimen. So maintaining the suppression is also not a very easy thing to do. What is the Indian scenario? And there are some data. Majority present to care with advanced disease, HIV diagnosis to care, there is a significant delay and there are losses on the way. These are the systematic reviews and the data from that. 80% of those diagnosed with HIV reached ART centers, Shastri et al. Among those reached, 25% registered after 3 months of diagnosis, including 12% reaching more than after a year, Sarna et al. Most of those who did not enter into care within a year remained lost to follow-up or died. So it's not just diagnosing, but putting them into care is also very difficult. Attrition during pre-ART and ART era, public sector, Ghate Madam's paper, 2% deaths and 11% lost to follow-up during pre-ART care. 13% deaths and 16% lost to follow-up at the end of 2 years, Bachani's paper. Private sector, our paper, there is data, 65% of non-eligible retained in pre-ART care, 67% eligible initiated ART within 3 months, and 30% initiated at ART died or lost to follow-up. This is our paper. Timely uptake of subsequent CD4 was only 58% among eligible patients and 46% among not eligible. So almost 50% of the people, even if they are eligible or not eligible, as per our criteria, hardly do their CD4 count in 3 months. This is our data. Late diagnosis, delayed linkage, as I just now said, lower uptake of follow-up, CD4 count among those with delayed linkage and higher CD4 count. So those who get linked late also remain defaulting or getting linked to the care very rarely. As regards TB, what happens? We just published a paper in International Journal of Tuberculosis, 1st of October. There is a significant anti-tubercular default, 4 to 30% and mortality rates observed among HIV TB co-infected patients. There are other data also. Higher default in private sector and among those not on ART. So there, when we actually look at everybody is diagnosed and put on treatment, there is going to be a substantial proportion of them going to the private sector also. It's not that 100% of the people would be in the government sector. There is a higher default in private sector and among those not on ART, so these linkages will have to be looked at. The issue with linkages are 2 ways. Out of 923 patients diagnosed with TB, 102 were lost to follow-up before initiating anti-tuberculosis treatment. Forget about antiretroviral treatment. Even the anti-tubercular treatment could not be started in them. 18 to 56% of ARV-naive TB patients cannot be started on ART. What happens to them is not known. Let's look at PPTCT. Retention in PPTCT cascade of care. Our paper, uptake of HIV testing was 86%, and just now Dr. Rewari said that we have 28 or 29 million pregnancies annually, and hardly about 45%, maybe around 40% are being tested, and so we will not be able to reach all unless we screen all of them. Uptake of ART was 46%. Linkages from PPTCT to HIV care. Since their exit from PPTCT, we did a retrospective study and then followed the women who had exited PPTCT program, but that was at the time when the treatment was not continued lifelong. The treatment was stopped at the after pregnancy and delivery when CD4 count was good. But what we found was only 62% were consistently in treatment. So there are several risk factors and barriers to linkages and retention in HIV care, and we have to remember that. It's not just a test and treat, go everywhere and test someone and put on treatment. It's not going to be that easy. There are several demographic factors such as male sex, younger age, low education, unskilled laborers, migration. There are psychosocial issues like stigma and discrimination, fear of disclosure, partner family support, fear of drug toxicities. There are issues which are medical. For example, perceived good health. You are having good health, you are not sick, your CD4 count is good, would you like to be on treatment for a very long time? There could be problems when there are low CD4 counts, when you are more and more sick and you may not be able to take so many medicines. And ART naive status. So you may have experienced ART before, you have left and you are coming on treatment again, or you are ARV naive is also important. There are economic reasons. Food shortages, unable to take time off week, cost of transport. These are all the factors which have been collected from several systematic reviews. And health system related issues like long distances, long clinic waiting times, shortage of health workers, need of visiting multiple times, frequent visits due to drug shortages, and all this Dr. Rewari was also addressing that these are going to be taken care of. So there are challenges galore, but there are possible solutions to these also. For example, streamlining services to minimize patient visits, and we are already talking of quarterly or 6 monthly visits. At our center, we are those who are virologically suppressed and have good CD4 counts are coming now only twice a year, and once a year virological monitoring, strengthening education support during pre-ART phase. Same-day CD4 testing is excellent because majority of our patients come in the morning, take their CD4 counts and go away in the evening. Of course, virological monitoring cannot be done on the same day. Rapid ART initiation, there is quite a bit of loss to follow up. So when we have test and treat, maybe just like we do in PPT-CT, that a woman who is diagnosed with HIV, we don't wait for her CD4 counts to come, we start her on treatment. So similar thing, starting ART at the same visit, there has to be a lot of peer support to all these people. Convenient clinic timings, not fixed schedules, etc. And we have to look at some other technologies like mobile health or something which would keep giving the patients reminders for treatment and educating the people. We did a randomized control study of sending mobile messages to people for adherence and treatment. Facilitating links to RNTCP monitoring center mechanisms through intermediary organizations and involvement of private and public partnerships. So this is the photograph from somewhere. Simplify the way I get ARVs. I'm tired of walking, and there is a lot of time wasted by people in getting to ART centers, even if diagnosed. And the person is walking for his ART, and we have to walk on our path of taking treatment to all. Thank you.
Thank you, Dr. Kulkarni.
Dr. Kumaraswamy started saying with attack. No, there is no attack. Where is the attack? I started my talk with saying, yes, we agree to treat all. We cannot deny science, particularly when the START trial, HPO215 trial, both trials had India sites. All these trials were approved by NACO Ethical Committee, NACO Technical Resource Group, and that went ahead and Health Ministry Screening Committee. So we cannot deny the results from multi-country trials which happened in India also. So there is no denial. So where is the gap? I think some of the gaps have already been pointed by Dr. Vinay Kulkarni, who is not a program person. So we cannot say he's defending the program, and neither I am defending the program. It's never WHO guideline versus NACO guideline. It's never public versus private guidelines. Scientific evidence cannot be denied. WHO guidelines, yes, they say treat all. Very clearly, I showed you the slide from WHO itself. There has to be implemented in context of countries based on epidemics, programmatic consideration, and resources. I said in my talk in the beginning also 80-90 crores for treat all is not a big money for government of India. It is peanuts. So issue is not that it is resource, no programmatic considerations. The Secretary of National AIDS Control Organization himself attended the TRG, agreed to treat all. I presented to you the TRG recommendations. So where is the gap? Yes, where is the gap? Because when we say treat all, I think Vinay Kulkarni has already pointed out the 90-90-90 cascade, and the global coverage for ART, when 29 million need to be on ART, there are only 17 million on ART. India is 43%, yes, globally it is 52%, it is behind, but we just moved to 500, so it will be parallel. We have 12.5 lakh people registered with NACO ART centers, those who have been detected and registered with us. Out of them, 9.8 lakhs are already on treatment, moving to 500, 1 lakh will be initiated and treat all will be 1.15 lakhs. So that makes it 12.5. We have 21 lakh estimated. So we need to reach out to them. I presented this in my slide also, that we need to reach out, and Vinay Kulkarni has very rightly pointed out, we need to go to the community, do the community-based testing, maybe move on to think about self-testing, making HIV test nearer to people, residents, to all PHCs, all health facilities, and partner with private sector.
So, Dr.
Coming
Ribari,
to newer drugs,
Dr. Ribari.
Just let me complete. I've just noted down the points.
No, we have a lot of questions on you.
Yeah?
No, because you're talking a lot, but we have a lot of questions.
Yeah. I'm just giving answer to some of the questions which have already been raised. And another question was patients presenting late. I think Vinay Kulkarni has already answered. I just went to the WHO slide which says the median CD4 count at presentation has now moved from 142 to 300. I'll give you India data. Our median CD4 count at presentation was 119 in 2007, and it is now 260 in male and 300 among females. Globally, everywhere people are being detected late, though earlier than what was earlier. So we are not very far behind in India in terms of presentation. Yes, there are late presentations. There are issues with service provision. Yes, we did talk about new drugs, efavirenz 400, dolutegravir and TAF, and government is not behind. Already there was a meeting with the secretary, NACO, with the Gilead people who are developing the new combination with TAF. Dolutegravir has been given a approval by Drug Controller General of India. Efavirenz 400 is still not manufactured, and these are in pipeline. Even the pipeline given by WHO guidelines is around 1 to 1.5 years that these drugs will become available. So overall, when we agree to treat all, basically it is reaching out to all and retaining them. So I don't think there is any difference or any difference of opinion between WHO, NACO, or Kumaraswamy and me and Vinay and others. We are open to questions.
For our national program, not putting on treatment? No, because you agree with science, and you agree with everything, what I said as well as in the WHO guideline, is only the cost?
Kumaraswamy, I just said in the beginning of my talk, I think you were there in the audience, and just now I said, it's not the cost. I never said. It is 80 to 90 crores, it's not the cost. But the program and the government has guidelines for procurement. Procurement is an international competitive bidding, and that procurement takes time. That is why there is a phased implementation of the guidelines. There is always a delay between recommendation and implementation. That is just because of the programmatic considerations and procurement guidelines.
Now, as you know that, India supplies, is based on the Clinton Foundation's, data. India supplies, I think, 82% of ARVs to the whole world in lower and middle income countries, right, to Africa, everywhere. I was there last 4 months, I was in 5 African countries assisting their guidelines, putting everyone on treatment, even adapting dolutegravir. They're all depending upon, Indian manufacturers, which are all behind your door. So now, even we have all the manufacturers here. Is procurement is a big issue for you?
No, it's not a big issue. We have never said that drugs are not available. Yes, India is supplying drugs. It is a matter of proud for India that we are supplying 89% of global ARV requirements in all developing countries and many of the PEPFAR projects in other countries also. There is a process. You have to put up a tender. There is a requirement of 45 days for this to be put up, and then there is a requirement of its bid opening. I think you have to understand the program also. There is a technical opening, there is a financial opening, there is approval, and then there is a 60 days lead time for suppliers to supply. So those are the timelines which are required. We cannot do away with those timelines, but the first time NACO has now said, we do it every year. Why every year? So this time that procurement has been put up is for 2 years, so that these delays are avoided.
So 45 days versus 3 years is a lot, right? Because 2013 guideline we are implementing now, so.
If you go to the global site, the 500 guidelines implementation took 1.5 years to 2 years in many countries. No country moves immediately on that day, next day to the guideline.
Yes, please. Yes, trying to think about the future. We're all in agreement that probably dolutegravir is a better drug than efavirenz. I think, Kumar, you showed Dr. Walmsley's analysis. So if we have this long lag time, and if in fact it is Indian manufacturers who are likely going to be producing the dolutegravir, TAF, 3TC, once daily, what can we begin to do now to ensure that that's available for a price which, at least they tell us, will be less than atripla?
All the newer drugs actually, as per regulations, require the trials in the country. But there is a mechanism whereby some experts, there is a meeting, there is a technical expert group at drug controller, whereby a waiver for clinical trial is given. You know, waiver for clinical trial is given in exceptional circumstances when it is a epidemic, it is a public health requirement, like it was given for Hep C drugs. There was no other drug. But like dolutegravir, it was a drug which was not very different as such from dolutegravir, but there was strong evidence of in terms of its robust response and less chances of failure. So there was an expert group constituted in which Kumaraswamy also came, and I was also a part. Though I didn't attend, I gave my comments on writing, and this drug has been given a clinical trial waiver. So we expect that these drugs like TAF, I already told you, there was a meeting with the Secretary of National AIDS Control Organization with Gilead people, and once they're ready, they themselves gave a timeline of 1 year that bringing TAF with combination may take 1 year. So as these drugs are become available, the clinical trial waivers are granted in India, because it's not only for India, it's for many other countries also.
Good morning, sir. Sir, our screening program are showing very good result, like PMTCT, STI and everything. And late presentation is always an issue. So are we planning to extend our screening program from PMTCT, STI and TB to some other extent, so we can detect people early and we can pull them into our HIV care?
Can you test everybody? Can you test 110 crores? And what does this tell you? This only tells you your HIV status as of today. It is not a cost-effective strategy to test everybody, everyone in the country. It's not feasible and is not practical. Yes, we have to focus on where the infection is coming from. There is a concept of provider-initiated testing and counseling. Basically, a high index of suspicion among physicians have to be there, because we have seen delayed presentation and missed opportunities, at least 1 or 2 missed opportunities where the person had TB or herpes or some other infection and it has been basically missed. So definitely we need to have a focused training which may be provider initiated. All STI patients already are offered testing, all TB patients, all pregnant breastfeeding women are already offered testing. Key populations also we offer, but we cannot make it mandatory for anyone.
Just to answer this, this can be done only by doing certain modeling exercise. I think I showed one slide on that. So right now, in collaboration with the NACO, with Rivari, WHO, and our group, and as well as the Harvard group, is doing a lot of such modeling. One is on testing, and on viral load we have already done and shown to them how it will be cost effective, and even dolutegravir, which will be presenting at CROI if it has been accepted. These are, I think, modeling exercise will help to drive this type of questions. Otherwise, it's very hard to say. Coming to the retesting, I think in that model we said every 5 years of national population and in key population every year, and high prevalent districts in India in every year will be cost effective. This is something our model shows.
Yeah, Dr. Rivari, is there something like, we are seeing so many young girls now testing for their pregnancies almost at home. Is there something like a self-testing program which would be promoted, which could be linked to ICTCs then when someone finds it, because it may not be a confirmatory diagnosis, but making it available in the country?
Yes, you are right. This offers an opportunity because there is a lot of problem in going to a center, getting test result and associated issue of confidentiality. WHO has approved self-testing, and the self-testing guidelines are just now ready, and we got an email yesterday only that they are now being published. Definitely, as the guidelines come in, we'll move on to those guidelines.
First of all, thank you everyone for the beautiful presentation and bringing so much information. All the presentations had a mention about the private sector integration into giving the services to the community. Could any one of you, Dr. Kulkarni, Dr. Oman, or Dr. Kumaraswamy, talk more about how to engage the private sector lucratively such that it's also business oriented for them, because it's always about business in the private sector, and in a city like Mumbai where the structure is very unregulated and also very complicated and there are so many GPs in the urban slum areas. Can you give us some 3-4 nodal points on how to get it started, how to go to the community, to the private sector?
there are a couple of things. Private sector in India, unfortunately, has been linked with a lot of profit making. And services, you know, there would be a lot of non-adherence if there is too much of cost involved in that. So I have always said, even in the discussions, that in India, there are three types of things. There is something called as a private sector. There is something like a not-for-profit private sector, which could be NGOs. And then there is a public sector. And there is a lot of scope of collaboration between the program and the not-for-profit private sector. And I think majority of our NGOs have been, my colleague in the morning said, we are providing second-line treatment, third-line treatment at subsidized cost. So there is something like that which could be possible not-for-profit.
We appreciate the private sector started ART in India much before the public sector. But over the time, because of long-term, lifelong treatment and the cost, public sector has got almost 9.8 lakh patients, while our estimate shows around 50,000 patients in the private sector. But nevertheless, there are some of the top practitioners in the private sector who follow a very good regulated regimen. There were issues with the prescription of second line as first line regimen in 2008-9, if you remember, and we had a lot of issues with the private practitioners starting on a PI-based regimen when the recommendation of WHO was an anti-based regimen, and we had to go to Supreme Court to regulate that. But anyway, now the situation is different. As Dr. Padare was saying, the regimen followed across public-private sector are the same. NACO has got 18 private public center ART centers, whereby more than 10,000 patients, 12,000 patients get treatment. With NGO sector, with private medical colleges, even private practitioner. We are now coming up with a new model whereby even single, not clinic-based private practitioners who don't have a hospital or others will also be partnering with NACO. And first week of November, NACO is holding a consultation on involvement of private sector into antiretroviral treatment program as a one program. We always say 9.8 lakh patient. Why not these 50,000 should also be NACO patient? And why not 9.8 should be it should be one figure that we are coming up. So November we are having a consultation on supported by WHO on involving private sector.
This will be the last question.
I would ask Dr. Rewari one or maybe two questions. One is this fixed dose combination of efavirenz, TAF, and emtricitabine. The dose recommendation is 400 efavirenz. Now, all the standard recommendation of efavirenz for an adult over 40 kilos of body weight is 600 milligrams. Now, first point is this going to cause any resistance problems in the long run? Second is TAF dose. What is the dose which you're going to put in that tablet? Because TAF dose is a controversial subject. Can you please elaborate on this?
Efavirenz 400 milligram is being recommended for all body weights. Even those who have got more than 60, it will be 400 milligram recommendation. And TAF is 30 milligram as compared to 300 milligram TDF. But again, both of these are still in development. First thing, individual drugs. Anyway, efavirenz 400 will not be a problem. We have 200 and 600, so making 400 is not a problem. TAF is still in development and approval even by US FDA. And then there is a need to have fixed dose combination. There need to be TAF with emtricitabine or lamivudine with efavirenz 400 milligram. So all these, we expect at WHO also that they should become available of Q3 of 2017, Q2 and Q3 of 2017. And once these are available, naturally then there will be issue of production capacity of the pharmaceuticals. If you are going to shift all 17 million from TDF, efavirenz 600 to TAF, efavirenz 400, or going to initiate new patient on the new drugs, that is always a issue. Even when we shifted to tenofovir single pill in India, issue was the capacity. Only 3 manufacturers are making it. But now everyone, all 8 companies manufacture. So it is the future. It is in pipeline, definitely.
Does it mean that you're going to discontinue efavirenz 600?
Can you repeat?
Are you going to discontinue efavirenz 600?
You know, when we moved to tenofovir, efavirenz, lamivudine combination, there were patients who were doing well on zidovudine, lamivudine, nevirapine. We never discontinued them. So this call will have to be taken on individual patient also, whether they have side effects or not. All change of drugs in stable patients have 2 considerations. Either they are failing, not responding adequately, or they have toxicity. If they have no toxicity to efavirenz, there are no side effects, why should we change?
I think 400.
And also in TB patients, the rifampicin, you have to give 600. If you're giving dolutegravir,
Those at one point,
yeah, then you have to
for
double the
TB
dose.
patient, even 800 was recommended. So that was for a short time. But then when you're manufacturing these tablets for NACO, for example, or AIT centers, will you make 400 tablets
This
as
will
well
be
as
the
600 tablets?
last question that we take, please.
Sir,
We are running out of time. So
let
please.
it be available. We don't have 400 milligram as of now, or neither the TAF. So this question is, yes, it is a question, but once these things are available, and our concern is fixed dose combination. If I have TAF separately, lamivudine separately, and efavirenz separately 400, I would not prefer to use that unless I have a fixed dose combination. There is a big advantage with a fixed dose combination, single pill, in terms of compliance, adherence, monitoring, supply chain, toxicity. So if you have 3 drugs to be taken and 1 tablet to be taken, we all know that. Why we went to FDC?
One short question. Is there any study on 400 efavirenz and 600 efavirenz?
Sir, this will be the last question. Please, we are running out of time. We ask you to please wrap up.
Can I finish this
Thank
question?
Just to say, 8 to 12% of our patients have initial side effects with efavirenz. When we changed to efavirenz first line, there were a lot of problems from PLHIV. But most of these patients stabilize after 3 weeks to 4 weeks. In the national program, I can say only 1% of patients had to change their efavirenz 600 because of its CNS side effects.
Sir, in the interest of time, I think we'll have to conclude this session. For all those delegates who would still like to put in a question, you could go to our app and you could tap on agenda, then tap on the speaker, and there's a section on comments, which we will pass it on to our regular speakers. We'll make it a point to get back to you too.
Thank you, speakers,
Thank you so
for
much.
the wonderful talk. We would like to felicitate the speakers for their talk. Dr. Pazare, I request Dr. George.
On to ART, there's a likelihood of there being more treatment failures. So without further delay, we'll go ahead with the first speaker, Dr. Milind Brushandi, who will speak on prevention and management of complications of second-line ART.
A very good morning to you all. First of all, I thank Dr. Gilada and Dr. Ganga Khedkar for giving me this opportunity. At the same time, I apologize because there might be some messed up of the slides because my laptop got crashed yesterday and I have just made the slides today morning. So there might be some confusion. So please bear with me. So we all know that about the second line recommendations, as the previous speakers have already told us, it depends upon the first line. So the first line preferred ARV regimen as on today is tenofovir, 3TC and efavirenz. But at the same time, the patients who are coming to us with first line failure were taking the ART, which was previously preferred as either AZT or in some cases D40. So whatever the cases we are getting, most of them have received AZT, D40 or in some cases DDI also as a first line. So the second line will definitely depend upon what the first line the patient is taking. So detailed history of the drugs and the ART regimen will be the mainstay for developing the second line regimen. The main important point as far as second line regimen is concerned is if the second line, if you are giving, then if possible, you have to take the detailed history, and if the patient is having initial history of D40 and AZT as the preferred first line, then the second line will be TDF, 3TC or FTC, and atazanavir or lopinavir. If the first line is TDF, then AZT, 3TC plus atazanavir or lopinavir. Here I would like to just give one comment. If the patient is coming from either the government setup or a private setup, the detailed history of Stavudine as well as AZT is a must. Why I'm saying this? Because those patients who were referred to our center, and when we went into the details, even from the government setup, public and private setup, there were switches of D4T and to TDF or AZ2 to TDF without doing a viral load. Even the CD4 count that time, they have not gone into the details, and in the public setup, the D4T as well as AZT was shifted to TDF. And these patients then failed even on the TDF, and they were coming to us. So this is a point where these patients might be failing as well as on TDF as well as AZT. So that particular group of the patients you have to look at. In HIV pregnant women, the recommendations are similar. If the patient is having TB, then definitely we have to consider rifabutin in a second line instead of rifampicin. And if rifabutin is not available, then we have to adjust the dose of ritonavir. As far as HIV and HBV co-infection is concerned, when the patient is on first line and taking TDF and having hepatitis B, and these patients fail, changing to AZT is going to take the cover of TDF for hepatitis B. So this point has to be considered while going for the second line. I just look at my own data. From 2005 to 2015, there were 341 patients which were put on second line treatment at my center. These were from either government setup or from the other private practitioners as well as from my own practice. The maximum patients were then in the age group of 30 to 39 and males predominating, like 83% were male, and these 30 to 39 years age group were 41. At the time of initiation of the second line ART, 44% of the patients were on WHO 1 and 14 were on 2. If you see here, 95% of the patients, which is very significant, plus 45, that is even the second line, like in the last early detection of the first line failure was also not done. So here comes the role of proper counseling and monitoring of the patient when patient is on first line also. Viral load monitoring, it has to be a must. If you don't do a viral load monitoring these patients, you might get the patient in either immunological or clinical failure. By that time, a lot of times are going to get accumulated as far as AZT and D4T is concerned, and that may jeopardize your tenofovir in the second line also. So we have to diagnose as early as possible the first line failure, for which a strict protocol has to be followed. Whenever the questions have been, I'm asking the questions to those who are coming late, the answer was, the doctor has said that अभी CD4 200 के नीचे नहीं आया हुआ है, अभी CD4 350 के नीचे नहीं आया हुआ है. Even in the public as well as in private, both this question was, the healthcare givers were not themselves well accustomed when to switch. So it is must that we should diagnose first line failure as early as possible. The initial first line was thymidine based, that is near about 91% of the patients were on the thymidine based. DDI based was 1.4% and TDF based was around 7%. I could do the DRT in 108 cases. The second line which we have started at our center was either TDF or abacavir plus 3TC plus either atazanavir or lopinavir. I'm sorry, this is 91% and not 0.91%. So 312 patients. Raltagravir and atazanavir was started on 5. The question that comes to me, why have it started on raltagravir in this patient? This patient has experienced multiple drugs, NRTI experience, and they all had TAM1 pathway, and the tenofovir was not sensitive in these patients. So these patients were put on dolutegravir plus atazanavir. Those who were on TDF, they were put on either AZT, and 4 of the patients, they have developed anemia because of zidovudine, so I had to switch over to D40 in these patients. The outcome of the second line in my study was 39, that is 11% of my patients lost on follow-up. There were 14 deaths, not related with HIV and AIDS were 4, acute myocardial infarction with hypertension were 3, malignancies were 2. In IRIS, we had 2 deaths, renal failure 1, 2 patients had stroke, and 1 patient had Guillain-Barré syndrome. Because of the non-affordability, 55 patients, that is 16% of my patients were referred to government ART, and as on today, I am having 211 patients. What is important is the monitoring when a patient is on second line. Do expect tuberculosis even if your CD4 count is going up. We had near about 4.69, that is 16 patients, they have TB lymphadenopathy, pulmonary tuberculosis in 1, tuberculoma in 1, and tuberculosis meningitis in 1. We do have IRIS in initial 3 to 4 months, and 4 had PML, 4 had EPTB, that is extrapulmonary tuberculosis, 2 had CMV retinitis, 1 had toxoplasma, another had PCP. And yes, we do have malignancy in 5 patients with NHL 2, CA rectum, CA cervix, and CA oral cavity 1. The adverse event which we could get, like 18% of the patient had mild to moderate gastrointestinal adverse effect, 28, that is 8.21%, had renal involvement, 1 had a frank fangoni. Bone toxicity was seen in 18, dyslipidemia in 16, liver toxicity in 10, anemia in 4, pancreatitis and lipoatrophy in 3 patients. So I just come to the, in short, regarding the NRTI class related toxicity, we all know that we have already used NRTI for a very, very long duration. Now in second line also, we are using zidovudine or tenofovir or abacavir, where the fat atrophy, lactic acidosis, pancreatitis and cardiomyopathy, as well as myalgia because of the zidovudine and anemia because of the zidovudine, they are the important toxicity we have to monitor for. And the patient education and counseling is very important again for the second line. Adherence counseling is a must. Like we are, in my setup, we are having 2 peer counselors and 2 counselors who are continuously wagging their head of the patient for the adherence as well as toxicity counseling. If you let them know that they are going to be toxicity, they are sure of the fact that they might develop and they might take those precautions and come back to you as early as possible. We all know that tenofovir we have already used for a long time now. Everybody knows about it. And what we have seen is the dysfunction of the proximal renal tubules, where there is excretion of small proteins, glucose, phosphates and bicarbonates, leading to proteinuria, glycosuria in presence of normal blood sugar, phosphatidyuria as well as metabolic acidosis. So these patients have to be monitored very strictly. Whenever the patient is on tenofovir, expect renal toxicity. It is not like that you are just sitting on that and continuing the drug. Whenever you are having your patients on tenofovir, first and foremost try to look for the underlying renal diseases, if already there any. Use of nephrotoxic drugs. Very important, patients get admitted for pneumonia or something like that, patient you are giving aminoglycosides. Just avoid all other renal toxic diseases, renal toxic drugs. And whatever anytime what you can do is go for the labs very regularly. We are having the CG as well as MDRD. I am doing MDRD because it is much better than the CG. So always you have to calculate the eGFR, and there is a protocol where you have to do at the baseline the creatinine clearance, urine analysis and serum bicarbonates. If the tests are normal still, don't leave that patient just like that. Risk factors, you have to go for bone diseases like low body weight, oligomenorrhea, history of traumatic fractures, bony pains, kidney disease, long-term corticosteroid. If there is no risk factor, then no further workup is required. But if there are consider the alternative antiretroviral regimen without tenofovir. If the results of the creatinine clearance are abnormal, then go for 24 hours unit studies. as well as adjust the dose for the creatinine. If the studies are absolutely abnormal, try considering changing the tenofovir drug. Otherwise, continue with the creatinine clearance adjusted dose. Monitor very closely for the bone disease also. Serum phosphorus, serum alkaline phosphatase, bone densitometry, DEXA, vitamin D levels, and consider the treatment for the replacement of calcium and vitamin D3. ART bone loss, we all know that it is now really, sometimes I think that whether we are okay with tenofovir, it was better. So we are getting fractures, we are getting tenofovir toxicity, renal toxicity, but we have to anticipate the bone loss, and for that, we all know that osteoporosis and fracture is a factorial thing because of the HIV virus per se, the ART, the aging, hypogonadism, glucocorticoid, nutritional status, tobacco, alcohol, drugs. There are a lot of issues for the osteoporosis of the fracture, but here the supplementation of vitamin D3 might reverse the things. Then I come to abacavir. You all know that abacavir hypersensitivity, once labeled is always labeled. Don't ever try to restart abacavir. If possible, go for HLA-B 5701. If it is suggestive, then don't start on the abacavir. Consider the other drug. Then PI, we all know that GI disturbances, hepatotoxicity, metabolic changes are there. Triglycerides, cholesterol, lipid atrophy, hyperglycemia, and cardiovascular risk. GI disturbances are there, lipid abnormalities, hyperglycemia, lipoaccumulation, all the things are there. We all know that lopinavir will be causing diarrhea, then the hyperbilirubinemia because of the atazanavir, ritonavir. So we should have a baseline serum lipid levels, baseline glucose, baseline liver enzymes, and symptom-driven testing. We should know that whenever, if you can compare with atazanavir, lopinavir, then the consistency with the pediatric drugs is not available with the atazanavir. We have to use lopinavir. But the advantage of once a daily atazanavir versus twice a daily lopinavir with more pill burden, both are safe in pregnancy. Then hyperbilirubinemia has to be considered in the mind when you are using atazanavir. Dyslipidemia more with the lopinavir, ritonavir, and availability of the generic drugs so as to decrease the cost is a very important thing. Dyslipidemia, you have to have annual basis, base testing for the dyslipidemia. The drugs which are there, which we all know that the main lopinavir, ritonavir is the main. We are not using so much about the saquinavir and timprenavir. Other drugs are much better. So in conclusion, adherence, and adherence, that is must to decrease the loss to follow-up. Then proper monitoring of the patient for the toxicity, for the iris, expect tuberculosis, expect malignancy, monitor for the toxicity, switch with caution, and treatment of toxicity. Thank you very much.
Thank you, Dr. Brushandi, for your presentation. We'll take questions at the end of the session. Our next speaker is actually, the presentation is by video link. We have Dr. Hans.
This is Dr. Hans Jäger speaking to you from Munich, Germany. Dr. Gilada has asked us to contribute to the Asicon 2016 conference, an update on HIV, and to give the German perspectives on that. I met Dr. Gilada for the first time about 30 years ago at the Max Müller Bhavan in Mumbai. And since then we have collaborated on clinical issues, on research topics, and on other issues related to HIV/AIDS. Our clinic is one of the larger HIV clinics in the country, in Germany, and we are treating several thousand HIV patients. Our staff is about 30 doctors, nurses, and scientists, and they come from 10 different countries, European countries, Asian. Hans Jäger speaking to you from Munich, Germany. Dr. Gilada has asked us to contribute to the Asicon 2016 conference, an update on HIV, and to give the German perspective on that. I met Dr. Gilada for the first time about 30 years ago at the Max Müller Bauern in Mumbai. And since then we have collaborated on clinical issues, on research topics, and on other issues related to HIV/AIDS. Our clinic is one of the larger HIV clinics in the country, in Germany, and we are treating several thousand HIV patients. Our staff is about 30 doctors, nurses, and scientists. And they come from 10 different countries, European countries, Asian countries, or African countries. Research topics in the last years or so have been HIV cure, and we are doing a research project on that. And another very exciting project is long-acting medication for HIV patients. That means giving shots instead of tablets. These shots are given every 2 months or 3 months, and they are a combination of cabotegravir and rilpivirine. In this short video, we will focus on 4 issues related to HIV. First, PrEP, pre-exposure prophylaxis. Second, low-level viremia and resistance. Third, hepatitis C and co-infection. And fourth, this has been a topic for us very challenging over the last year and a half because of very many migrants and refugees to Germany, is treating refugees and migrants. And now you will see the presentations.
Hello. Currently, the only drug which is recommended for PrEP is Truvada for people who have a substantial higher than average risk of contracting an HIV infection. PrEP studies like Hypergate, published in December in New England Journal of Medicine, Partners PrEP, shown approximately 90% reduced risk of infection if the drugs are taken every day. This is very important. PrEP is indicated for men who have sex with men, especially if he had sex without condom in the last 6 months, or he had any sexually transmitted diseases in the last 6 months. Reasons for not using PrEP are especially persons with unknown HIV status because of resistance problems, persons with hepatitis B because of flare-up after stopping PrEP, and persons with kidney problems because of side effects of the drug. Therefore, when suggesting PrEP, it should be taken under the control of a medical doctor. Since August, Truvada can be prescribed in Germany, but the costs of 800 euros are not paid by government or insurance, health insurance. There are possibilities to get it via internet from, for example, India, for a price which costs a fraction of the original amount. If PrEP is taken, it should be monitored every 3 months, including HIV tests, screening for STD, and kidney function. Following these instructions can be a very good strategy for the prevention of HIV and AIDS. Thank you very much.
Everybody, due to the availability of so many treatment options and due to the close monitoring of our patients, virologic failure with high viral load is rare in Germany. Challenges have changed, one of which is low-level viremia in treated HIV infection. So to speak, a repeated viral load between 50 and 200 copies. Low-level viremia may reflect active virus replication and thereby a risk of resistance development, but on the other hand can also reflect assay-dependent variation or intercurrent activation of the latent reservoir. How do we deal with this phenomenon in clinical practice? After excluding adherence problems or drug interactions, we try to perform a genotypic resistance test, especially if the patient is on a regimen with a low resistance barrier. Generally, we perform population sequencing, where we can detect virus populations of at least 50 to 20%. However, resistance testing more often fails in case of low-level viremia below 200 copies. If we have enough virus, so to say, have enough plasma concentration, the virus, we prefer resistance testing from RNA. Otherwise, we try to sequence proviral DNA from virus integrated in the cells. Proviral DNA sequencing is also of special interest if we do not have treatment history or history of drug resistance in pre-treated patients presenting with low lipoviremia while on antiretroviral therapy. So this helps us to evaluate the activity of single components of the regimen and helps when treatment changes is necessary due to, for example, side effects. We also have access to ultra-deep sequencing, where we can detect minority variants down to 1 or 2%. But the clinical relevance of minorities is still inconclusive, since we do not know the clinical cutoff for specific drugs. However, if we detect an increase in drug-resistant variants, even at low levels, this might be an alert for us to change therapy or monitor more closely. So, this was just a brief overview of our HIV management strategies. Now, more important, I wish you a successful conference with many new insights that you can implement in the clinical management of your patients.
In our outpatient clinic, we diagnose and treat patients with chronic HCV infection. As we are specialized in HIV medicine, some of our patients are co-infected with HIV. Diagnosis of chronic HCV is often made within the first contact with a newly diagnosed HCV patient. At our place, as we check for concomitant sexually transmitted diseases. Furthermore, we do control HCV status in our patients on a regular basis. That means HCV antibody test or PCR 2 times a year, as there is a relevant number of new infections or even HCV reinfections after successful treatment. We also see patients that are already identified as HCV positive and who are sent to our center to get specialized recommendations in treatment of this disease. Patients are having varying backgrounds. The greatest proportion of many HCV monoinfected patients are people who take drugs or have done so in their longer history. But, as in many other countries, a far bigger proportion of patients hasn't been aware of the disease, and we can't identify any risky behavior. So we still face the problem of a big proportion of undiagnosed HCV infections. In Germany, doctors specialized in hepatology or infectious diseases initiate and prescribe HCV treatment. This is mainly due to the very expensive treatment costs for direct-acting antivirals, ranging from €18,000 up to €30,000 per monthly prescription. Some patients, especially from Eastern European countries and Russia, who purchase their medication via international pharmacies or directly from India in hope for a better price, as we have learned to price somewhat only a tenth or even less compared to Germany. Nevertheless, with the new interferon-free BAA treatment options, we achieve stable cure rates of 90%, which has been confirmed in various international and also nationwide studies in real-life settings.
In 2015, over a period of a few months, a huge increase in the influx of refugees arrived in Europe, about 1 million of them in Germany. This was quite a challenge for a country of 18 million inhabitants, which does not consider itself to be a country of immigration. Overall, the resident population showed quite a welcoming attitude towards the refugees. Many volunteers helped to care for them. Nonetheless, there has also developed a marked increase in right-wing nationalist political movement in the aftermath. In terms of infectious diseases, some diseases can be highlighted among the refugee population, none of them being a threat to the local population. There is tuberculosis, both pulmonary and extrapulmonary, which is a very rare disease in Germany, but among refugees has a much higher prevalence. There is measles, which we had a serious outbreak in Berlin due to poor vaccination coverage and also due to housing in densely populated camps. HIV infection is mainly diagnosed among refugees from sub-Saharan Africa, while those from the Middle East are predominantly diagnosed with chronic hepatitis B. Treatment is financed by government as long as the disease is acute or a life-threatening chronic disease, such as HIV infection. Non-life-threatening conditions, such as hepatitis B or C, need individual case-to-case negotiations with government to cover the costs of treatment. Overall, the medical care of the refugees is working well.
We all wish you a great Asicon 2016 in Mumbai.
प्रति के शहर क्लिनिक में डॉक्टर ईगल की विशेष प्रयोगशाला की टीम एसिकॉन 2016 कांग्रेस का मुंबई में हार्दिक स्वागत करती है.
In Mumbai and Delhi and from the MSF team in our clinic, I'd like to present to you our experiences of treating second-line failures and patients who are taking third-line ARTs at our clinic. We have been seeing this slide for 2 days now. So just to give you a brief idea, the number of patients who are on ART has increased, and also the deaths have decreased globally and also in the country, and most of this has been attributed to increased availability of ART services. We have seen these 90-90-90 targets also, and as we all know by now that the first 90% of people should know their HIV status. The second 90 is that 90% among them should be on ART, and to focus on the last 90 here, which says that 90% of the patients who are on ART should have virological suppression. And a major requirement for this virological suppression is that patients should be on an effective ART regimen. As first-line ART services are being increased today, more and more people are coming on first line. So we have observed failures and people are taking second line. But as second-line ART services are also being increased, we can hypothesize that in the future, the need for third-line ART is, demand for third-line ART is going to increase. With this brief background, I'd like to give you an introduction to the setting of the study. So MSF has been, we have a clinic in Mumbai since 2006. We are in the western suburbs of Mumbai earlier. Currently, we are based in the eastern suburb of Govandi. We run a specialty clinic providing services to drug-resistant tuberculosis and for HIV. The clinic has a multidisciplinary team. We have doctors, nurses, psychologists, counselors, social workers. All of them work together, and we try to provide a package of care which comprises of medical and counseling and other services. Now, it's not that we keep on treating all the patients in our clinic. We do not provide treatment for all. What we do is patients are referred to us for second-line failures, drug toxicities, or some other reasons. And then what we do is we manage those toxicities or failures and other things. And whenever it is possible, we transfer out the patients to mainly public facilities such as JJ or KM ART centers. So total, we had about 1,200 patients who were enrolled with us. And currently, we have an active cohort of 150 patients who are taking antiretrovirals with us. We are providing third-line ART since 2011. That's about 5 years now. To give you a brief idea of how our cohort over the period has looked. So first, when we started with providing first line. Then when first line was made available in public centers, we shifted to second line and toxicities. Now, since last year, we have been focusing mainly on providing services to second-line failures and only third-line ART. So the inclusion criteria for our clinic is patients are referred to us with second-line failures. It's not for the first time that we have been advocating something like third-line ARTs or virological testing for everyone. The paper that you see here was published about 2 years back, which gave our first experiences about treating third-line ARTs. This paper is a systematic review which cites the study shown earlier, and they also advocate for viral load monitoring as a tool, as a routine virological monitoring for adherence and treatment monitoring. This comment was published about a year back in Lancet, which we had published. It reads, HIV viral load message should go viral. And we have been advocating for monitoring of viral load here. It's not only in India that we are doing this. The last paper that you see here is published from South African cohort of MSF. We have a bigger project in South Africa, Kylie, to be specific. To give brief methodology, for this paper presentation here, we have done a retrospective cohort analysis of all patients who had been referred to us as second-line failures from 2011 till June 2016. We used genotyping and we used the Stanford Genotyping Guide for interpretation. The backbone regimen for our third-line ART patients was ritonavir and raltegravir. Before I go into details, I'd like you to know a few definitions. So second-line ART, we have defined it as treatment regimen for PLH who have failed a first-line regimen. And this regimen consists of mainly a PI and 2 or 3 NRTIs, as we had seen in the earlier presentation. For treatment monitoring, we use virological failure, and hence I'm defining this here, which says that plasma viral load is less than 1,000 based on 2 consecutive viral load measurements 3 months apart, and the important part is there should be adherence support in for these 3 months. Another definition that we use is something called a substandard regimens. Now, we define substandard regimen as adding only 1 new drug to a failing regimen, or using drugs with cross-resistance from previously exposed drugs, or a regimen which contains less than 3 drugs for any reason, maybe financial or the prescription itself. It's not that as soon as the patient is referred to us as second-line failure, we start them on third line. So whenever any patient is referred to us for second-line failure, we'll do a baseline viral load, and on the baseline viral load, we'll start a patient first on a second-line regimen of a PI and NRTIs or NNRTIs, depending on the history, and then we'll do an enhanced adherence counseling sessions. Now, what enhanced adherence counseling is? Now, enhanced adherence counseling is a very intensive and an individualized sessions that the patients get, which starts with knowledge assessment of the patient. How much does the patient exactly know about the disease and the treatment literacy? Then the counselors do a motivation assessment of the patient, and then based on that, along with the patient, a treatment supporter or a buddy, they prepare an adherence plan for the patient. And using this adherence plan which is prepared, it is individualized, highly tailored to the need. So for each patient, this adherence plan would be something different. And they'll continue providing intensive support until the barriers to adherence are resolved. After doing these 3 things, that is baseline viral load, a second-line regimen, and an enhanced adherence counseling for 3 months, then we'll repeat the viral load. After repeating the viral load, you can see to your right that if the viral load is undetectable or there is a 2-log decrease, we'll continue with the second-line regimen and we'll continue 6 monthly viral load monitoring. If the viral load is detectable after 3 months of adherence counseling, then we'll go for genotyping, and based on the results of genotyping, we'll decide for further action. To give you a brief the cascade, in study period, 104 patients were referred to us as second-line failures. And after 3 months of enhanced adherence counseling and second-line ART, you can see here that 70% of them improved on a second-line regimen and did not have to be switched to a third-line regimen. So, and 31 patients, about 30% who had a viral load of more than 1,000 had to be investigated further. So to give brief characteristics of patients that we had 44 patients total with a median age of 44, which is similar to, I guess, the earlier presentation. Quarter of them female, and 5 of these patients were taking drug-resistant tuberculosis treatment. Most of the patients, 60% were referred from private, 40% referrals came from public ART centers where second line is currently being provided. And if you look at the past regimens, as I had shown you a definition for substandard regimen earlier, we saw that almost 50% of the patients who were referred to us had exposure to substandard regimens in the past. And if we go into a bit more detail, 3 patients were taking only 1 ART drug, while 6 patients were on a regimen which had only 2 ART medicines. If you look at the resistance pattern, genotyping was necessary for 27 of the patients, and we can see that all of them had resistance to NRTIs. About 77% showed resistance to 1 or more NRTIs, and about 65% of those for whom genotyping was done had resistance to one or more of protease inhibitors. The major mutations that we had observed, all patients had the M184V mutation, which is quite common for patients who are taking ARTs, and I guess many clinicians use this as a proxy for adherence. The others were L74I and the Q151M, which give resistance to mainly the first-line 3 TCFC and the IBC. The NNRTI mutations were the G190A and the K103NS and Y181, which give resistance to mainly nevirapine and the other ones. Major protease mutations. Now, 2 patients had the I154L and 3 had I84. With these 2 mutations provide low-level resistance to darunavir, which is a backbone for third-line regimen. So these patients actually have low-level resistance to darunavir already. The outcomes of the patients, 31 patients were started after the enhanced adherence counseling, 13 were prior enrolled with us, and 44 out of the 44 patients who are taking third-line ART, 36 currently had completed 6 months. 83% of them had virological suppression with this newer regimen. They had a viral load of less than 200 and are doing well. 4 died, 3 of them due to drug-resistant tuberculosis, and 2 patients currently await salvage regimen beyond third line because of their resistance to protease inhibitors and in RTIs. So you know that this is a small cohort, but this is one of the very few studies on third-line ART in India. We have seen a viral load resuppression of about 70% after just enhanced adherence counseling. So if that is done, enhanced adherence counseling is done properly, then we'll have avoid unnecessary switch, and this can be a cost saving for the program, and it will also prevent exhaustion of ARV choices, which actually are needed lifelong for the patients. After initiating third-line, viral load suppression was also high. Then TB was the major cause of death, and a higher exposure to substandard regimens. It had been seen earlier by some papers, but again, we still continue to see that. 2 patients currently need salvage regimen beyond third line. To conclude, routine viral load testing followed by genotyping will be more cost effective by preventing unnecessary switch to an expensive regimens. Then socioeconomic assessment and counseling should be done before putting patients on third line ART, especially in the private sector given the cost of third line ART. Self-funded treatment, especially for third line ART, should not be encouraged. Widening access to ART in the public system and a robust public and private referral wherein patients can be referred way should be developed. And fast tracking of registration for ARVs which are required for post third line salvage regimens should also be done. So thank you.
Thank you, Dr. Chinmay, for a wonderful talk.
For inviting me up, and thank you, Ganga. Also, I think Ganga actually designed this topic. It's a very difficult topic, I can tell you, because of the heterogeneity of the data and very difficult to interpret evidence. But let's try to do it, and let's try to look at how we can translate some of these evidence into practice. This is the outline of my presentation. I'll talk to you about how do we define treatment interruption. Then we'll look at few studies looking at the prevalence and risk factors for treatment interruption. We'll look in detail on the consequences of treatment interruption. And finally, we'll talk briefly about how to manage treatment interruptions and how to prevent them in practice. Well, there are 2 kinds of treatment interruptions, a planned treatment interruption and an unplanned treatment interruption. A planned treatment interruption would be a short-term treatment interruption, which usually goes on for days to weeks. And this is basically driven medically, either by the physician who wants to stop the medication of the patient for certain reasons. The commonest reason would be toxicity of a particular medication or a combination regimen. Conditions which would need nil by mouth, example surgery, or pancreatitis, which is quite common in the HIV situation. Surgical procedures for the patient may be or may not be related to HIV. Drug-drug interactions which may hamper using these drugs together. You may have to briefly stop the medications. Pregnancy, where you need to switch or stop, and especially delivery, around delivery time, if the patient is going through a C-section, you need to keep the patient NBM. And finally, strategically, if you want to really give a patient a breather kind of a thing to stop the medications on a weekend and take it for a week, and there is some evidence for this coming from the breather study. Very planned treatment interruptions can happen in the long term, but this is basically only in the context of clinical trials, particularly in primary HIV infection. Unplanned treatment interruptions are the second kind, where it's basically driven by the patient. You don't have control over it, and most common causes for these in low income settings like India, low and middle income settings like India, is affordability. Patients can't afford drugs, they stop it in between. There may be drug stockouts which happen in the government sector. There may be errors in prescription and errors in dispensing, particularly in inpatients, that we commonly see where nurses or they don't give the medications at the proper time. There may be treatment fatigue by the patient, particularly who is on a long-standing treatment. Again, toxicity driven by the patient because the patient feels he can't tolerate the medicine. A lot of patients for intercurrent illness go to local physicians who advise them to stop the ART. So that is another unplanned treatment interruption. And then there are a host of other social and behavioral issues which cause treatment interruption, which are patient driven. The second issue is, let us see what is the prevalence of and risk factors for treatment interruption. Now there is heterogeneity of data here because people have different treatment interruption variedly. Some right from having a treatment interruption for 1 day to for more than 1 year. So this is something which is difficult, but this is one of the big studies, the ART-CCC, which basically looks at global cohort, kind of a global data collection cohort study, which looks at durability of first-line regimen. And as you see here, treatment interruption forms a significant proportion of, I can't find the pointer. Okay, treatment interruption is basically constituting almost 40% of non-durability of a first-line regimen, contributing to non-durability over a period of 3 years. So significant amount of people interrupt treatment and maybe reinitiate it later on a global level. There is a meta-analysis looking at risk factors and prevalence in low and middle income countries recently published. And again, this shows that around 25% of patients interrupt treatment unplanned for more than 3 months. And then there is a varied duration below less than 3 months. What are the predictors for treatment interruption? Younger age, people who are young tend to interrupt more, females interrupt more. People who come with advanced HIV disease, stage 3, 4 WHO, or a low CD4 count of less than 200 tend to have more unplanned treatment interruption. Let us now look at what are the consequences of treatment interruption. If you stop treatment, the first and most important thing is obviously going to be a viral rebound. You stop treatment, your virus comes up. That can lead to, in a significant proportion of patients, an acute retroviral syndrome because you have a viremia coming up, so you have something like primary HIV infection, which can trigger retroviral syndrome, which is different from the seroconversion illness because here you already have antibodies in the patient's plasma. If you have a long treatment interruption, then it's going to cause a decline in the CD4 counts, it's going to cause HIV disease progression, and then there's a whole lot of immune activation which is triggered by the virus coming up. So you have a lot of what are called as serious non-AIDS events. We'll look into the evidence for that, particularly cardiac events, renal hepatic, and the progression of neurologic disease as well because of the viremia. Obviously, since you are going to have viral rebound, the risk of transmission is there. We know antiretroviral therapy, if taken effectively, reduces the risk of transmission. If not, you would have an increased risk of transmission. And finally, of course, the development of drug resistance. And there are various factors really in treatment interruption which can lead or trigger to development of drug resistance. We'll see some evidence for that as well. Perhaps the most important study in treatment interruption has been the SMART study. This is an old study almost a decade ago where patients were randomized into 2 groups. This was a CD4-directed drug interruption study. You had a drug conservation arm in which patients continued to take antiretroviral treatment, and then you had drug conservation arm in which the patient interrupted taking treatment based on CD4. So they started treatment and then they continued it until the CD4 went above 350 and then they stopped till it came to less than 250 versus patients who continued to take antiretroviral treatment. Now if you stop antiretroviral drugs, you would expect that you are going to develop opportunistic infections and death from any cause, more commonly if in the drug conservation group. So it's not surprising that there was a significant, the trial was stopped in between because there was a significant increase in the risk of opportunistic disease and death in the patients who had CD4 directed treatment interruption as compared to continuous treatment. Now, we would also expect that if you stop antiretroviral medications, then the side effects of drugs like renal or hepatic or cardiovascular, for example, may go down. But this was not seen in the SMART study, and this was the major surprise from that study. In the drug conservation group, in the patients who interrupted treatment, you had a higher risk of developing non-AIDS events. So this was surprising, which triggered a thinking that it's actually HIV viremia which is causing immune activation leading to higher event rates and not solely because of the side effects of the medications. And then when you actually look at the risk ratios of these various events, the evidence clearly shows that it's the current CD4 and the viral load and not treatment interruption which is causing a higher risk of this event, both opportunistic disease as well as non-opportunistic disease. So when you stop treatment, a lower CD4 count and a higher viral load is going to trigger these events and not just the treatment interruption arm as is shown in this slide. What about side effects? Because you think that you're going to conserve the drug in the interruption arm, you will get less adverse events. Well, this was not clearly shown in this study. There was a slight trend towards decreasing adverse events in the drug conservation group as compared to the suppression group, but then this was not really statistically significant. Now this was something which was a clinical trial, but there was a cohort study from the EuroSID. Again, it's an old study which looked at the risk of progression to AIDS and death in patients who interrupted treatment for more than 3 months and then reinitiated treatment. And after reinitiating treatment, what were the events? And as you see here, even after reinitiating treatment, after an interruption of more than 3 months, you have a higher incidence risk ratio of developing an AIDS or a death. Which is shown in the first cartoon there. But then when you start adjusting it to the current CD4 count and the viral load, you see that that hazard ratio decreases. That means that after treatment interruption, whatever the CD4 and viral load is, that is something which determines the risk of developing AIDS or death. There's another planned treatment interruption, which was a PROMISE study, the third arm of the PROMISE study, which is basically a perinatal study which looked at continuing ART after pregnancy, after delivery versus stopping ART. And what they actually saw was not much difference in the AIDS-defining event, serious non-AIDS event, or death because of any cause between these two arms. It was quite safe, but then the study also showed that it is safe to continue antiretroviral treatment after delivery if you have originally only planned it to use for MTCT purposes. So very clearly continuing ART is something which is beneficial and safe even in the postpartum period. There were certain interesting things which were seen in the SMART study. I already told you the most interesting thing was a higher risk of developing CVS, renal, bone and liver toxicity. And what this was basically looked into was changes in procoagulant or inflammatory markers like interleukin 6 or D-dimer, which are basically procoagulant or inflammatory markers. And as you see here, the risk of developing higher levels of this increases with the risk of viral load on interruption. So higher the viral load, higher is the D-dimer, higher is the IL-6, as is shown in both of these graphs here. There's another trial which actually used a higher CD4 cutoff for reinitiating treatment, but however it also showed similar increase in CV risk factors with planned treatment interruption happening in patients who basically interrupted antiretroviral treatment. This is a recent Malawian study which looks at unplanned treatment interruption patients and looking at arterial stiffness as a surrogate marker for CV risk. And as you see here, as the number of treatment interruptions increase, arterial stiffness increases. The pulse wave velocity, which is basically a marker of arterial stiffness, increases over as the number of interruptions. So you may be able to reinitiate treatment, you may be able to reduce, achieve virologic suppression, but those treatment interruptions are kind of in the history of the patient, and that confers a higher risk of developing either an AIDS event or a non-AIDS event in HIV positive patients. So it's quite threatening to have treatment interruptions in your clinic patients. Interestingly, platelets also decline after planned treatment interruption. This is again data from the SMART study. And this is again basically looking at viral load. As higher the viral load, more is the decline in the platelets. What happens to the bone? If you stop antiretroviral therapy, the bone density improves. So that is directly perhaps more related to the, so this is one beneficial benefit of having a treatment interruption in terms of reduction, in terms of increase in the bone mineral density when a patient has a planned treatment interruption. What happens to sexual transmission? This is a study which looked at treatment interruption, correlation between viral and seminal viral load, and as you see here, as the blood plasma viral load increases, the seminal plasma viral load increases as well after treatment interruption, which is kind of a surrogate for increased risk of transmission. It's not only that, but the longer it takes for the viral load to go undetectable again, or for longer it takes to continue to be detectable, you have a higher risk of having a seminal plasma viral load, leading to higher risk of transmission. It's also not dependent on what is the duration of treatment or adherence, but it also what type of ARV regimens you are using. This is a complicated slide, but what I want you to focus on is only the red dots. These are basically virologic failure dots, and this is an NNRTI. On the y-axis, you have the duration of treatment interruption, how many days a patient has interrupted versus average adherence on the x-axis. And as you see here for NNRTIs, if you have a longer duration of stopping the medication, the risk of developing resistance is higher, vis-a-vis for the same level of average adherence. But for a PI, you basically have lower average adherence, but not the duration of stopping a particular PI, which is leading to development of resistance. So it's not surprising that in the MSF study that you have patients resuppressing, because their average adherence may have been good, though they may have stopped the medications for longer periods of time in their second line regimen. And finally, this is a planned treatment interruption. It's a success where you have young adults and adolescents being randomized into weekend off of efavirenz and continuing after achieving suppression. And as you see here, as compared to continuous treatment, the short cycle treatment did as well in these patients. So in very selected populations where you can monitor adherence, you can perhaps offer weekend off treatment with efavirenz based regimen. Let me briefly tell you about post-treatment controllers. This is not something which we do in clinical practice, but this is basically you start ART in patients who are acutely infected and then subsequently remove the ART. You plan a treatment interruptions and they achieve control without ART. And there are various reasons why you basically achieve this post-treatment controllers, right from reducing size of reservoirs to preserving gut-associated lymphatic tissue. But when do you start treatment? When is this most beneficial to achieve a post-treatment control status? Earlier is the better, and not more than 6 months. How long before you interrupt treatment in primary HIV infection? You should perhaps treat them for a longer period of time, maybe for 3 to 4 years. And finally, what type of ARVs may also matter, because your ARVs initially should be able to penetrate into the gut and the lymphoid tissue, where there is maximum amount of replication happening. So these are some of the factors which may help us in achieving a post-treatment controller if you plan to treat a patient with primary HIV infection. Let me finally end by giving you, based on these evidence, how do we translate that into practice in terms of managing a treatment interruption. So if it's a planned treatment interruption, it is easy. If it's a patient is having a grade 4 event, a toxic epidermal necrolysis or a drug-induced liver injury, you need to stop all drugs. There is no issue about that. But if it is for a few days, in that situation, you need to look at what kind of regimen the patient is on and whether the individual ARVs have different half-lives. Particularly if it's an NNRTI, you know, they have a longer half-life, and if you stop all of them together, you're going to have functional monotherapy because of the long half-life of an NNRTI. So you can usually continue the backbone nucleoside for a period of 2 to 4 weeks, or you can replace the NNRTI with a boosted protease inhibitor for 4 weeks. You have to remember also that patients have food requirements. So if you have a patient coming out of pancreatitis who's on oral liquids only, or water only, then atazanavir, ritonavir absorption can be a problem. So you have to take these at the back of your mind when you manage these patients. In terms of planned long-term interruptions, I don't think we should do it or have a look at it outside the setting of clinical trials. This is just a cartoon which summarizes the differential half-life of NRTI and NNRTI. So this is a combination regimen of both. You see the NRTI dose going up, and then you have the long half-life of NNRTI. If you stop, then you're going to have functional monotherapy. So you continue the backbone nucleosides to cover for that functional monotherapy over a period of time. Now, managing unplanned treatment interruption, this is a clinical reality. Patients coming to you, if you ask them a history, they'll tell you that they have missed medications over a small period of time. So how do you approach them? In that situation, you have to remember that each patient is different, and there are various categories, various thought processes that you have to have in your mind in determining what regimen you are going to give. The key question here is, are you going to reinitiate the same regimen that the patient was taking, or are you going to switch the patient into, if he is on a first line, to a second line or a third line? And what is going to help us in that? First and most important is the nature of the unplanned treatment interruption. In that situation, what we are talking about is whether the patient took the treatment one day on, one day off, or whether the patient stopped all the medications together. In that situation, the risk of development of resistance is going to be high if they're going to be taking it intermittently versus somebody who has stopped all of them together. Again, you have to look at whether they're taking NNRTIs or PIs. And I told you that beautiful cartoon which showed you that average adherence make a difference in PIs, while how long the patient stopped the medication makes a difference in terms of developing resistance for NNRTIs. Whether it is a single tablet regimen that the patient was taking or a multiple tablet, whether he was going to stop only one component of a regimen and continue the second one. All of these things have to be taken into mind when you're deciding reinitiation or switch. What was the state of the patient at the interruption? Whether the patient was virologically suppressed prior to the treatment interruption. If the patient was suppressed, then the risk of developing resistance because of interruption is lower, and perhaps you may think of reinitiating the patient on the same regimen. What is the current clinical status of the patient? Whether the patient has advanced disease, in that situation, you can't really experiment by reinitiating the same regimen for the patient. Perhaps you should be switching the patient in that context if you're not really sure about the efficacy of reinitiating the regimen. Whatever you do, close monitoring, particularly after reinitiation, is very, very important. And that means you have to have access to viral loads. An earlier viral load to see a 2-log response over a period of 4 to 8 weeks is a reasonable surrogate that the regimen may be working fine for your patient. And finally, you need to also not forget to explore and address reasons for unplanned treatment interruptions. I'm sorry, I'm running out of time. So let me finish by giving you preventing issues. Most important thing obviously is medication taking behavior, and there are two concepts here. One is adherence to medication, another is what is called as persistence. That means you have to take a medication for a long period of time, and that is defined as persistence. You need both adherence as well as persistence for achieving treatment success. Unfortunately, there are very few interventions with good design which look at how to improve adherence to ART in the clinical setting. Large amount of evidence is available for SMS texting and reminding patients, and there are randomized trials which have shown the effectiveness of the same. And I think at this point of time, both in the public sector as well as in the private sector in India, adherence support system is a big unmet need, and that is something which we need to really look to improve in terms of reducing the risk of treatment interruptions. So let me summarize by saying that unplanned treatment interruption is a clinical reality. Almost all of us have faced this in our practice, patients coming to us with an unplanned treatment interruption. That is, it is very clear that even after reinitiating ART, these individuals have a higher risk of morbidity, mortality, risk of transmission, and development of resistance as compared to patients who continue to take treatment. Preventing unplanned treatment interruption is the key. Unfortunately, very few formally tested effective interventions are there. And finally, managing an unplanned treatment interruption in the clinic is a very complex process, and it has to be a highly individualized approach. And it's important to have access to viral load and close monitoring of the patient after reinitiating or switch to make sure that the patient resuppresses and gets a clinical benefit out of it. Thank you for your attention.
Different type of questionnaire rather than just writing to a treatment interruption. So it is wonderful to note such things. Now I invite Dr. Milind and Dr. Chinmay on the dais. Any questions are there?
Well, I'm waiting on effervescence. If they develop toxicity to nucleosides, we may have to stop the drugs, planned intervention. In such case, effervescence also to be stopped immediately. So is it advisable to continue effervescence with some other drug, PI drug or something, to prevent NNRTI mutation at a later stage? Can you follow me? Did you understand? FDC, tenofovir, lamivudine, effervescence.
To whom are you addressing the question, sir?
To Sanjay Pujari.
Can you repeat your question, please?
Okay. In government setup, we give FDC for the patients, and FDC fixes the combination, tenofovir, lamivudine, effervescence. Sometimes if they develop nucleoside toxicity, for example, bone marrow density is reduced in tenofovir, or lactic acidosis, life-threatening, or something else connected with the nucleosides. So we are stopping all three drugs together. So exposing the patient to the effervescence resistance or something at a later date. In such scenario, what shall we do? Shall we substitute PI drug with effervescence, or shall we stop effervescence total?
Yeah, I think the question is important because in the public sector you may have limited repository of drugs. So if a patient comes to, and again it depends on what's the severity of the adverse event. If you have an AKI secondary to tenofovir, then you're going to stop all the drugs together for the patient because you're going to manage that acute event right now rather than trading it off for the risk of developing an NRTI resistance in the future. But if a patient has a mild adverse event and you want to basically stop these medications, I would rather in my clinic substitute the offending drug with another drug. For example, if it is a tenofovir associated Fanconi, then I would perhaps switch the tenofovir to abacavir in my patient population rather than stopping all the medications together. But I'm not sure how you approach it in the government.
Now, if it is for tenofovir-induced renal failure, hepatic failure, what shall we do? Hepatic toxicity, nucleoside toxicity.
Your voice is
echoing.
Nucleoside toxicity, if it is stopped in FDC, to prevent effervescence mutation or resistance, single drug therapy, what shall we substitute with effervescence? No, for nucleoside toxicity.
I told you already, if it's AZT, you substitute to TDF. If it is a TDF, you can substitute to abacavir or AZT. As long as you are sure that the regimen is working fine for the patient is suppressed.
So, cannot be used any nucleoside? If cannot be substituted for any nucleoside, what shall we do?
Sorry, we can't make out what you're saying. Can you just go back a bit from the mic? It's echoing.
Okay. If we cannot substitute the nucleosides, what shall we do? Shall we continue effervescence or shall we stop it?
Can somebody just...
That's what I mean.
You're addressing your question to?
Sanjay Pujari.
Let's have a one-to-one outside.
Okay, no problem. Okay.
Just another 2-3 questions, please, because we are running out of time.
Sanjay, you said plan interruption for weekends, and weekends can be Friday, Saturday, Sunday or Sunday, depending on you are in central government, you are in state government, you are in private. So I think that has to be clarified. Secondly, there is also stockout related treatment interruption with NACO. Sometimes some drugs are not there. So even that can be planned or unplanned. I don't know how that can be decided.
Stockouts, as I told you, is an unplanned treatment interruptions. Now, it's very clear that you need to be on ART for life, and there need not be a treatment. We have seen the consequences of treatment interruption are bad. As far as your question of weekend on, weekend off is, it's basically one study, which is the breather study. The population is very clear. It's children and young adults. So we're looking at adolescents, even in that population. Now, the concept is simple, 2-day off. Now, whether it's a Friday, Saturday 2-day or a Saturday, Sunday really doesn't matter. The issue is 5-day on and 2-day off. Now, you can have a weekend on Wednesday, Thursday. I have no problems.
So I have a question and a comment. The question is for the MSF presentation, which was excellent. So you talked about 70% of people who were resuppressed. So I wanted to ask, how long have you followed them, and can you say if this is sort of sustainable? And the other related question is, could you identify any differences between those who were and were not suppressed, whether you had access to any genotypes before, and whether these were just people that were not taking their medications and did not have any resistance before, as opposed to people who actually had resistance to these medications and then resuppressed, and then the question of how long they were followed. That's the question. The comment is to Dr. Pujari. So one other option of unplanned treatment interruption is sort of a chaotic, unplanned event, unplanned treatment interruptions. And we looked at such circumstances in Kenya after the violence that was after an elections, where people just couldn't get to clinic and were basically not able to take any medications. And we looked at long-term outcomes of that and compared people who had and did not have treatment interruptions 2 years after that event, and the people who had this unplanned treatment interruption and were resumed on the same treatment failed significantly more than the others, supporting your final conclusion.
Regarding the follow-up of the patients, the 70% they were followed up for the 70% number comes at the end of 3 months from the initiation of their, when they were referred to us. So once a patient is referred, that's the time we start, and after 3 months we check for the, after baseline viral load and 3 months of enhanced adherence counseling and on second line regimen. At the end of 3rd month we do a repeat viral load, and that's where the 70 and the 30% have been differentiated. We do have access, so after this 3 months, for all those who had not been suppressed, we had done the genotype. Not all, some had earlier genotyping. Some patients actually had a substantial amount of time that they were taking darunavir or raltegravir or some 3rd line regimen, so we actually could not shift them back to a 2nd line. So we continued a 3rd line regimen for such patients. And regarding the difference between these two cohorts, I do not see any major difference as such, but it's mainly, I think, the individualized counseling and the support that they receive. We have peer educators and counselors who see to it that they prepare a good individualized treatment plan and everything, which actually made a difference to identify who are actually failing and who are not failing. Also, mainly the referrals are based on either clinical or immunological failures and not virological. Not all referrals are with a virological failure. So even this makes some difference between these two.
If there are no more questions, then thank you all. Thank you, Dr. Milind, Dr. Lakshmi, and Dr. Sanjay Pujari.
Thank you, speakers and co-chairs. I would like to request Dr. Glory Alexander. I would like to request Dr. Murugesh Pastapur to kindly felicitate Dr. Sanjay Pujari with a We will now proceed.
So if anyone does not know the Stanford HIV sequence database and is interested in HIV drug resistance, then please go to that website. It's probably the best source in the world for anything related to HIV drug resistance. And the reason it's here is because last week they had replaced their website. So this is the new visual website of the drug resistance database. And that's probably the most important thing in the world of HIV drug resistance. So I just wanted to start with that. What I'm going to do is I'm going to review drug resistance data that came out of India in the past year to show the new research that's going on. Then I'll talk about a new technology for drug resistance testing that I think is a recent improvement and will definitely be relevant as we move forward, and that's next generation sequencing. So I'll review some data as related to that, and then I'll finish with incorporation of drug resistance testing into clinical care and research limited settings. We've been discussing up to now a little bit about it, and I'll review some recent information that's related to this. So starting with review of the literature in the past year from drug resistance in India, and I'll talk about it throughout the timeline of HIV treatment and resistance. So we're talking about transmitted resistance in naive people before they start treatment, then people that fail first line and develop first line resistance, and then people that fail second line and develop second line resistance. And we've heard some recent data that's related to this. So transmitted drug resistance, and I'll move a little bit quickly. I'll make just the important points that are relevant to this, but these studies have a lot more information in them. So transmission drug resistance from recent research in India shows basically low levels. Here's one study from Pune that found in 52 people, most of which were subtype C infected, 3.8% drug resistance. 2 people out of those 52 had single mutations for the NNRTIs, and the recommendation was to continue surveillance when individual testing is not feasible. A second study from the past year was from South India with Anita Shet's group looking at data from Bangalore, from Mysore, and from Chennai, and again found a little bit higher, but still considered low because it's less than 5%, 4.3% in a large cohort of a little bit less than 600 patients, again showing a little bit of NRTI and NRTI resistance. So it's still considered to be low level. And then the third study that I found from the past year is from Kanchipuram in Tamil Nadu, and they looked at 36 people and found 2 people that had transmitted drug resistance with 5.6%. So the reason I'm pointing a question mark is because 5% is the cutoff between low and maybe intermediate level. And I put in at the bottom of the slide the mutations that these 2 people had, and I would say that because the first person had 4 drug resistance mutations, we can question the fact that it is transmitted, because this is a lot of mutations to be transmitted, and there was not enough information in this paper to figure out how much research they did about whether this patient was previously exposed to antiretroviral therapy, and this is why the question mark is there. But if this is true, then it's definitely sort of a trend upwards based on the prevalence that I've showed you up to now. Quickly, this is a transmitted drug resistance global view showing from large amount of studies, 287 studies, more than 50,000 sequences in individuals globally, showing an increasing trend in transmitted drug resistance. This is on the left in sub-Saharan Africa. You can see up here that there's a trend of increasing drug resistance. The x-axis is time since treatment was started, and the y-axis is prevalence of transmitted resistance, and the size of the circle is the size of the study. This is not seen, at least in this data set, in data from South and Southeast Asia that included some data from India. You can see that the line here is even going down.
We can discuss why that is, but we're not going to do it right now. But I think the bottom line is that surveillance is definitely needed, as in some locations, transmitted drug resistance might be increasing. Then really quickly, the impact of transmitted resistance, we all know, is not good, meaning if you have transmitted resistance and are put on treatment without the knowledge of that, you will fail more. And we showed this in the 5175 ACTG global trial in multiple subtypes in India, had 2 sites in Chennai and in Pune that enrolled patients to this study, but showing that pretreatment drug resistance impacts treatment failure. So moving to first-line resistance study in the past year in India, bottom line is they all show that there's a lot of resistance when people fail first-line, and we talked about it yesterday in the discussion. And so in this study from Tamil Nadu and a little bit over 200 patients, they found around 90% of drug resistance, NRTI and NRTI, which is very high. And there was a little bit of a tendency to have more resistance when people were on nevirapine-based regimens compared to efavirenz-based regimens. A second study that relates to the talk from Nari that we saw in the previous, or 2 sessions ago, I guess, about the 12-month treatment follow-up done in 2014 in about 80 patients. They also found high-level first-line resistance. Here it was 79%, again with high levels of NNRTI resistance, a little bit lower level of NRTI, 59%, with a very high level of K65R, 53% in people who were receiving tenofovir-based treatment. And they also found high levels of multi-NRTI resistance, and the bottom line is that linkage to care, viral load monitoring, and adherence are extremely important in order to minimize this first-line drug resistance. Another study from the YRG Care group, again, found very high levels of people that were failing tenofovir-based first-line. Here it was 90% resistance with high levels of NRTI, NNRTI, and dual drug resistance, 71%. And one of their conclusions was that AZT it's supportive of the data that AZT is a good second-line NRTI, like the guidelines say after someone has been exposed to first-line tenofovir-based first-line failure. Another study from the Chennai group, again, found high levels, 94% of first-line resistance. This is in people who are on AZT-based first-line treatment, which is an alternative first-line recommended regimen. Again, high levels of dual-class resistance, 75%. And they also looked at an aspect of accumulation of drug resistance, and they found limited accumulation of thymidine analog mutations. And we can talk more about this, but there's an interesting discussion in the paper of why that might be. And then I think this is the last first-line resistance study from Manipur. I put very in parentheses because they actually summarized it as high resistance, but it's a bit lower than what I've shown you up to now. It's 53% resistance in 76 people, and I think it could be discussed further why that is. There wasn't too much information in the paper, but whether adherence was an issue or other factors, it's questionable. Again, just a global overview. The study was mentioned yesterday about the tenofovir-based first-line people who failed with high levels, in this case 57% of tenofovir resistance. Bottom line is this high-level resistance is existing globally after first-line, justifying further surveillance of viral load and drug resistance. And then lastly, second-line resistance. There's not a lot of information about this. I found one study from Varanasi that in very small number of people, 16 people, showing high level, 50% of major protease resistance. This is higher than reported in other locations. There was another previous study a couple years ago from Chennai showing almost as high PI resistance in second-line failures. And again, this could be a topic of a talk in and of its own of why that might be. But those people were also failing with other high-level resistance to NRTIs and NNRTI that was probably carried from first line. But the good news is that 88% of those people were still susceptible to darunavir, which would be, as we heard, a third-line option, which is a good one. This was not a second-line resistance study per se, but I just added it since it talked about the feasibility of rilpivirine in treatment in India. And without going into too many details, this is from Bangalore and a large number of patients. They looked at the rilpivirine use, and a couple of their conclusions was that primary resistance is rare, but whether one wants to think about rilpivirine as first line, we'd have to be cautious because viral load at baseline seemed to be higher in India compared to other settings, and you can see the graph on the right. I think India, this is showing viral loads at baseline, and if I can get the pointer, this shows India. And you see that as compared to other settings, the viral load is higher. And what the reason to that can be discussed, but the bottom line is that since it might be higher, rilpivirine might not be a great consideration for first-line failure. But what they also did is they compared different mechanisms of subtype C versus subtype B and found that rilpivirine might not be as good as a drug for subtype C compared to B. And as we all know, subtype C is the main subtype here. So that's an important consideration. And so their bottom line is that if we're thinking about rilpivirine as a experienced patient drug, it could be useful, but we might need resistance testing in order to incorporate that. Okay, so that was a quick review of the last year in research in drug resistance in India. Now let's talk about a new technology, or relatively new technology, that I think would be important as we move forward, and that's next generation sequencing. So we talked yesterday about drug resistance testing, including Sanger and point mutation assays, which you'll hear more about in the talk after me. We talked about two aspects of Sanger sequencing. One is that we get full sequences with a full list of mutations, and another one is that it's very limited in its sensitivity, if you remember, meaning it can't get those minority variants. Next generation sequencing will cover both of those. It could give us information about all the viruses that exist in the patient's blood, including those that are minority variants, and it will give us the ability to look at full sequences, even though it's not going to give them all at once. It'll give us small pieces of those sequences that if you put them together, you'll get a picture of the full sequence. So I'm not going to talk about the technology of it in and of itself. It's becoming more inexpensive. It has numerous applications into what we're talking about, which is drug resistance as well as others, and it can definitely detect minority variants and show us the quasi-species, as we call them, of the viral variability and diversity in a patient's blood. There are different reviews of the incorporation of the next generation sequencing. This graph shows the decreasing cost of per genome for using next generation sequencing, which is pretty incredible as far as the decrease, and I think that will even go forward lower as we go forward. Very hard to control the pointer, but this graph shows the increasing number of studies that incorporate next generation sequencing in HIV, and the majority of those studies, as you can see here, were on HIV drug resistance, but not only. So just to make the point that this is an important and evolving technology. It can detect drug resistance below the level of detection of Sanger, which is represented here by the green line. And you can see here in the circles the different mutations that were detected at lower frequencies using a very high coverage, which is shown here in black, a very high coverage of this diversity, intra-patient diversity, which is feasible by this very sophisticated technology. A few studies that incorporated this and this study shows basically that NGS can improve resistance detection. It's a study from France on multiple subtypes, and NGS was able to detect many more clinically relevant mutations as compared to Sanger. There are different studies that compare the different platforms for next generation sequencing. There are a few platforms, and they each can have different characteristics. Here are the different platforms in the top and the different characteristics that we can discuss about what is good in which scenario. You can talk about the different amplifying method. You can talk about the read length.
You can talk about different aspects of these, and everyone that's considering incorporation of this technology should take those things in mind. But they were all able to generate very usable, very good data, and some key differences might be needed to take into consideration when we're thinking about it. Now, there are different challenges when we have these new technologies. And again, without going into a lot of details, those challenges can lead to errors when we interpret this very large amount of data. For example, when this group from Switzerland did an assessment of how many sequences that could be built into a full sequence from these small reads are real versus those that derive from error, the real sequences based on this data that was made from plasmids where they can really look at those errors. Basically, the top part of this slide is are the only sequences that were real, and the bottom part of this slide are sequences that were basically a result of different errors, making the point that we got to be very careful when we have these new technologies that are introduced, and we want to interpret what we can from them. And there are different methods to do that. This is a primer ID method that, again, without going to a lot of details, basically marks every one of those sequences that we put in order to make sure that what we're seeing when it comes out is a real sequence from the patient as opposed to some error from the process in and of itself. And this is still evolving. Lastly, I want to talk about the incorporation of drug resistance into clinical care globally and in India, and I think that's a very relevant point, which I think we heard about from past sessions as well. So this could be related to it could be to Sanger, which we talked about. It could be related to point mutation assays, which you'll hear about in the next session, in the next talk, and to next generation sequencing. So this study from India basically developed a lower cost drug resistance genotyping ability for local labs using Sanger sequencing. And they showed that it was much more cost effective, and if that is incorporated into the life here of patients in Kenya, it can improve drug resistance interpretation and drug resistance testing, and that's been done previously by the Chennai group a couple of years as well. So this is good news. How about incorporation of next generation sequencing, which I just discussed with you, into clinical care? So this group from Canada basically looked at a way to incorporate this technology using hundreds of samples at once in order to come up with a good representation of drug resistance in patients. And they were able to have a large percent of success, showing that this can be done. There was great concordance with conventional tests, and they suggest that this could be a very widespread way for widespread individual testing and regular surveillance of drug resistance testing. And the similar concept was done here in India as well by Neogi's group. And they basically did the same thing. They developed a cost-effective way to incorporate next-generation sequencing into their pipeline in order to come up with drug resistance interpretation that could be cost-effective and be incorporated into clinical care. I think this is from their paper, and you can see here that whereas in population sequencing, or Sanger, there were a lot of undetectable mutations, those were detectable using next-generation sequencing, as well as detecting the frequencies of specific mutations, which is something that the conventional method cannot do. There are a couple of studies that looked at the ability of next-generation sequencing to predict failure better than Sanger. This is a group that did it in data from Spain, and they basically were able to show that this is an ROC curve, and if I can get the pointer, I can't. But what you can see is that data from next-generation sequencing were better predicted treatment failure than Sanger sequencing. And this did the same thing, or they were able to show the same thing, and not only treatment failure, but time to treatment failure. So the data that's very sensitive from the next generation sequencing, shown here on the left, was able to predict better than Sanger sequencing, shown on the right, the time to failure, which is, as we know, very important clinically. This basically did the same thing from Uganda, making the same point. Another important concept when we talk about the ability to incorporate drug resistance testing into resource-limited settings, including into India settings, is the ability to get samples from the patient to the lab. And so these are just pictures of a few methods that tend to either dry blood spots on the upper right, or sample tankers on these two pictures, or HEMA-spots, which are new versions of the dry blood spots that enable us to quickly get with a pinprick in the latter two options, samples from the patient to the lab in a very cost-effective and quick way, and maybe can help incorporate drug resistance testing into such settings. So finally, to conclude, transmitted and acquired drug resistance is a major problem for patient care in India and globally. I put transmitted parenthetically just because of this trend that we're not seeing yet here of increase, but there is a concern that this will happen as it happens in sub-Saharan Africa. Continued resistance surveillance is needed, particularly with changes in treatment and monitoring, and we talked about viral monitoring a lot and its direct association with increased drug resistance. Existing and new technologies for drug resistance detection are promising. We discussed some of them and should continue to be evaluated and developed. And in my mind, incorporation of drug resistance testing into clinical care using these new methods will be inevitable. So I thank you very much for your attention.
Some questions I do have, but we'll have it at the end of the
Why should we really care about resistance? And I think that, compared to CD4 monitoring or viral monitoring, the idea of implementing drug resistance testing can actually be quite polarizing. So, I mean, the reason that I personally care about resistance testing is that I have spent almost 10 years working in Botswana, and they have one of the highest HIV incidence rates and prevalence rates in the world. And back in 2012, we were performing a standard surveillance study on transmitted resistance, and the population we were using were young, pregnant women who were coming into the antenatal clinic. And back in 2012, we found that less than 1% of the women who were coming into the clinic actually had pre-treatment drug resistance. And that single individual, her name is Tassila, she was switched to second-line therapy because she had resistance to the first-line drugs that were given to her for PMTCT. And because of her resistance, they probably wouldn't have worked. And she was only genotyped for resistance because she was part of our research study, and because of that, her son Felix is HIV negative today. But it got us thinking, there are plenty of women out there like Tassila who go to the antenatal clinic, find out that they're infected with HIV, and get first-line ART for PMTCT. But they don't get a resistance test. And then in 2014, 2015, we saw a huge jump in transmitted resistance in the same population in Botswana. And this year, it's almost 10% of women who are starting ART for PMTCT already have resistance to one or more of those drugs. So that was really the impetus for designing the technology that I'm going to talk about, which is PANDA. Now, this is a slightly old number, but I think we are still enabling access at a very similar rate. This equates to almost one person every 20 seconds who's starting ART. But one of the biggest issues is that 80% of those people who have access to ART don't have access to drug resistance diagnostics. And there are really three compounding factors associated with not having access to resistance diagnostics. The patient lives with unmanaged HIV for a very long time. There's a greater risk of them transmitting not just HIV, but drug-resistant HIV to others. And we saw from Dr. Cantor's talk there that transmitted drug resistance is on the rise. And healthcare resources are wasted on inefficient patient drug matching. So patients who don't have access to drug resistance testing are on the wrong regimen for an extended period of time. They're having to go back to their physician, get repeated viral load testing, and that takes up a lot of scarce resources. And we've known for almost 20 years that resistance testing can guide optimal treatment selection. This is from 1999, showing two different patients, one that received a genotypic resistance test and one that completely suppressed on their first regimen. So why 20 years later are we still trying to figure out how do we get those other 80% of people access to resistance diagnostics to give them complete optimal care? So why aren't we doing resistance testing? And one of the major factors is that the cost of implementing resistance testing at its current price point is equal to the amount of funds that are wasted on the drug-patient matching. So I know I can appreciate that ART is somewhat cheaper in India, but this is from an MSF a couple of years ago showing the median first and second line costs. And resistance testing has a median of $300 per patient. So for $300, you could either give one patient a resistance test and put them on their optimal therapy, or you could supply 2 patients with first-line treatment for a year. So there really is no economic incentive at the moment to implement resistance testing in resource-limited countries. So how can we address this? Dr. Cantor spoke quite a bit yesterday about point mutation assays, and he linked into Bob Schaefer from Stanford, his work on what resistance mutations really matter during first-line failure. So if you can look at a Sanger sequencing, you get a lot of information, but really for first-line failure, there are only 6 resistance mutations that matter. And these 6 resistance mutations can allow us to really focus the genotyping and that way design a much more optimal test for resistance. So with point mutation assays, even though they're much, much more sensitive than standard Sanger sequencing, they still haven't really got to a point where they've been implemented clinically. And some of you might be familiar with a very old technology that's still in use called real-time PCR or qPCR. You know, it's the foundation technology for viral load testing and a whole host of other genomic tests. So the way qPCR works is that you generally have a probe and it will bind to its target. So this example here is perfectly bound. And what happens is there a complete match between your probe and your target, you get fluorescence and you can detect that fluorescence. And if there's even a single mismatch between your target and your probe, the probe won't bind, there's no fluorescence, and therefore you get a negative result. So in resistance testing, it would look something like this. You measure the amount of fluorescence over time, and in a positive sample, you get high fluorescence, and in a negative sample, you get the same as the baseline. So that's the basic premise of qPCR. So why have we never implemented it for HIV drug resistance testing? And the problem is that, you know, HIV is a moving target for sensitive diagnostics like qPCR. In a single individual, it's always changing, mutating, and that's the primary reason why we've never been able to implement qPCR in such a manner. So here I've taken a very well-known drug resistance mutation for the K103M mutation for the verapamifavrins and NRTIs. And that resistance mutation is coded by an AAC. So in the perfect scenario, you have a probe that matches your AAC drug resistance, you detect the fluorescence, and you say, yep, resistance is present. But in the real world, HIV is constantly changing. So even if your drug resistance mutation is present, there are going to be other mutations not associated with resistance, but natural polymorphisms around that AAC, so your probe won't bind. And this results in a whole host of problems. You know, we have 30% of patients would end up with a false negative result, which isn't acceptable for any sort of clinical diagnostic. And if you look at the 103, the region around this 103 mutation here, you can see there's a whole host of mutations that would really prevent the probe from binding. So as I said, those 30% of patients, even if they had resistance, an assay would say no. So pan-degenerate amplification and adaptation, or PANDA for short, is a way to circumvent that problem of these additional mismatches, these additional natural polymorphisms present in the HIV genome. And I'm not going to go into too much of the technical detail because I appreciate that a lot of you are clinicians and are more interested in the implementation, but what PANDA does is it strips out all of those additional mutations that I just showed you. So what it will do is it will actually mutate the HIV genome so that it matches your probe. And the net result is that even if you started with a patient sample that had lots of mutations, you end up with a patient sample that's going to match your probe. So to put it in the context of all the sequences I just showed you here with all of these different mutations, those 30% of patients through 2 through to 11, what happens is that Panda just gets rid of those additional mutations. So those 30% of patients that would have been a false negative can now successfully be genotyped by Panda. So how do we implement Panda as a clinical diagnostic? It did start off as a research tool. It was developed when I was at the Harvard School of Public Health, and it's now morphed into a startup company called Aldatu, so that we can provide Panda to first and second line treatment failures. So Panda is a kit. It plugs into existing real-time PCR machines that are usually ubiquitous in centralized testing laboratories. And what Panda can do, it can look for those 6 resistance mutations I said at the beginning that can be found in over 99% of patients failing first line with resistance. It acts as a confirmatory viral load, and I'll explain more about that in a moment. And it can detect resistance when it's present at 1% or more of the virus population. In terms of the implementing it, we can genotype 24 patients in 2 hours. It's very affordable. We've designed it to be thermostable, and it's completely subtype independent. So some commercial Sanger sequencing kits, such as VirusSeq, have had issues with non-B subtypes and failure to genotype there. So Panda has been specifically designed to be subtype independent. So it's one kit that can be used anywhere in the world. And one of the issues we've also tried to address is how can we make it as user-friendly as possible. If anyone in the audience has ever done Sanger sequencing for resistance testing, or even just sent a sample for resistance testing, you know that the turnaround time is quite long. The workflow for Sanger sequencing is between 2 and 3 days to get your results. So we really wanted to get to a point where we had a sample-in, answer-out approach to resistance testing. So this is the workflow I was talking about. This is Sanger sequencing at the top and Panda down the bottom. So there's over 95% reduction in labor time. So the cost saved not just in buying the kit itself, but actually implemented it in terms of labor and overheads is greatly reduced. So one of the biggest barriers to cost-effective drug resistance diagnostics is the need for the cold chain. So shipping the reagents on ice, storing them in a fridge, so on and so forth. So it comes with enzymes, buffers, primers, probes, and most of these have to be stored and shipped at -20. And that was one of the first barriers that we wanted to overcome when translating Panda from the lab-based test into the clinical diagnostic. And what we've done is we've worked with a couple of manufacturers in lyophilization and thermostabilization, and we've turned Panda into this. Hopefully you can see it, but at the bottom of the tube there's a very, very small pellet. And in that pellet it contains all the enzymes, buffers, primers, and probes needed to do a viral load and detect 2 resistance mutations. So one patient would have 3 different types of those, we call them lyospheres. And that's completely thermostable, so it can be shipped at ambient temperature, stored at ambient temperature, and then just taken off the shelf when you need to use it. And this is the sample-in, answer-out point. So this is a 96-well plate with a lyosphere at the bottom, and it would be just a matter of pipetting in the patient sample. So once you purify the viral RNA from the patient plasma, you just add it to 3 different wells, which covers 6 different resistance mutations, and then you place it into your PCR machine. So that's second step there. So once the 2 hours is completed, because it's a quantitative assay, you can actually get an automated viral load and resistance report. So Sanger sequencing at the moment requires a technician to go through the sequence, check for sequencing errors, make sure that the sequence that is reported matches up with the data. But with Panda, because it's quantitative, there's an automatic translation, and there's no need for the end user to have to do any interpretation. So how does it perform? So if you remember the qPCR slide I showed earlier with the fluorescence versus time, in Panda, I said we detect a viral load. We call it a viral quantifier, and we use that not just as a control to make sure that there's HIV RNA present, but also as a way to do the quantification of drug resistance. So for those of you not familiar with real-time PCR, what you do is you look for a particular level of fluorescence and then ask, how long does it take to get to that level of fluorescence? So the higher the viral load, the earlier a particular fluorescent signal will appear. And here I'm showing you a 4-log range from 100,000 copies down to 100 copies. And you can see that as you have less HIV RNA, it takes longer for the reaction to get there. So how do we translate that into drug resistance detection? So here we have an example, 10,000 copies of viral RNA. Same principle. And what we see is the resistance signal comes up at the same time as the viral load, the viral quantifier. If we can say, okay, this virus has 100% K103 and 100% M184 V or I. Now, we don't differentiate between the V and the I at the 184 position because clinically there's no real relevance in knowing which it is. So by reducing it to both, then we can save time and space. Here's another example. We're putting in 1,000 copies, and here I'm showing that we can actually detect resistance at 10%, so 100 copies of RNA. And then a couple more examples. This is one where we've mixed it up. So this particular patient sample has 100% K103N, but only 10% of the 184. And then on the flip side, we have 1,000 copies, or 100% of the 184 resistance mutation, and 10% of the K103N. So when would this become available? So we're a very, very small company. We're a startup formed out of Harvard. There's only 5 of us. And we're all scientists by training, but thankfully we're very generously funded by the NIH. And we focus a lot on NIH funding because it allows us to keep our costs as low as possible. So we're in a phase now where we are piloting Panda, hopefully moving into Botswana and Tanzania in the next few months to see how it really performs with the end user. And then by this time next year, scaling up and hopefully getting it to clinics. So the first iteration that we're working on, as I said, is for first-line failures. But we recently just got funding from the NIH to translate Panda into a clinical diagnostic for second-line failures. So that would look for 2 NRTI mutations at the 65 and the 184 position, and then 5 protease resistance mutations as well. The biggest question about Panda is probably, that should actually have the symbol for rupees, but I guess that's failed. The question is, how much is it going to cost? And the answer is I don't know, because what we're trying to do is keep the cost as low as possible, but make it cost-saving or cost-efficient for a particular national program or country to implement. So to explain that a little bit better, a lot of work has been done in South Africa trying to determine if resistance testing could ever be cost-effective. South Africa has one of the highest absolute number of patients, both on ART and with HIV. And they've shown that if a resistance test was under $100, it would be cost-saving to the national program to implement. And the reason for that is, and to go back to Dr. Cantor's talk, he showed the prevalence of resistance at first-line failure in India, and it ranged from upwards of just under 60% all the way up to 90%. But between 10 and 40% of those patients that didn't have resistance, they would be switched to second-line treatment without a resistance test. But they have adherence problems. So some of the biggest cost-saving benefits from a first-line resistance test isn't actually identifying those with resistance, it's identifying those without. And I think the average or the median is around about 30% of patients are currently switching to second line, which is much more expensive, 3 or 4 times the cost, when they have adherence problems and no resistance whatsoever. So that was what was shown in South Africa. If you could prevent 30% of people from switching to more expensive second-line therapy, you would save South Africa $125 million over the space of 5 years. So that's about 10% of their HIV budget, and that would put over an extra 500,000 people on treatment for a year. And more recently, they've shown in Brazil as well that if you do pre-treatment resistance testing, because transmitted drug resistance is on the rise, the more people that have access to treatment, the more transmitted resistance is going to increase. If you implement a pre-treatment resistance test before first line, it would actually save a country like Brazil $10 million a year. So they're paying for a resistance test and it's saving them $10 million, which isn't something that happens very often in diagnostics. So I'm going to leave you with a question. And I've learned a lot while I've been in India over the last few days about how the treatment system works, and that it's really the patient here that's paying for their own care. So if it is the patient that's paying for their treatment monitoring, how do we prioritize diagnostics? If we were to introduce resistance testing, is there something that has to give? Would CD4 monitoring still be necessary? At what point can we fit in resistance diagnostics to make sure that these patients are on the right therapy at the right time? So I'd just like to end by thanking the organizers for the invitation to speak, particularly Dr. Gulada. And as I said, a lot of this work was done at the Harvard School of Public Health, where I had an absolutely phenomenal postdoc, some of you might know, Tripti Gulada. And as I said, Aldatu Biosciences is a small team. There's just 5 of us, but we hope to grow in the future. So thank you for your attention.
Thank you, Dr. McLeod, for a
sort of comment would be that I think that viral load monitoring is clearly associated with it, meaning if we would be able to monitor virologically close, or even in general, as much more viral load testing as we can do, we could hopefully identify those patients earlier when they still have only M184V, and then the impact will be less. Phenotype, my main answer is cost. These are usually much more expensive tests, and they usually are needed for patients who are much more treatment experienced, that have much more treatment drug resistance mutations, and therefore the interpretation might be more difficult. And though there are emerging tests that try to incorporate phenotypic resistance at a lower cost, this is still, I would say, not the case. So I think when we talk about resistance, genotyping is still the way to go.
Thank you very much. We will have questions from the floor.
We have started a program, Indian program of NACO with stavudine-based or zadudine-based regimes almost 10 years back now, on 12 years now. So they are failing now. So, but there is, you have shown the study only for the M84V or K103. So there is no TAMS studies over here. What about TAMS in the as mutations in anywhere in the? Is there a study TAMS mutations?
So you're asking if TAMs occur or if they are important?
Or any study doing the TAMs, because you show only K103 or M84V 10% and 50% like that, but nowhere is the TAMs are in the resistant testings.
So if I understood you correctly, you're asking about D4T based treatment, is that right?
D4T or Z, AZT.
Or AZT, right. Yeah. So yes, TAMs do occur in D4T or AZT-based treatment, and if you wait long enough, you can accumulate enough TAMs that will even impact tenofovir. That's rare, but it does occur. So yes, studies that are on D4T-based or AZT treatment show accumulation of TAMs, and the longer you wait, the worse. I hope that answers your question.
Any studies are there on the TAMs? That's a studies on TAMs.
There are multiple studies. Every study that would have an AZT or D4T-based treatment and look at failure and resistance will have accumulation of TAMs. These are the most common mutations that accumulate when you have D4T or AZT-based treatment. So there are multiple studies, including from Kenya. I think I showed one from the past year on AZT-based from Chennai, but any study you would look at where this is the baseline regimen would have accumulation of TAMs. Perhaps it be together with NNRTI as well as with M184V, and perhaps they occur a little bit later and at lower frequencies, but they do occur.
Basically, one of the reasons for moving away from AZT-based regimen was to TDF was the reason that if you have accumulated TAMs, you may have K65 or also, and you may not really respond well to tenofovir. That is why we have moved away from a AZT-based regimen to a tenofovir-based regimen.
Some laboratories are giving us virtual phenotype resistance reports. What is your comment on that? How reliable is it?
Virtual phenotype. That's what you're asking about? Personally, I don't have a lot of experience with it. There are not too many studies, as far as I know, that have looked at virtual phenotype compared to real phenotypes. So my experience is limited. I know that a lot of European centers do use virtual phenotype, and they have good experience with it. I would say that from an Indian perspective context, the amount of subtype C infected people in general and Indian specific subtype C infected people that are in the database that is sort of the feeding information for the virtual phenotype are low. So that's but that's a limitation to think about virtual phenotype in the Indian context. But in the European context, like I mentioned, which the majority of the data are coming from, I think there are centers there that use it.
I don't see any other questions, but just to update, this issue is being taken seriously now. In India also, WHO has now supported NACO to actually write and clear a proposal and get the funding for drug resistance surveillance in India, in which we'll be doing PDR and ADR12 and ADR48, and 400 samples will be selected at 40 sites based on the WHO sampling strategy, and Dr. Ganga Khitkar at NARI will be conducting this study. And once we have the baseline surveillance, then it will actually decide on the individual drug resistance testing before initiation or initiation of second line or third line. I think this will be the last question.
Question is to Dr. McLeod. You know, when we get our genotype resistance testing done from Vyarji Care, Chennai, and it costs us about rupees 6,000 for NRTIs and NNRTIs, and rupees 8,000 for the PIs. So when you talked about Panda, you know, there seem to be so many advantages, but when it comes to cost, it's about the same that we are paying now. Just a comment.
This microphone on? Yep. 1,000 rupees, I believe, is $150. Would that be right? So, yeah.
No, $100 would be equal to 6,500 rupees. It's about 65 rupees to $1? 67 rupees to $1. So $100 is equal to 6,700 rupees.
Okay, that's one.
Huh?
So it's about $300, $400 maybe?
Yeah, it costs us $100 to do NRTI and NNRTI
Okay,
resistance testing today.
Yeah, $100. We would definitely be under $100. $100 is our upper threshold. The benefit being that you could possibly, if you have the equipment, do it at point of care, so you're not having to wait for resistance tests to be returned. Panda is also much more sensitive than Sanger sequencing, so you will detect resistance earlier. So those are the major benefits, and being able to do 24 patients at a time as well.
But in India, the cost factor is the most important.
Yeah, no, absolutely. If the patient is the payer, then...
The cost comes down with volumes also.
Yes, exactly. Yeah.
Thank you, both the speakers and the audience, for the active participation. And just a closing remark as a microbiologist, that resistance testing must be made widely available along with viral loads. And another point is all mutations that we detect in the lab by the molecular assays need not be interpreted as clinically relevant. And thirdly, there is a need for simplified and cost-effective ways of detecting resistance which is clinically relevant. Thank you.
Thank you, speakers and co-chairs. I would like and Dr. B.B. Rewari to please.
Everybody. Today we are going to have an interesting plenary session, and we have selected Dr. David had sent to give the plenary session. And I call upon Dr. David to come up to the stage and start his session.
Thank you, and it's always a pleasure to come to Asicon. I want to thank particularly Dr. Gelada for, again, giving me one of the more confusing mandates for a plenary session that I've encountered, which is negotiating the last 90 of 90-90-90. We'd really like to see, as many of the speakers have noted, 90% of people living with HIV on treatment achieve virus load suppression. My fear is that The Art of the Deal is the book supposedly written by Donald Trump, and he prides himself on negotiating. So I worry about that term as a means of expressing something. Let's see what I'd... Now, how do I advance? Right. Okay, so I think negotiating 90% suppression really means attending to the new phrase, virus load informed differentiated care. And that's become the way in which those of us who do simulations and modeling have advocated for the introduction of widespread use of virus load. Certainly, we've just heard Dr. Cantor and Dr. McLeod really talk about first-line virologic failures and switching to second-line failures being offered effective third line. And so I wanted to sort of tell you what I've been doing recently in Zimbabwe, which is certainly a very, very resource-constrained setting, to try and understand how we can achieve some of those goals. So this was the working group on modeling antiretroviral therapy monitoring strategies in sub-Saharan Africa, led by Andrew Phillips, large group of people who looked at simulations, and they asked the question, what's the best way to monitor patients that's cost-effective, bringing some of the concepts that Dr. McLeod was raising about what's the cost of monitoring and how much money does that save you in terms of survival of patients, dailies, and avoiding bad outcomes. And they came to the conclusion that, in fact, virus load differentiated, let's see, oops. So, no. Sorry, I seem unable to get the arrow to appear, but that virus load differentiated care using dried blood spots really represents a very effective way to be able to manage patients. They suggested that if the virus load is greater than 1,000 copies per mil, then that could provide the impetus for an intervention. They didn't feel that CD4 counts were necessary in terms of virus load differentiated care. That's where they saw some of the cost savings occurring if you switch to that. And they basically advocated for monitoring strategies that used virus load. I tried to simplify this or make it a bit diagrammatic. No. Sorry, I still haven't gotten the trick of the arrow appearing, but this is the concept of prevention as treatment as prevention, in which virus load differentiated informed care really consists of simply getting a virus load assay every 12 months annually, that there probably isn't a reason to do more frequent testing, that I use the red triangles to indicate the eventuality of encountering greater than 1,000 copies per mil, the green being less than 1,000 copies per mil. The notion that you always need adherence counseling, community support, social media, many of the cues and reminders that we've been discussing in order to keep people on therapy, keep them adherent, and keep them involved with their own treatment goes without saying. This notion of repeating after 4 to 6 weeks of virologic failure a second in order to obtain a confirmed virologic failure. And Dr. Cantor quite accurately described the fact that 50% or more of patients will in fact suppress if you simply give the right sort of impetus for adherence. Now, some of this was worked out initially a few years ago in Uganda, where they tried using dried blood spot samples for virus load testing, for virus load monitoring, and EID in resource-limited settings. And this was in a very rural parts of Uganda, and all the little red dots on the map of Uganda represent EID hubs. And then they had the Riders for Health who were bringing drug and collecting dried blood spot samples, returning these to a central lab where a very high throughput QIAGEN Symphony, and using Cobas AmpliPrep, they were then able to process those dried blood spots and in fact showed, and this is the lower left-hand corner, that in fact virus load is really preserved quite well in dried blood spots. So this negotiating virus load informed differentiated care really means virus load monitoring of ART, and that's where you have to ask some very fundamental questions about the structure of how you're going to do that. Is it central high throughput versus near or point of care testing? Does the absolute level of virus load make a difference? There are people who are very concerned that the 1,000 copy per mil WHO threshold that's suggested for virologic failure may be inadequate or inappropriate. And how is virus load information obtained, archived, and transmitted? And that involves information systems that really ensure encrypted patient information being safely transmitted. So is the greater than 1,000 copy per mil WHO threshold adequate and appropriate? And I just happened to be working on a paper with one of my fellows where we're looking at a number of patients in rural Zimbabwe who had, in fact, virus load measured with Roche 2.0 using an entire mil of plasma. So we were able to So we were able to, in this column, look at the 15 or so patients who initially, do I have to have the menu there if I have the arrow? Apparently they don't seem to be independent. But this baseline virus load were 15 patients who had essentially had RNA copies greater than the lower limit of detection. We followed the same patients a year later on the same treatment and hit escape. Thank you. Well, okay, so this, no. Sorry, once you've converted to Mac, it becomes very difficult to use these primitive IBMs. Sorry. Anyway, the last column tells us that essentially a low virus load measured in a patient living in a rural area on pretty poor regimens, because you'll notice these patients, some of whom are actually receiving D4T, 3TC, and nevirapine, which is still quite prevalent. In fact, no one took off, no one escaped. There's no reason to worry about these low virus loads in terms of public health monitoring. So I think we're quite safe with the 1,000 copy limitation. So I wanted to talk to you a little bit about rural virus load monitoring in community-based ART in a rural village, a tiny one called Nyamutora, and this was data that we obtained in Zimbabwe from 2014 to 2015. Virus load measurements in plasma were in fact obtained. We also made dried blood spots, and we were sort of trying to make sure that the dried blood spots would give us accurate information about the Roche virologic monitoring. And we had 143 people enrolled in this village who were had been receiving ART for a median of 4 years. This year, I've had the opportunity to compare the Roche 2.0 to, in fact, Expert Quant, as that became approved for quantitative monitoring using the same kind of plasma. And hopefully, next year, we'll begin moving Expert to near point-of-care virologic monitoring. Just to give you a feel for how far this is from anywhere, this is a very, very rural area of northwestern Zimbabwe. Although it's only 200 kilometers from Harare, it takes you about 6 hours to get there because the roads are, let us say, quite poor for the last couple of hours. And the particular mission hospital, which is the district hospital, in fact, has developed what I think is a very radical approach to sustaining treatment in rural Africa, which is that they essentially prepare 3 months worth of medications for all 143 people in Nyamatora, and this is one of 8 centers that they go. So they actually have 1,500 people on treatment in which they make up those medicines. Then I hit escape, and I have an arrow. Thank you. Anyway, we'll have to endure this because at least I can control the arrow now. They load these medications into Land Rover, go to the site. There's a little preparatory speech by, in fact, the community counselor. And then essentially, yeah. Well, now we're back to the beginning. Yeah, now I'd like to see the show and be able to control the arrow with my finger. I don't seem to be capable of doing that, so, right? So now can we go forward to the slide we were on, right? Here, and now the, yeah, why can't we have the arrow?
So it's a picture, so it's a picture.
Yeah.
It's an image. You can't have the arrow.
I'm sorry. Anyway, so the technology of IBM arrows seem to be beyond me, but needless to say, there's really an extraordinary ritual of essentially bringing drugs to the people, and HIV treatment becomes a public event. This has remarkable effects on these communities in that essentially much of the stigma which we're concerned about, much of the fear that your neighbor is going to know your status completely dissolves because, in fact, the community actually receives their treatment all at one time together. And so this population had been on ART for a median of 4.5 years, and we did Roche virus load, CD4 Partec measurements at 3 visits to Nyamatora over an 18-month period of time. We drew blood and, in fact, brought it back to Harare, where we were in a central lab. We did Roche virus load testing. I hope next year to begin replacing that by doing expert virus load testing at a local laboratory. But I embarked on this because I was sure that this wasn't going to work. These people were essentially unmonitored for up to 7 years. There had been no virus load monitoring and only sparse CD4 monitoring. So I was very surprised that the virologic suppression rate was 96% in this rural area. In fact, only 3 of 118 adults had virologic failure, but it was clear that there was a problem with children, 3 of 17, or 18% of the children. So they made up, in fact, the majority of those who were failing. You can see here that essentially it was a 10-year-old, 17-year-old, a 5- and 4-year-old who were all failing viral therapy. There were only 3 adults, 34, 30, and 46. The regimens that they were taking were certainly not very sophisticated. And in fact, the mutations that they eventually had when we sequenced them were certainly the type that we would want to look for with a PANDA or other point mutation assay. So I really came away from this feeling that those at highest risk, the key population that we needed to focus on, particularly in rural area, were children and adolescents, and that they're the most vulnerable population for virologic failure and drug resistance. And this dovetails very nicely with work that we've been doing in Harare. This is Tariro Makazange, my colleague at Harvard and at the University of Zimbabwe, who produced a very nice look at clinical virologic immunologic outcomes and drug resistance patterns in children and adolescents in urban Zimbabwe. And it was very clear that the failure rates when among 600 children and adolescents were much, much higher than we were seeing with adults. And in fact, they were worse in older adolescents, so that these were clearly people who had difficulty taking drug and remaining adherent. The drug resistance mutations in children and adolescents were not wildly different from those that we see in adults. but it posed that problem of distinguishing non-adherence and wild-type virus from, in fact, failure with resistance. And this has been seen consistently around the world. This is Paula Vaz from the Fundación Ariel Glazer for Pediatric AIDS Foundation in Mozambique, who presented this very nice view of resistance in children and at their very high levels. So the most important negotiation is actually working with children and particularly adolescents. So this is the local counselor, a nurse midwife, who are talking to them really about sexual and reproductive health, about helping them understand what they're going through, and the whole issue of disclosure and counseling for, in fact, children and adolescents with HIV, I think is a fundamental place you have to focus in order to really achieve high levels of virologic suppression. The other issue that we've touched upon, which I think is really important, is switching to second line. And I'm going to try and point out some things on this graph with a certain amount of trepidation. Now if I hit escape, no, it goes away. Okay. Anyway, suffice it to say, so how do we get rid of the menu and retain the arrow?
Just double press it.
Great, thank you. We'll have to do it again next slide, I'm sure. But clinical monitoring achieves very little in the way of identifying patients who are failing and need to switch to second line. This was a compilation of studies throughout Africa asking the question, what kind of monitoring results in identification of first-line virologic failure and hence switching to second line? And it turns out, of course, that confirmed virologic failure actually occurs at about 3% per year, even in a highly adherent, well-managed population. This is saying that if you do one virus load a year, you're going to end up with about a median of 3 people per 100 people on first-line therapy. Over 5 years, this gets you a rate of second line, well, it's up to 15% by 5 years. And that is the idealized way we should be, in fact, switching to second line amongst virologic failures. So one of my students there produced a very nice small study, but it was an adherence intervention to identify drug resistance among HIV-positive adolescents who are failing second-line therapy at a public health clinic. Tariro Chiwana presented this in South Africa at the International AIDS Society, and suffice it to say that she compared the standard of care, which is essentially self-administered treatment with adherence counseling at the clinic, to what was called MDART, which was a modified directly observed therapy in which actually a community counselor came to the house 5 days a week to directly observe therapy, look at the family situation, talk. It was essentially a very intensive adherence intervention, including SMS texts on the weekends when, in fact, we couldn't employ a community worker to go to the house. And what happened was, in fact, there was a major increase in suppression of very small numbers, I'll warrant you, but we went from 18 people who had virologic failure to only 9. There was a 50% rate of resuppression, essentially, with an aggressive with an aggressive adherence counseling methodology, as opposed to only 2 out of 15. So if you work very hard with adolescents failing second-line therapy, you can get many of them resuppressed just by making sure they take drug. There were fascinating pieces of information about what kind of PI mutations occurred. The PI being used here was atazanavir ritonavir, and in fact we had 2 people with documented high-level atazanavir resistance, but everybody, or 80%, had very high-level NNRTI resistance, which is typical for second-line failures, and why it is that they carry these NNRTI resistance mutations for 2, 3, 4 years after they have gone off of first-line therapy is really one of the things we have to understand in order to craft adequate treatment for these people. The second study in Zimbabwe, which I'll just go through quickly, was genotyping 86 second-line failures who were referred to a clinic, which was in fact a national reference center for this. And my job was to help them develop low-cost genotyping. So we have actually been able to get genotyping very similar to that which is performed at YRG for about $100 for a full genotype. But the people who are failing people with HIV and AIDS on second line atazanavir or ritonavir were referred for virologic failure and consideration of third line. The fact that the median age was 20 tells us that this is, again, a problem with adolescents and with children. Half of them were women, actually girls, 55% were unmarried, so these are young people who are in fact have been probably infected at birth, have managed to survive into childhood, have gotten treatment, now are on second line and are failing. The median CD4 count was 201. They were pretty viremic with a median RNA copies of 53,000, and they had been on ARTs for 7.7 years, 4 years on first line, 2.5 years on second line. So these are the very experienced patients where I think genotyping is going to be helpful. And these are the kind of virologic kind of mutations that occurred. As we can see, many had TAMs in answer to the concern expressed last time, high levels of NNRTI mutations, but only half of them had any PI mutations. So again, this is typical of second-line failures. When you look at genotypic susceptibility to determine a third-line regimen, you in fact can identify darunavir as the drug you want to be using. These patients were in fact treated with darunavir plus raltegravir. We've now switched to dolutegravir, and of 30 patients who've been followed about 6 months, all of them are being adequately suppressed with darunavir, raltegravir, or dolutegravir, plus generally Truvada was sort of thrown in as a third and fourth drug. So in terms of maintaining suppression, treatment for these second-line failures, I think really requires genotyping for some of the reasons Dr. McLeod indicated, that you don't want to provide very expensive third line to people who still have options. But genotyping demonstrated multi-drug resistance to all three classes of drugs. And these are the people who were, through our treatment efforts, in fact now generating this multi-drug resistance, and we really want to be able to recommend a rescue or salvage regimen that appears to be darunavir, ritonavir, an integrase inhibitor, and 2 NRTIs, which looks to be very effective. So I'll just conclude by saying diagnostics is a critical element in the whole treatment 2.0 and treatment as prevention, that monitoring with virus load assays really is important, and then I think we need to begin thinking about how to provide those as point-of-care assays so that the information can be fed rapidly back to the patients and providers rather than the long loop that we've seen in South Africa, where you have highly centralized National Health Service labs. Drug resistance assays really help you optimize drug treatment regimens, and it's only by really aggressively suppressing people that we can prevent transmission and end the HIV epidemic. The challenges where global markets for HIV diagnostics are not really being met, and I think they're the bottom two, which I won't try and point to, but late switching to second-line ART due to limited access to virus load testing to identify first-line ART failure is really a critical need, and I think we're now seeing national programs gearing up to ask how can we identify virologic failure. And late detection of resistance due to virtually no access to drug resistance testing at an individual level is something which we hope to end. So hopefully this is the beginning of the end of AIDS, and I will gratefully acknowledge all of the people who helped me, but I don't have the slide with all of their numbers and I couldn't point to them. So I'll just thank you for your attention and stop standing between you and lunch. Thank you.
Thank you, David. It was very nice to hear. Yeah. It was very nice to see a presentation on what perhaps entails if we have to achieve the last 90% milestone. it is also becoming perhaps apparent that it might be very difficult to maintain 90% level if the new patients who are coming into ART program, they tend to fall in numbers because by 4 years itself, the 10% have already failed, those who started in last. So it could be a big challenge, and we need to address the issues of introduction of viral load, which is being contemplated in India, at least for second line monitoring. First line monitoring, we perhaps may be doing it annually pretty soon once we scale up the program of viral load offer. And drug resistance testing could be useful in the program setting even if we belong to less developed countries group. We thank you for your inputs that you have given. Since this is a plenary session, we won't have questions.
Thank you, Dr. Katzenstein, and thank you, co-chairs. We now request Dr. Ganga Khedkar and Dr. Ravindran to kindly felicitate Dr. Katzenstein with a token of art. Thank you, everyone. We will now...
Physiology, like once the HIV enters the human body system, there will be a brief viremia, and during this brief viremia, the HIV, enters into the variety of compartments, which some of them are sanctuary sites. Of importance are the cellular compartments like the CD4 cells, especially the latently infected CD4 cells, macrophages, and the dendritic cells. And few of the compartments are termed as an anatomical reservoir, and of all these, the anatomical compartment, the brain and the genital tracts, these are the two very important the compartments where we need to address and we need to focus when we are talking in terms of the cure of HIV infections. The other compartments are the lymph nodes, the gastrointestinal tract or the gut, and spleen, lungs, etc. So let me take you to the cellular compartment, how the HIV harbors and hides into the cellular compartments. We know that like when somebody is having HIV infection, the daily turnover of HIV virus would be in the tune of 10 billion copies a day. And these highly replicating viruses, once you put them on anti-HIV medications, the 99% of the replicating events will be controlled within 2 to 3 weeks of putting them on anti-HIV medications. So the remaining, the 1% of the pool, which constitutes this, the reservoir or the compartments. And these are the slowly decaying compartment. And the most important here would be the free virus, which is extracellular, which lies on the surface of the follicular dendritic cells, which is very difficult for antiretroviral agents to target because the ART drugs will not act on the extracellular free virus which is adherent or which is overlying the surface of the follicular dendritic cells into the lymph nodes. The latently infected CD4 cells, we know that these cells are not replicating, so the drugs are not effective. So this is another very important the cellular compartment where we need to focus. And the macrophages, of course, these are the very important the cellular compartment in HIV. So let me take you to the macrophages. Like these macrophages, they releases the virus slowly during the lifespan of the macrophages. And the important differentiating features between macrophages and the CD4 surface cells is that the macrophages, they escape, they are resistant to the cytopathic effect of the replicating HIV or the HIV infection, where we know that the infected CD4 cells, they die during the process of replications and the emergence of the virus from the CD4 cells. Though number of infected macrophages are low, but it plays a very important role in the HIV pathogenesis. And it provides vehicle for HIV trafficking between various body compartments. So infected macrophage will carry viruses from one organ to the other organs and plays a significant role in the establishment of compartments to the various target organs. The gut or the gastrointestinal system, this is another very important area where the HIV can independently replicate from the peripheral replicating events and can emerge as a resistance virus in different area. So this is a very old publication before 8 years, and they studied HIV into the different portions of the gut or the gastrointestinal tract, and what they found that the esophagus, stomach, duodenum, and colon, and all these sites, they have different replicating, different quasi-species of the HIV, and they behave like a separate compartment. And because of these different areas in the guts have different quasi-species, it contributes to the overall diversity of the virus in the human, infected human body system. So this gut could be a very important sanctuary site for resistant strain from which the replicating virus can come back into the peripheral pool and produces the emergence of resistance. Genital tract, I mean, this is very important because the CNS and genital tracts, these are the two body compartments where the penetration of the drugs is an issue, right? So because of this poor penetrations into these two anatomical sites, these two sites are very important to address when somebody is receiving anti-HIV medications. There are various studies which showed that the HIV found in the semen as a free virus particle as well as into the cell associated. So infected cells are there when somebody has some inflammatory process into the genitourinary system, and it is also found as a free virus particle, not attached or not infected as the cells. And we know that there are various studies which showed that there is a significant discordance between the peripheral viral load and the seminal fluid viral load. So this discordance is known, and this is the reason that probably the poor penetration of the drug is responsible for this discordant relationship between the seminal fluid viral load and the peripheral plasma viral load. Like any other anatomical sites, the resistance mutation patterns evolves into the genitourinary tract, and it is different in the plasma and different in the genital fluid secretions. The female genital tract also showed the same findings, like same discordance like the male genital tract, and it has the same characteristics of different the species of the virus. There are studies which showed that after initial trafficking of HIV from a peripheral, so during the initial viremic phase, there will be independent replications, emergence and evolution of the virus into this compartment, and it can lead to the systemic seeding later on. So this is a busy slide, but I mean, this showed the penetration of the various antiretroviral drugs into the genital tract. So if you look at this, the first this is a cervicovaginal fluid, this is the rectal tissue, and this is a seminal plasma. The pharmacokinetics of antiretroviral into genital tracts is compared with the matrix blood-plasma ratio. So look at here, like the zidovudin, lamivudin, amtricitabine, darunavir, indinavir, and maravir. These are the drugs which has got very high matrix, the fluid and the blood-plasma ratio. So these drugs has a very good penetrations here compared to the rest of the antiretroviral drug. And if you look at the examples of rectal tissue, amtricitabine, tenofovir, ritonavir, maravir, and raltegravir. These are the drugs which achieves a good the ratio into this rectal tissue. Similarly, the seminal plasma, tenofovir, amtricitabine, lamivudin, D40, raltegravir, zidovudin, and indinavir. These are the drugs which achieves a good, fairly good concentration and produces effect. So most of the drugs that we use to treat HIV-infected patients, they do not achieve good levels into this genital tract and can be a concern when we are talking about the cure in HIV medicine. Now coming to the very interesting, because I mean, so far like when we talk about lymph node, the gastrointestinal system or the genital tract, our primary focus would be the independent replications, reseeding or the reemergence of the resistance virus and infecting the systemic pool. And we are not worried about, we are not significantly worried about the organ dysfunction because of the independent replication. But when we talk about the CNS compartment, not only concern is not only the replication, independent replication, but the concern is clinical deterioration or the clinical syndrome that patient may get because of the independent replicating virus into the CNS compartment where the peripheral plasma viral load is well controlled. Sorry. So CNS is considered as a specialized anatomical and immunological compartment for HIV. And most of the patients, they develop CNS infections within a first month of acquiring HIV infections. After that, the virus can have independent replications into the variety of the central nervous system part, which includes the choroid plexus, the brain parenchyma, meninges, and all these three compartments within the central nervous system can have a different replication pattern of HIV virus. And we know that like when we talk about the management of infections into the CNS, like any infections, meningitis, tuberculosis, or toxoplasma, or the main issue is the penetrations of the variety of antimicrobial drugs because of the tight blood-brain barrier. Similarly, like the antiretroviral drugs has also challenge in crossing blood-brain barrier. And the brain represents a unique environment for HIV, like not only for the compartmentalization of the virus into the brain, but like other compartments, there is a separate evolution, the independent evolution of the virus into the CNS, and it harbors the latent virus that could present a special challenge for eradication, because we can take care of the replicating virus into the peripheral compartment. But the virus which is latent within the CNS is difficult to target. And as I already told you that like the replicating virus into the CNS compartment also produces a clinical syndrome that we called as HIV-associated neurocognitive abnormality. And I mean, this is a significant challenge that I see in my clinical practice in last couple of years. Like many of our patients, they came with variety of CNS syndrome, cognitive abnormalities, tremors, forgetfulness, and when the disease gets advanced, they have all long track signs, difficulty in walking, standing, and bladder bowel incontinence. And this is just because of independent replicating virus producing damage to the brain parenchyma. So what are the evidence for, that there is the persistent replication of the HIV within the CNS compartment? We have enough evidence that there is a replicating events within the central nervous system. It can be demonstrated by the elevated CSF neopterin level, which is a marker of macrophage and dendritic cell activation. So the neopterin level goes up. The MR spectro, I mean, it's again very important non-invasive study, which also showed the elevated myosin-acetyl creatine level in all brain parenchymal region, while the choline creatinine ratio is increased in basal ganglia and the midfrontal region. In neuroasymptomatic subject with almost 80% of the patient had peripheral plasma, which viral load is undetectable, and the 62% has CSF undetectable viral load. That means that even though the significant number of the patient who has controlled virus within the CNS as well as the peripheral compartment, they do have MR spectro abnormalities which can be picked up. The another important thing is that you can look into the CNS compartment for evidence of persistent replication would be elevated neurofilament light chains. This is a marker of the damaged neuronal damage because of the ongoing inflammations. And all the biological and the functional marker of this CNS inflammation, they reduces, but they never completely eliminated, even though somebody has achieved well-controlled HIV infection. So all these facts says that there is a persistent and independent replication of the HIV, producing persistent inflammations within the brain parenchyma and producing clinical syndrome. The HIV RNA and HIV DNA can be detected in brain patients without neuroclinical and neuropathological findings. So in autopsy studies or in a live patients, like it can be demonstrated well, the RNA as well as the HIV DNA into the brain parenchyma in a patient who has no clinical or no radiological or no neuropathological evidence. And this is a very interesting study, like published 4 years back. What they did, like they checked all the patients who had undetectable plasma as well as undetectable CSF load with standard evaluation. And they check all these CSF sample and the plasma sample with ultra-sensitive single copy assay. And what they found that 13 out of 17 who has undetectable plasma has detectable virus in a single copy assay, and 1 out of 17 in the CSF has detectable with single copy assay. That means that whatever the assay that we use to assess the control of HIV, still there is a replicating events and can be detected by the ultra-sensitive assays. And the most important thing is that the asymptotic CSF viral escape is not uncommon. So, I mean, it is not a routine practice that we check CSF examinations and we check the viral load when somebody is asymptomatic. but you may found a patient who has detectable viral load and controlled peripheral the viral load. So CNS viral replications can emerge from the reactivation of the infection that patient has acquired during the primary HIV infection. So I told you that within a month of primary HIV infection, the brain is being seeded. So I mean, this original virus which produces infections into the brain parenchyma can get reactivated later on and produces the CNS syndrome from that originally infected reservoir. And there are animal models which supports the same, and the HIV sequencing from the CNS and the peripheral compartment also support the same findings. So what was the compelling evidence of CNS reservoir? The most important and compelling evidence of CNS reservoir is the independent replicating virus into symptomatic patient who has the HIV-associated neurocognitive disease, and patient has suppressed plasma HIV viral load. So this is the most important evidence where we can say that patient is having a CNS compartmentalization or the disconnect between the CSF and the peripheral plasma level. And the most important question that we should be asking, or we should be worried, that can HIV exist? So is any possibility of reverse trafficking of the CNS associated virus into the peripheral plasma, which might have emerged into the resistance? So this is a significant challenge and to address. So reverse trafficking can occur. So there are some models, and it can be found in one patient where the peripheral tissue showed the CNS associated virus. So the virus which is present in the brain parenchyma can exist CNS and can infect peripheral pool. And discordant resistance is not uncommon. So this is the last slide. So discordant resistance in CNS compartment and peripheral compartment is well documented and well recognized. So again, this is the area of the worry. So the major implications of all these compartmentalization, like whether it is a genital tract or the gastrointestinal tract or the CNS, is on HIV cure strategies. So the issue is that autonomous replications can occur within all these anatomical reservoir and can contribute to the different quasi-species, different resistance of virus. And it can provide a potential source of systemic viral reseeding from genital or from the CNS tract, and which could be a resistance virus. So this is an area of concern and in management. Organ dysfunction is a big challenge, especially in the CNS compartment, and there will be a plausible HIV transmission from persistently replicating genital tract, even though patient is on fully suppressive anti-HIV medications with fully suppressed peripheral plasma viral load. So this is the last slide. So the question to the clinician that should we assess CNS and genital compartment for further fine-tuning ART in suppressed patient, because we know that there will be independent replications in both this area and which can be a concern in management of HIV-infected patients. Thank you very much.
Dr. Cantor. Now this talk is a little longer one. I didn't edit much because it would be incorrect on my part, but I would try to move in as fast as possible. So we are trying to see what are the complex issues that one may face when we get a case which is a late presenter. Now, the outline of the talk is we would perhaps try to see first what do we mean exactly by late, why late, being late matters, those who know their status or those who do not, does it matter here, and what do we need to change. If you actually look at this particular slide, you would suddenly realize we did not know what is late. No, whether it was CD4 count of 350, CD4 count less than 200, or CD4 less than 50, people adopted different definitions. They also tried to see whether it could be time until the first AIDS defining event that occurs, and they tried to have their own definitions. But some consensus came, and that consensus is for late presentation. One definition is those persons who present for care the CD4 of less than 350 or an AIDS defining event regardless of CD4 count. Late preservation with advanced disease would have CD4 of less than 200 and any AIDS defining event irrespective of CD4 count. What are the consequences of such a late presentation? And the consequences could be related to mortality, morbidity, treatment response, transmission, and cost. If you look at the short-term consequences, there is a higher risk of mortality among those who present late. There is a reduced chance of viral suppression. The risk of hospitalization increases. There would be more of drug-drug interactions, and they are more likely to have iris. When it comes to long-term, there is an increased risk of non-AIDS event, increased risk of neurocognitive impairment, and HIV transmission possibility also increases to others, and high direct cost of care is another big issue which we need to understand. When it comes to late diagnosis in UK, one thing which becomes apparent is the life expectancy is strongly related with CD4 count at which these individuals start. You will find older individuals are more likely to have late diagnosis as one of the presenting features. If you try and see whether the things have been changing over a period of time, in UK, when you look at 2000 to 2011 and compare that with 2011 to 2013, you'll find that it is essentially almost same. There has been hardly any change that has occurred with respect to late presenters. Late presentation is not necessarily only UK's problem, but you see, if you look at the data, it tends to occur even in most of the developed countries and in significant proportion of patients, which could range between 23 to almost 45% of those who come for taking care as such. Now, what are the other consequences of late presentation? We try to look at the mortality, and in mortality, when they did Viva audit in UK, they found the second biggest attributable cause for deaths was coming late. It was almost 24 out of 387, 24% of the deaths were caused because of late presenters, and that was an attribution that was given in that audit to the cause of death. Mortality, when does it occur? You know, most often this mortality is likely to occur in the first 6 months of initiation of ART. What are other morbidity-related complications that you are likely to see among late presenters? Late presenters, they tend to commonly present with AIDS events. And which are these AIDS events which are most common? Not a big surprise, you would have PCP, tuberculosis, and other opportunistic infections which we know of, like cytomegalovirus, candida, wasting, Kaposi sarcoma, toxoplasma, crypto, and encephalopathy. If you actually look at what is the incidence of other organ-related issues among these people, you will find the lesser the CD4 count is, you will find that liver-related disorders, they would perhaps contribute maximally towards mortality among those who are late presenters. And the same is the story when it comes to all-cause mortality. It is always higher. The lower the CD4 count, the higher is the all-cause mortality. If you look at the incidence of fatal AIDS-defining or non-AIDS-defining malignancies, the lower the CD4 count, like what you see in the first bar of less than 50, you will essentially find that AIDS-defining malignancies are more likely to be higher among those who are having advanced HIV disease compared to non-AIDS-defining malignancies with the lower CD4 counts. Opportunistic diseases or deaths that can occur by latest CD4 cell count, here also you will find the same picture. When it comes to CD4s that are less than 250, you find that the incidence is far higher compared to those whose CD4 is higher than 250 in different categories. CD4 count and HIV disease prognosis, this is a meta-analysis related data. You will find there is an increasing progression that would be observed the moment the CD4 strata goes below 200, and when it is less than 50, you find risk of progression to AIDS or death that increases maximally. What are the issues related to treatment start time and responses? Now, when we think about them, HOP study essentially showed that the incidence of virologic failure even after complete or successful suppression that has occurred with heart, that is far higher when your CD4 is less than 200 compared to 200 to 250 and more than 350 cells, which essentially means even if the provision of ART has been successful, the risk of virologic failure continues to be high among those who are less than 200 or have late presentation. When it comes to major mutations and also possibly NRTI-related toxicity, you find that it is higher among those who have low CD4 counts of less than 200 compared to those who are more than 350. When it comes to prognosis, the prognosis is worse when it comes to the low CD4 counts that you observe at the time of presentation. As we had seen in an earlier slide, you find that the probability of development of AIDS or death tends to be extremely high among those who have very low CD4 counts of less than 50 or in different strata that is less than 200. It is also substantiated not only by the earlier study, but smart sub-study analysis also shows the things in similar manner. You find that the occurrence of events tends to be higher when the CD4s are lower. Those who start with lower CD4 counts, one of the most important message that we must carry, they don't catch up with others when it comes to increase in CD4 counts over a period of time. You see it very clearly for a line that is for the lower CD4 counts. You find that it continues to remain at a lower level compared to the CD4 counts of, let's say, 50 to 200, 200 to 350, 350 to 500. You will always find they maintain a typical curve which never goes just the way it would with higher CD4 counts. What are other consequences related to cost when it comes to late presentation? You would always find those who present late are likely to require 2.5 times of the cost for initiation of ART. The inpatient cost continues to be high compared to the total cost among those who are late presenters. So essentially it tells you the later the individual will present, the cost that you have to incur on management of this person is likely to be high, and that's especially true for inpatient cost because they would be hospitalized. Late presenters commonly place a major demand on hospital resources. If you actually look at this particular graph, you will suddenly find that their daycare costs tend to increase. It's not only inpatient cost, but they need to repeatedly come to the clinics and seek advice, and therefore the cost tends to increase among those who are late presenters. The estimated cost of late presentation every year following diagnosis, if you actually see that, which comes almost like a summary of what we have seen earlier, you would find that these costs continue to, the yellow bars continue to be higher compared to the pink bars. That is mainly because late presenters would require higher amount of money for their management. We try to look at the other consequences, transmission-related consequences among these late presenters. Most of us have seen this kind of slide earlier. We know that 54% of the new infections are actually attributed to 25% of the people who are unaware that they are HIV infected, which essentially means you have to first know your HIV status. Late presenters, since they are presenting late, they may be completely unaware. And therefore, we may have to think in terms of its impact on transmission, and that is very, very clear from earlier studies. Earlier, if you recall, Tom Quinn's group had very clearly shown that in serodiscordant couples, the transmission was related to the plasma viral loads that they have. There was no transmission. Another study showed that there was no transmission if my plasma viral load was less than 1000, which essentially means it was fairly well suppressed among these people. And that case perhaps doesn't exist among late presenters because their initiation of ART is late, their viral loads could still be high. So can we find these patients before it is too late? We need to look at what approaches we could have to reduce late presenters. They are diagnosed earlier. You may perhaps have to use rapid tests, provide testing in locations and in conditions that are convenient to the clients. You may detect more number of people who, or perhaps you may have, your success rates may be higher in terms of finding out HIV infected individuals. You need to improve the links and access to treatment, care and support. You may also have to introduce provider-initiated testing, which is very much there in India. You need to use targeted campaigns to encourage the uptake of HIV testing. What can be done? Perhaps we could initiate client-initiated testing strategies, understand that client-initiated testing strategies may not be sufficient. PITC should actually be promoted. What are the key successful initiatives for early diagnosis? Antenatal screening, we know we detect more asymptomatic persons. You increase testing among MSM. You screen those who attend genitourinary medicine clinics. You screen TB clinics, screen IDUs, and indicator condition guided HIV testing should be done. Increased HIV testing correlates with reduction of late diagnosis of HIV. If I offer more number of tests to right kind of people, perhaps late diagnosis actually drops down. What are indicator guided HIV testing? That actually, I don't know why they use such a term, but that's like offering test to all those who present with any opportunistic infection as one of the disease condition, even whether they are HIV positive or not, you offer them HIV test and then try and see whether the person comes out as positive. When they tried to do it among 10,139 patients of unknown serostatus, they could pick up large number of infections from these people. If you look at HIV prevalence rate, one thing which they found is people who have hepatitis B or C are more likely to have more positive persons in Britain. Those who have lymphadenitis, those who have leukocytosis, pneumonia, and neuropathologies perhaps have higher yield in terms of contributing HIV positive people. Of the late presenters, one of the key issues that tends to emerge is those who are detected as positive. When you try to analyze their data, they found that 54 to 77% people did not attend any clinic. When it comes to primary care, they found 20 to 25% of them had not attended any primary health clinic as such. When it comes to secondary care, 2 to 40% did not attend, which essentially means you may have to do something like community-based testing as an approach to try and see that you overcome the same. When they asked the clinicians, they reported the barriers for HIV testing. Most often, one of the most important barriers that came out was time. The clinician did not have time. Either the patient's language was different, because we are talking of a setting in UK. Patients' knowledge levels were poor, and therefore they could not actually offer HIV test as such. These late presenters may present with different diagnostic difficulties. You may confuse between drug reaction, iris, or hypersensitivity reaction. When you initiate heart, there seems to be some kind of confusion as to when we should start. Some people used to wait. Some people wanted to wait only to ensure that you could avoid drug interactions among them or not have overlapping toxicities. But at the same time, we need to remember that early initiation should be one of the norms that we have to follow. So to summarize this, Late presentation is common. It is associated with significant consequences. Late presenters pose clinical management issues. They are also associated with high cost and complexities in care and can make differential diagnosis more difficult. Novel strategies are required to reduce late presentation. We may have to adopt perhaps US-like model for routine testing, and need of evidence-based approaches is very much there to overcome the barriers for testing and treatment uptake. Thank you.
Dr. Usha Natarajan from UK. She will be talking on managing older HIV-infected patients.
Good afternoon, everyone. It's a great pleasure and privilege to be here in Mumbai in Asicon. My topic is managing older HIV patients, and I have about 15 minutes to do that. So I would like to start off setting some objectives. Why do we have older patients? And what is so different about them? Do we have guidelines for the management? And also a brief principle in their management we should be able to discuss within time. So, in 81, what started as an acute terminal illness, you all know this, patients were dying like flies. And then it became one with treatable complication. And from 96 onwards, thanks to heart, it became a chronic manageable disease. So no wonder, if it's a chronic manageable disease, that we are going to have patients who live through, get old, and hence we have older patients. But I want to also just point out at this stage, we still have, at least in UK, a smaller proportion of patients who are getting infected in their older age. So that also contributes. I don't want to forget about that. So this slide is from UK, showing the life expectancy of patients living with HIV. The top two lines are the normal population, male and female, their life expectancy. And the bottom three are HIV patients, and they are stratified according to the CD4 count. So if I can ask you to look at this line, which is the top CD4 count in this graph, which is only 200 to 350, which is near normal. And nowadays we are talking about CD4 counts of 500, 700, 800. So the bottom line is they have normal life expectancy. That's what I tell my patients in the clinic. I say, your life expectancy is normal. You're going to be normal, so get on with life. So aging is universal. There are certain organ system changes, and also there is decreased physiological response to stress. But that's only one half of the story. With lifestyle issues, with smoking, alcohol, drugs, with your dietary habits and exercise, you can choose to age however you want. I won't say any more. So now we said they're living longer. As people live longer, it's not a surprise they acquire certain comorbidities, hypertension, diabetes, neurological conditions, and also cancers. So they in turn affect your bone. Your bone mineral density is decreasing with age. You don't have to be 55 and 65. We all know after the peak of 25, your bone mineral density starts going down. And it also affects the kidney, cardiovascular system. We know about all those things. One of the things which happens in the renal and hepatic clearance, when there is decreased blood flow, it obviously means that your drugs are not cleared. When the drugs are not cleared, they are hanging in your system for a longer period, causing more side effects. So, POPI cohort. POPI stands for Prospective Observational Study, looking at the effects of aging in the clinical outcomes in people over the age of 50. Okay, this is a study from UK. It's a multi-center study. There are about 10 centers participating. It started in 2012. It's still ongoing, but we do have some interim data. It is a very strong study in terms of numbers. There are totally about 2,000 patients. We have 1,000 patients with HIV over the age of 50, and you have 500 in the age group less than 50 with HIV, and you have also HIV negative patients over the age of 50. They are all very well matched for gender, ethnicity, sexual orientation, and so on and so forth. So, what do we have? So you have the comorbidities here. I'm just going to point out the first two columns. If you can just pay attention for the first two columns here. In patients over the age of 50, this one is 25, and under the age it's 10, and similarly in nervous system it's 11 compared to 8, 42 compared to 26. So, I don't have to convince you hard. You can see how much it is increased in patients over the age of 50 compared to the ones under the age of 50. Now forget about this column, and if you can kindly focus on this one, which is the negative patients, again I'm just going to point out 18 compared to 25, and this is merely 5 compared to 11, which is more than double, 29 to 42. Now, this clearly tells us with HIV, they get more comorbidities, and they are much higher than the negatives, and much higher as they get old. Now, this is a Danish data, age HIV, and again, they had about 350 patients in each arm, positive and negative, comparing, it's a cohort data, and they started slightly younger age group, 45 and over, okay? So all the dark bars are the infected, and the lighter shades are the uninfected ones. And it's not rocket science. You can see in every case, the positive ones had more comorbidities. But I'm urging you to look at one thing here for me, please. So look at hypertension, okay? Look at this. You don't have to be a statistician to say this is so much significant, okay? There's a p-value, but look at this. So I would say, as clinicians, we'll have to be thinking about hypertension in our patients that we are seeing, which probably, they may not have to be 70, but even if they are 50, please think about it. Now, this is Swiss data. Okay, what is so interesting about Swiss data is 14% of them had 4 or more comorbidities. It's not about 1 or 2 or looking at hypertension. They come in bunches. Please bear that in mind. So in women, I'm going to hurry up. In women, we have the added menopausal changes, hormonal changes, which make them more prone to osteoporosis. That's an additional comorbidity we'll have to be thinking about. And in fact, DHS guidelines suggest avoiding tenofovir. So we saw they live longer, which then means they're getting more comorbidities. So what next? If they get comorbidities, you'll have to treat them. So you get polypharmacy, and with polypharmacy, you have potential interactions. I'm not going to dwell on interactions, mainly because I know that's the topic of the next speaker. But you all know, we all know about ritonavir. We all know about statins, what we want to avoid. So with pharmacokinetics, I already alluded to the renal and hepatic clearance, which is decreased. Pharmacodynamics. Now, your patients are going to be having increased sensitivity to certain groups of drugs. anticoagulants, psychotropic drugs. Your 2 milligram warfarin in a 45-year-old is going to be very different when you're giving it to a 70-year-old. So be mindful of that. So the drivers of chronic disease. We said about lifestyle, genetic factors we can't do anything about, so we're not going to talk. Heart, to some extent, contributes. From the SMART study, we know it affects the brain. With HIV, it's the persistent inflammation, which fuels the whole issue of comorbidity. So do we have guidelines for our older patient? The answer is no, emphatically no. We don't have guidelines. There's no guidelines in BIVA. There is no European guidelines. Why do we not have guidelines? Because we don't know what is good for them, how they react to these drugs. This is where the POPPY study is hopefully is going to finish in 2 years, and we'll have some data and we can produce some evidence-based guidelines. How to follow these patients, what's going to be good about the drug that we can choose. Now, for the first time, FDA and European agency has asked for age stratification. When somebody goes with a clinical trial, they're saying, what age? Are you going to show us what's happening to older patients? That's really good news. So with that, I'm more or less sure you'll be convinced that we are going to have more RCTs looking at older patients. They're not going to be excluding patients with comorbidities. In fact, they should be including patients with comorbidities. So we are clinicians. You have a patient sitting right in front of you. You can't say you don't have guidelines, but we have to be treating them. So what can we do? Time being, have a good knowledge about the physical, mental, psychological status, and even social status. And look out for comorbidities. Don't wait for them to happen. Whatever you're comfortable with, Q risk, Framingham scoring, whatever, FRAX, look out for that. Assess frailty. That's, again, another big thing. When it comes to ARVs, I would urge you to think about safety rather than efficacy. We know all the ARVs that we have now works well, provided it's taken, of course. But in older patients, think about safety. So there are things that you don't want to be using, like tenofovir, which is renal and bone toxic. Abacavir, we have some unresolved issues still. But it's not all doom and gloom, okay? You got, listening to what happened yesterday with the patent pooling, I'm so impressed. You're going to have raltegravir, you're going to have dolutegravir. They are fantastic for your patients, especially if you have them diagnosed with cancer. Okay, you don't want to be putting them on something else, even if they are on some other regime. You want to be switching them to an integrase inhibitor, raltegravir based. It will be fantastic in terms of interaction. Now, TAF, tenofovir alphanamide, is only around the corner. Maybe you'll get them more easily than we will get in UK. So you do have options. TAF, there's a sub-study showing the TAF is better in terms of mineral density. In fact, they said that its mineral density increases with TAF than with, obviously we know that with tenofovir it goes down, but with TAF it increases, which is fantastic. And also you have some non-nuke studies coming along, and you have some dual regime coming along. So you do have things, oh, I'm right on time. So that's really, it's not doom and gloom. You're going to have some drugs, but you'll have to be thinking more about these patients, looking out for comorbidities. So in summary, the life expectancy of these patients are increasing. They're getting more comorbidities than your normal general population. And you have to think about their needs. How can you improve their needs? And maybe the future is having some specialist clinics for them with your elderly care physician, with a pharmacist to check on drug interactions, to check on the number of drugs like polypharmacy. which are sometimes unintentional. They are on too many analgesics, which are going to add on to the renal toxicity. This is actually happening at the moment in UK. There are centers where about 50% of the patients are over the age of 50. We do have some specialist clinics where it's with the HIV physician and elderly care physician and a pharmacist. These are three main important components of people who do this clinic. You will have to be thinking in terms of multidisciplinary approach, having physiotherapist, maybe social service, whatever it needs. So that's all from me. Thank you very much. Thank you.
Friends, and thank you to the organizers for their kind invitation for this topic. I think picking up from where the last lecture ended, which really focused on older people, I think this is one of the most significant issues that is going to happen as we treat more and more patients who are older and living longer with HIV. And it's not just that, but try and remember and don't forget that we use at least 3 drugs for HIV and sometimes 4. So there are possible interactions with every drug that we use. Patients are living longer with not just comorbidities, but as they get older, they also have possibly more co-infections. We also use drugs to manage drug toxicities, and there's some data suggesting that you could use anti-osteoporosis drugs to manage some of these bone toxicities, or perhaps some other drugs. They themselves could contribute to drug interactions. And we know the biggest bane of geriatric medicine is actually polypharmacy and drug interactions. And it's not uncommon to see patients taking more than a dozen different tablets and pills, and sometimes liquids, and trying to figure out which one to take when, and which will interact with which. And there could be sometimes 3-way interactions of drugs. So clearly this is very fascinating and sometimes perhaps the most complicated science to understand and figure out for the clinicians. And the important part is, look, drug concentrations, even for most HIV drugs, do matter. Whenever drugs interact, you could get the concentration of the HIV drug going up or going down. And if it goes to supra-therapeutic levels, you could actually get drug toxicities. If you go to less than therapeutic levels, you could possibly get treatment failure and even drug resistance. And the challenge for us is try to keep the concentrations of drug within a certain range, which perhaps is not all that narrow, but there are some very significant drug interactions which can actually dramatically do that. And with the introduction of newer classes of ARVs, it's also important to understand how the new ARVs interact with the older ARVs as we're trying to find exactly where these drugs should be used in our treatment regimens. And if you look at the way drugs are actually moving on from the, after absorption from the GI tract, you can see that interactions can occur in the pharmaceutical preparations as well. Right from the triple combinations or the quadruple combinations that companies make, could there be interactions even in those? Interactions taking place at the absorption level, which may be related to pH, to the presence of CYP enzymes, which are not just in the liver. A lot of people forget that there are cytochrome P450 enzyme systems present in the GI mucosa as well. The presence of P-glycoprotein or transporters, which are responsible for ferrying the drug across cells and sometimes getting it out of cells. And of course, the biggest organ where you get drug interactions is actually the liver, because of the large number of isoenzymes that are present, which is CYP3A4, 2B6, 2C9, the PGP again there. And don't forget, there is often a second step, or some drugs are exclusively metabolized by glucuronidation. And it is this process of glucuronidation which could also lead to drug interactions. That's an area which we often probably miss. Then within the systemic circulation, we talk about drug which is protein bound or free. And a lot of other drugs which can compete for the same protein to which the ARVs are bound could result in drug interactions. And then within tissues, it could be the same problem. And within the target cells, you could actually get sometimes competitive antagonism between different ARV drugs for getting converted into their active compound. Drug interactions could also happen at the level of the kidney when the drugs are being excreted, and we have examples of that as well. So clearly, interactions between drugs can take place at every step when the medication is taken orally till it is actually excreted. So which are the drugs which are commonly implicated in interactions? And we know among the ARVs, the protease inhibitors typically have been the most notorious of them, followed by the NNRTIs, the NRTIs, and now we know some of the interactions of the INSTIs as well, which are well documented. Among the drugs which we use for opportunistic infections, clearly rifampicin, particularly in our part of the world, is notorious for all the interactions that it causes. The azole antifungals, let's not forget, you can have very complex interactions, particularly when you're using drugs like voriconazole or fluconazole. Fluoroquinolones, macrolides, cotri, anticonvulsants, extremely important. Anticonvulsants can dramatically alter the concentrations of ARV drugs. Some of the anti-malarials as well. Drugs which we're now using more for viral infections, not just for HPV so much, but more now for the hepatitis C drugs which are there with us. What are their interactions? And as we get more and more cancers, there are interactions between chemotherapy drugs and antiretrovirals as well. The drugs that we use for side effects, we use cardiovascular drugs such as statins, calcium blockers, beta blockers, which can cause drug interactions, acid-inhibiting drugs, which are over-the-counter. You often don't know what acid-inhibiting drugs the patients may be taking, and this may be leading to clinically important drug interactions. Antidials, antiemetics, oral hypoglycemics. I think metformin was mentioned in the previous talk as a drug also which could lead to drug interactions. Several other drugs, use of psychotropic drugs. HIV-associated infection and treatments are associated with a lot of psychiatric issues sometimes. So what about the role of psychotropic drugs? Methadone, of course, in certain situations. Corticosteroids, oral contraceptives, warfarin was mentioned, erectile dysfunction drugs as well. And never forget herbal drugs. This is something which we have very, very little control on what patients may be taking. And unless you take a very specific history, you may not know what the patients are taking. So here's an example from Thailand. This is about 1,000 HIV-infected patients from Thailand. A third of them reported clinically significant drug interactions. And look at the severity, grade 3 and 4 in more than a third of these patients. So clearly, significant drug interactions, even in our 2014, continue to occur with a very, very high frequency. And this is what clinicians really need to be aware of more. Now, if you see such a chart, this is the perfect chart post-lunch to go to sleep. No clinician will be interested in saying, what does this mean? What is a substrate? What is inhibition? What is induction? What is mixed inhibition, induction? No significant effect. And worst of all, not determined. So you're completely in the dark as to actually what's going on. And I'm not encouraging you all to see this, but I think it's important to remember some very fundamental principles of interactions between the ARVs and the commonly used drugs that we have. So for example, one of the commonest drugs that we increasingly are using now with ARVs and patients who are living longer is actually statins, and which would be an appropriate statin to use. Is it simvastatin? And you don't see it even here. So clearly, if you want to use a statin in patients who are HIV positive and taking drugs, you either use the lowest dose of atorvastatin or rosuvastatin, or perhaps you use a drug like pravastatin, which does not have important drug interactions, but unfortunately, it's not that potent. And there's another compound which is called pitavastatin, and these are the limited choices that you have. But interestingly, fibrates can be used quite safely, and they are often the drugs of choice because you have hypertriglyceridemia in many patients who are HIV positive. So these are some key things to actually remember. I'm going to briefly touch on ARV interactions with anti-cancer drugs because that's often talked of as the most significant issue that is emerging in the older patients. Many chemotherapy drugs are substrates for the CYP3A4 enzyme. There is a high potential for drug-drug interactions between these. And when we use chemotherapy agents, we just don't use chemotherapy. We also use drugs to manage the toxicities of chemotherapies. So here you may see a 3 or 4-way interactions between the ARVs, the chemotherapy drugs, and the drugs which we use to manage the side effects of the anti-cancer drugs. Many of these anti-cancer drugs are also substrates for P-glycoprotein, and not just that, they are metabolized by CYP3A4. And on the slide here, you can see the list of drugs which are P-glycoprotein. In fact, interestingly, people were trying some other drugs in the olden days to block PGP to increase the concentrations of drugs intracellularly of the cancer medication. So clearly there is a lot of pharmacokinetics as well as some interaction at the glucose, at the PGP as well for this. And here's, if you want, a laundry list of some of the key interactions of anti-cancer drugs with the ARVs and the management of it. So clearly, the simple thing is to monitor these patients much more closely when we are treating patients of HIV infection who also have cancer. So taxanes, zinc alkaloids, anthracyclines, and cyclophosphamide. These are extremely commonly used drugs in such patients. I'm going to end by briefly touching on interactions with some of the newer drugs that we are quite excited about. Everyone's quite excited about tenofovir alafenamide. But it's important to remember that it's still tenofovir. It is a substrate of P-glycoprotein, and the levels of tenofovir can also be altered by certain drugs. And I think the most important drug interaction that needs to be highlighted is the possible interaction with rifampicin. if you actually carefully look at all the data of interaction between rifampicin and tenofovir, there is a small interaction between tenofovir, disoproxil fumarate, and rifampicin, and the concentrations go down marginally. But because TDF has high concentrations in the blood, you don't see that clinically important effect. But in case of TAF, which has the advantage of having low concentrations of tenofovir in the plasma, but higher in the cell, you could actually have a very significant drug interaction between rifampicin and TAF. And currently you see that these two are not recommended to be given together. And I see that by the end of the year or early next year, we'll actually have hard PK data to know what is the kind of drug interaction between TAF and rifampicin. And if there is a clinically important drug interaction, what can we do to alter the dosage of TAF? And I think we really have to follow this up. Because of this, you see the excitement of TAF got a little tempered in the developing countries because of the presence of tuberculosis. Ritonavir and cobicistat can also increase plasma concentrations of tenofovir, and darunavir can decrease it. Interestingly, if you look at all the renal toxicity data with tenofovir, one of the risk factors is concomitant protease inhibitors. And this is because of the presence of ritonavir, which can increase the concentrations of tenofovir in the plasma and in the kidney, and therefore cause more renal toxicity. But importantly, no significant interactions have been seen between TAF and dolutegravir or the integrase inhibitors. And rilpivirine, which is a drug which somehow, I don't know how much of that has been discussed in the meeting, but that's a drug that is often not given adequate importance. And I'm going to end with this last two slides on a very interesting issue that I just came up with. We all have seen the success of dolutegravir and its uptake in the Western countries since its introduction. But at the same time, let's also remember that efavirenz, which was successfully taken up so many years ago, after 10 years, we now feel, oh, there's a lot of toxicity with efavirenz, and therefore we should not be using that much of the drug. And we should now be moving to the new integrase inhibitors. So what's the data on clinical trials of dolutegravir versus real-life data on dolutegravir? And if you look at discontinuation rates of dolutegravir in the real-world studies, is clearly higher than what has been seen in clinical trials. And this is actually, there are two papers out there. One of them is this, intolerance of DTG in CART regimens in real-life practice. And this is an observational study of 556 patients, and the discontinuation rate was actually about 15%. Not low, that's quite high. And if you look at some of the commonest reasons for discontinuation were essentially related to the central nervous system. But what is interesting even more is what were the risk factors because of which dolutegravir was discontinued. And the most important risk factor turned out to be, interestingly, concomitantly giving it with abacavir. And that's the only fixed dose combination that is available in the market, is abacavir, lamivudine, and dolutegravir. So here's actually looking at a Kaplan-Meier curve of CART, continuation of CART with abacavir and dolutegravir versus without. So clearly there seems to be some unknown interaction that may be happening, this is all hypothesis, between abacavir and dolutegravir. And here's what is suggested. Both dolutegravir and abacavir are metabolized by the hepatic glucuronidation. And is something happening there which we don't know as yet. But remember, this is an observational study, this is a hypothesis, we still don't know exactly what's going on. But what the message I want to show is, we are excited by new drugs like TAF and DTG, but we need to really understand drug interactions, both kinetic as well as pharmacodynamic, which are unexpected. To me, TAF and rifampicin was unexpected. We never really thought about it when TDF was there, but now we're really thinking serious about it. So the message I want to give is new drugs, great new drugs, very helpful toxicities perhaps, but let's be also careful of drug interactions. And I've just listed out some key drug interactions with DTG. DTG has interaction with rifampicin, and you need to double the dose of dolutegravir, and that's a thing that we will have to face in India when we have DTG in the market. Rifabutin reduces the DTG concentrations by 30%, but that's not clinically important. Now, interestingly, if you combine dolutegravir with efavirenz, and I don't know which clinical situation you may have to, but you never know, right? You may have to again double the dose of DTG to 50 milligrams twice daily. And if you want to construct a triple drug therapy with etravirine as well, which is not yet available here, it reduces the concentration of DTG by 70%, and actually co-administration should be avoided unless you give it with a ritonavir, darunavir, or ritonavir, lopinavir, where the concentration then comes back to normal. So very complex three-way interaction between etravirine, dolutegravir, and a boosted protease inhibitor. Last and final slide of mine, I always show this towards the end of my presentations on this to drive home the message of herbal interactions on absorption of drugs, which is St. John's wort, garlic, and a few others. Be very, very careful on drug interactions with herbal medications. So I'm going to stop here by saying that we all know HIV is a chronic disease and frequently associated with polypharmacy due to several co-infections, comorbidities, drug toxicities, etc. It's critical, not just essential, to take drug interactions into consideration when prescribing ART regimens. I think drug interactions are a big challenge in the management of HIV today, and I'm not sure how much we emphasize on the importance of drug interactions. One can manage by altering the dose of one or the other, or importantly, by substituting with another drug of the same class. And therefore, I think we need to comprehensively expand. And if you can't remember how to use it, I can tell you I can never remember these drug interactions. You saw that chart out there, and that's why I use the internet. Use the Medscape app, which you can download on your smartphone. Use some of the other apps that are available from various sites like Liverpool, UCSF, etc. Thank you all for your hearing.
So I request all the speakers to come on dais. Dr. Atul, Dr. Ganga Khedkar. Dr. Jyotidhar also is there, I think, if she can also join with us.
We need
Jyoti.
two chairs.
Yesterday, and I envy her commitment to science.
Hello.
Her bag was put in taxi, and her mother-in-law was not having pulse. So she calls me. My mother-in-law has no pulse. Should I come or what do I do? And her husband tells, you go ahead. I said, no, you cannot come. You just finish that. And within 1 hour, her mother-in-law died. So I really applaud her presence, and we would have greatly missed her if she was not there.
So any questions from the audience about the talks? There's a reminder about compartmentalization of HIV, late presentation, treatment of older populations, and drug-drug interactions. Please.
Good afternoon. My question to Dr. Atul Patel, sir. Sir, do we, resistant testing of CNS viral load is possible or not? And do we require it when we see that plasma viral load is undetectable and CNS load is high?
Yeah, this is a very good question, and recently we have tried to look at the resistance in the CNS compartment, and we have couriered 2 samples to Dr. Ganga Khedkar at Nari, and just waiting for results. But absolutely yes, like whenever you have a controlled disease into the peripheral compartment and you have very high CSF viral load, you have to look at the resistance inside the compartment, and you need to adjust the dosage. Though we do not have great information that the adjusting dosage can improve the neurocognitive abnormalities, but yes, we should do it, and probably that will help to a patient. So whatever experience that we have in adjusting the dose, the antiretroviral drugs and the dosage, when somebody has a controlled peripheral disease and breakthrough in the CSF compartment, most of the patients, they have rapid improvement in their the HIV-associated neurocognitive disturbances. So even though we do not have a great the information that adjusting the drug by CPE score will help in reducing the neurocognitive, but when somebody has the symptoms, and once you adjust according to the CPE, it will definitely improve the neurocognitive abnormalities.
So, which are the best ART for kind of the cases?
The Zidovudin, Nevirapine, and ritonavir boosted Indinavir has the highest penetration.
Good afternoon. This is once again to Dr. Atul Patel. You have explained the reservoirs in various tissues very excellently. I'm having a doubt. In future, if we are having drugs to eliminate the reservoir or purging the virus, will it affect differently in various tissues? So HDAC inhibitors, they may likely to come, or urinostat, they may likely to come. Even in that condition, even that is a reservoirs in gut, reservoirs in CNS system will behave differently or same. That's what my question.
That means you want presentation of CNS HIV viral load viruses, or what do you want actually?
No. To eliminate the reservoirs or to eliminate the virus from the reservoirs, the drugs in future, will it behave same with the all tissues or with differently with say, different tissues?
So you want me to say about elimination of the virus from the
future,
reservoir?
in future.
In future. Yeah, I'm not a right person, but I mean, I think Ganga Khetkar can answer this about reservoir and the elimination strategy that he's working on.
No, perhaps we could wait for that question tomorrow. No, otherwise.
Maybe I can ask a question about late presentation. One aspect of that is diagnosing patients early and then seeing them grow older, and I think that's very important. We're all seeing it. Another is having people either infected or diagnosed very, very late. And I mean, the eventual result is maybe the same, but maybe there is a specific considerations to be made on the second group. I was wondering if you had any information about this from India and whether there should be any considerations on that.
I don't have any information about that from India, but I can say from UK, we do have a percentage, which is not very high, and as we can, these are patients in UK, it's very different setting, and these are patients who are regularly testing, so they would have had something like 20 negative tests before they tested positive. So we know when somebody tested positive when they're 65 years of age, and they had previous negative tests, we certainly can be very sure that's a new infection at that age, and not somebody who had the infection for 20 years and we are just picking them up. So that way, I think we have those information. Thank you.
Other questions from the audience?
If it is not there, we'll conclude the sessions and request the organizer to felicitate.
I request the chairpersons to kindly felicitate the speakers. Dr. Amar Pazare to Dr. Atul Patel. Dr. Jyoti Dhar. Dr. Cantor to Dr. Usha Natarajan. Dr. Cantor to Dr. Jaideep Gopte.
The opening speaker in this session will be Dr. N. Kumar Swamy from Chennai, whom we have heard since morning also. Impact of WHO 2016 ART guidelines. Dr. Kumar Swamy.
Good afternoon. Thanks again for the opportunity to do this presentation. So this particular session is on comorbidities. So I might be focusing more on the impact towards the prevention of comorbidities. What will be this impact? And also for some of you who heard my talk this morning, first part of my talk will be a little repetition, but I may go a little faster. This session was sponsored by Gilead Sciences, so what I'm talking is not being coerced by them. It's been purely based on science and from data and from guidelines. I'm sure everyone here knows that this you have seen might be like today the 30th time, and I had also shown twice earlier. So what is this WHO 2016 guidelines is today's treat all. And irrespective of the CD4, irrespective of the symptom, irrespective of the pregnancy status or anything, someone who's HIV positive, put them on treatment. So, and again, coming to the impact, so I'm going to use the same slides, but I'll be talking different stuff. So the HPT and O52 study, which again I said this morning, is the one which made all those revolution. So 5 years back, our group showed in the interim analysis, there is 96% reduction in HIV transmission, if you start treatment early, mainly the sexual transmission. The study was continued even after 2011, and we put everyone who were on delayed on treatment to assess the durability of HIV transmission. what we found is we are able to see the sustained or more than 90% reduction in HIV transmission in those who are on antiretroviral treatment. This is the first impact, when you implement this and, the new WHO 2016 guideline. You'll continuously see prevention of HIV transmission, and that will be durable. But that will be durable only if, again, we had seen 8 linked transmissions in this HPT and 052. Again, if you looked into this the data, which I showed this morning, but I may walk you through a little more deeper into that. The 4 infection occurred either before or soon after starting treatment. That means don't wait. You're not going to see any impact. Test and put them on ART, make sure that they have been suppressed virus. And also 4 infection happened when these patients failed ART. So that means don't even give time for the virus to replicate when they're failing. Do viral load and switch them sooner. If you're not doing that, you're not going to see the impact of the prevention of sexual transmission of HIV following this ART. So today, the WHO 2016 guidelines strongly recommend put everyone on treatment, and where you'll see an enormous benefit of preventing sexual transmission of HIV. Again, I didn't have the slide since earlier session was very interesting where we talked about polypharmacy and we talked about reservoirs. One thing I like to show you, this morning I showed a slide, and also we had some partial evidence which will be presented at CROI if it is accepted, which I showed a slide on that. Again, starting treatment early will also reduce the reservoir size and reduce immune activation, which will also help future cure strategies. Again, I didn't have the slide to show, and we just submitted this paper for CROI. Next, going to the impact of new WHO 2016 guidelines is, the START study evidence. Again, this is a session on comorbidities. So what's seen in the START study is patients who are on immediate term, starting treatment at a higher CD4 more than 500, there is dramatic reduction of various comorbidities, both serious AIDS events and non-AIDS, which I showed this morning. So 14 in the immediate arm and 50 in the deferred arm. And again, if you look into the non-AIDS complication, 29 versus 47. This very clearly shows that a huge impact on implementing 2016 guidelines on patients who are starting treatment early. And very importantly, again, I said this morning, tuberculosis will be prevented, especially in a country like India, where you'll have a huge impact by implementing the recent 2016 guidelines. Please don't delay, do it. And also in sub-Saharan Africa, I've just seen dramatic reduction of Kaposi sarcoma in patients who are starting treatment early. And also, in the non-AIDS complications, especially the malignancies and cardiovascular and kidney disease, were able to be prevented by starting treatment early. There is a huge impact. There is no doubt on that. We have got enough evidence, and following this, the WHO 2016 guideline, start treatment early. And also, one thing we heard a lot about the previous session on drug-drug interactions and polypharmacy. Don't make your patients to develop all these opportunistic infections by delaying. But if you do that, then you'll end up in treating all these infections and putting on ART, where you'll have more and more drug-drug interactions. So if you put everyone on treatment at a higher CD4 before they start developing, then we may not have Jaideep Gokte's talk in the next Asicon, where we may not have that amount of drug-drug interactions. We waited up to patients to develop all those OIs, and now patients have much drug-drug interactions. Start treatment early, where we'll have much more benefit to our patients, where again, with single FTCs, they will do very well. So the major impact today by implementing this WHO 2016 guideline is not only in this public health benefit, but also enormous on individual benefit by preventing various comorbidities. The next thing, which I didn't show this morning, is this might be new to you. So we have now 2013 guidelines where we are using efavirenz 600 along with tenofovir 3DC or FTC as a fixed dose combination to initiate on treatment. So what had happened in the last 3 years is, this is a large retrospective survey, review of 4 NIH-funded ACTG clinical trials. Out of those, one was done in research limited setting in India, including Chennai and Pune, called ACTG 5175, and also 3 other studies. Data was being used for this retrospective analysis. So what this investigator did is, they looked into the data of patients who have been put on efavirenz-containing therapy, which was compared with other regimens. What's been found in that is, participants who are on efavirenz-containing therapy, they had 2.5-fold higher risk of attempted or completed suicide among those who are assigned to efavirenz. Today, we are talking about treatment for everybody. Even at 1,200 CD4, they're perfectly fine. When you put on efavirenz 600 milligram, we don't want our patients to develop this major comorbidity of attempting a suicide, and their near ones and come and report to you that you gave this drug, they committed the suicide. Now, this is just presented a couple of months back in Durban at the World AIDS Congress. So this is a sub-study conducted on the START study, which I said about, which recommended treatment for everybody. So their analysis was done on those patients who have been participating in the START study. So what's been found is out of those 4,685 patients, 270 individuals had reported some sort of a prior psychiatric diagnosis. It could be depression or anything. So what's been found in that is patients who have got history of psychiatric disturbance, they have higher reported evidence of efavirenz-related side effect, particularly on CNS, including suicidal behavior. So it's not just one retrospective study. Even in this prospectively conducted START trial in sub-analysis, it's shown that efavirenz 600 may not be a right drug when you put patients on higher on treatment. And one step going ahead, now today we all know that baseline resistance is moving from region to region, from 2% to 15%. Today in the US, the baseline NNRTA resistance is almost around 12 to 15%. And in UK, it's around 10%. And in some countries in Africa, it has touched 10. And in Asia, it has been hovering between 3 to 6%. So I think, if our resistance baseline goes up, efavirenz again will not be a good, perfect choice for starting treatment. We need other alternative drugs. Following all this evidence, the new WHO 2016 guidelines also recommend two other alternate options. One is reducing this efavirenz 600, which causes suicidality and various CNS toxicities, to efavirenz 400, and another one is introduction of new drugs, that is dolutegravir, which you heard a little earlier. And again, going into what is this evidence of reducing this dosage. So this is a trial called ENCORE study. So what this trial did is they compared two groups of patients. One received on standard 600 milligram efavirenz, and another one, test arm, received 400 milligrams. So this is a very large study on 600 patients, 300 in each arm. X-axis is the duration in weeks, and Y-axis is proportion of patients who have suppressed viral load. And here, if you see the red color graph, it is on patients who are on efavirenz 600, and the white color one is efavirenz 400. If you look into this virological suppression, both are same, both 400 and 600, irrespective of the body weight. Here, they didn't look into the BMI, it's been same. But very importantly, looking into the comorbidities of efavirenz on suicidal tendency and CNS toxicities, if you look into this efavirenz 400 arm, where there is dramatic reduction of efavirenz-related adverse events as compared to 600 milligram. So again, by implementing the new WHO 2016 guideline, by reducing 600 to 400, you'll be able to reduce a major comorbidity of efavirenz-related adverse events. They're not looked into the suicidality, but other various CNS toxicities which we see in our patients. As a result, they tend to disrupt the medications. But if you go into this newer drug of dolutegravir, majorly what we will see is again a trial called single trial, which compared between dolutegravir versus efavirenz. Again, if you look into the x-axis is the duration of patients on treatment, and y-axis is proportion of patients who have got suppressed viral load. The green curve is patients who are on efavirenz, and white one is on patients on dolutegravir. Again, if you look into that, higher rate of virological suppression with the newer drug, dolutegravir. And also, again, if you look into this, I said this morning, the suppression occurs much earlier, even before than efavirenz. This will have a tremendous effect in terms of prevention, and also you heard a lot of talks on reservoir setting up. Again, if you start treatment early at a higher CD4, soon after diagnosis, put them on dolutegravir, the virological suppression will be much earlier, so thereby we can even prevent the, even the formation of certain reservoirs, thereby even one day if there is a cure, even the strategy will be much, better. So again, implementing the new 2016 guideline will also step the pace for the future cure and eradication strategies. Again, the study also showed that, as compared to efavirenz, there is almost no CNS toxicities. It's been very clear. I think, this will be a huge impact. Now, coming to the viral load, I will not spend much time on that. Just again, various speakers this morning talked about that. So, new WHO guideline very clearly states that routine viral load monitoring is mandatory, and that's a preferred mode of choice. If you're not going to do this, we all know that, you'll end up in patient either sick, or they have already failed, they have accumulated mutation. Again, you heard this morning from various resistant lectures, thereby it can jeopardize future regimens. So today in the WHO 2016 guidelines also recommend the second line and third line. This again, you'll be able to use this in a public health approach only if you got viral load monitoring. If you don't have a viral load monitoring, we and others have shown in the past that if you don't do viral load monitoring after first line failure, the accumulated NNRTA mutation can jeopardize future second generation NNRTAs, which are preserved for third line. And if you're not doing viral load monitoring following PI failures, and accumulated PI mutations can also jeopardize darunavir efficacy for third line. So there will end up having no drugs. So again, the impact is if you implement viral load monitoring as part of the WHO 2016 guideline, we'll have a better second line and third line and better impact on the patient's productivity. Right. So I just wanted to show this data, which has been analyzed from a very large data set called a Treat Asia data set. This has been data being collected from 7 countries, from different clinics of almost around 16,000 patients. What we looked into that is, we looked into the patients who received care from different durations. We looked at the patients who have been started on ART between 2003 to 2005. We looked into the survival probability. We found it's almost 92%, 4-year survival probability. There is a guidelines to start a treatment when the CD4 is less than 200. But when you look into the patients who initiated treatment between 2006 to 2009, where the patients have started treatment at a little at a higher CD4, survival probability increased, and 2010 to 2013, where they used 350 threshold, also they used tenofovir, where the survival probability much more increased. Now we are also looking at the 2013 guideline, and also I personally feel when we do this analysis, if we implement 2016, the survival probability might even touch 100%. That again, based on the better drugs we are using, better monitoring, and better switching, and the availability of all those. So implementing newer guidelines will have a better survival probability in our patient cohorts. And just before conclude my talk, I'd like to say that this is something what is being done by UNAIDS and other organizations. What will be the major global impact if every countries start implementing the WHO 2016 guideline? We'll about 21 million AIDS-related deaths, and also will be able to prevent 21 million new HIV infection by 2030. If India is not going to join this war, so we'll not be able to achieve this. I think it's right time that we should start implementing in our region so that we'll be in pace with the global scenario. So you may ask a question on cost. Again, I showed this morning. So our group, in collaboration with the Harvard group, have already shown that starting treatment at a higher CD4 is being cost-effective and cost-saving both in India and South Africa and even in various other countries. So this is a data being published a couple of days back. Many of you now have seen this. So this is a group of investigators in collaboration with a group in UK. What they have done is they have used the WHO 2016 guideline indicators and also the data from START study, and they have done the cost-effective analysis in Nigeria, South Africa, Uganda, and India based on the cost per daily averted. What these investigators have shown is if you implement the WHO 2016 guidelines, including starting treatment yearly, as well as putting on the newer drugs, there will be immediate cost effectiveness will be seen, and as well as likely even cost saving over a period of time. This very clearly shows that it's not there's no point in delaying implementing this. By implementing this, you'll have a huge impact on preventing transmission, preventing morbidity, and in future in science, even setting the phase for future cure and eradication strategies, and as well as will be even cost effective. Will these newer ARVs will be cost effective? Clinton Foundation has already done and published showing that reducing the dosage from 600 to 400 milligram will be cost effective, and also will have reduced the side effects. And also our group in collaboration with the Harvard have very recently done this work. I don't have the data to present, we just submitted to CROI, and what we have shown is implementing dolutegravir even in India, even I do not know the cost, but I heard the cost will be marginally higher than efavirenz. But if you look into all those failures and prevention effect and as well as adverse events put into the model, will be cost effective on a long run. So even introduction of the new ARVs will have a huge impact even reducing this cost. With this, I'll be ending my talk and happy to take questions later. Thank you very much.
On the improvements in the renal and bone safety after switch in ARV. Dr. Gilada, please.
Sorry to interrupt. The tea break which was scheduled after this session is cancelled as we are running short of time. However, tea will be served outside. Thank you.
As we are progressing in our HIV management skills and available molecules, we are looking at some novel molecules as well. So looking at improvements in renal and bone safety, TAP versus TDF. This session is sponsored with the unrestricted educational research grant from Gilead. Apart from that, I don't have other disclosures. We have to look at role of TDF in HIV positive individuals as well as HIV negative individuals. In HIV positive individuals, we have to see to reduce their risk of transmitting HIV to others. So treatment as prevention. In HIV treatment as ART, everybody know that. In HIV negative individuals, post-exposure prophylaxis, pre-exposure prophylaxis. In oral PrEP, in topical PrEP, which is a tenofovir-based jelly, and also in HIV, HBV co-infection or HBV infection. Now, so often we see patients coming with a lot of kidney problems and ask, where is my kidney? Now, kidney can be knocked out because of several issues, and one of them is TDF or tenofovir. There are other issues also for renal morbidity that can be HIV related, it can be hypertension, diabetes related, it can be HIV related, and it can be other comorbid conditions. Now, both TDF or TAF, they have a prodrug and active molecule is tenofovir. But if we look at the comparison between TDF and TAF, TDF is more in plasma and TAF is more in cells. So therefore, you require 1/10 of the dose of tenofovir if you use TAF molecule. In TAF treatment experienced patients, there are studies done, and one of the studies, study 1089, which is a switch study of FTC TDF2, FTC TAF, and it was analyzed at week 48, and it's a randomized double-blind control study, and it was done in virologically suppressed patients, and FTC TDF plus third agent. So one of the third agent was used, and when they analyzed, the study was basically for non-inferiority margin set at 10%. And baseline characteristics were same, both in TAF as well as TDF or similar. And efficacy at 48 weeks, if you look at virological success or virological failure, it is non-inferior study. In virological success by third agent, if the third agent could be PI or it could be non-PI based unboosted third agent, and results were similar. So it can be used with any of the combinations. In adverse events, there were some adverse events noticed with TAF, but they were not statistically significant. If you look at changes in the eGFR rate from baseline with TAF, there has been a lot of benefits with TAF, and eGFR rates were better, and therefore it has been considered as one of the safer molecule than TDF. If you look at change in renal biomarkers at 48 weeks, you can see that there is an improvement in tubular function at all the levels, whether it is a protein, albumin, RBP, or beta-2 microglobulin. If you look at change in bone marrow density at 48 weeks in spine and hip level, you can see that with TAF there has been gain, whereas there is also some gain with TDF, but TAF with a larger gain. In TAF, also in treatment naive patient has been seen, and this study is a study, there are two studies, 104 and 111 in ART naive adults and analyzed at 96 weeks. The two phase 3 randomized double-blind active control studies, and they have looked at again non-inferiority margin set at 12%, and in the first group there were a TAP-based regimen, in the second group there was a TDF-based regimen, so either Stribil or Jinvoya. Again, baseline demographies were similar in both the groups, and when they analyzed at 48 weeks and 96 weeks, it was seen that virological success and virological failure both were non-inferior. In changes in proteinuria through week 96, in all the 4 parameters, it has been seen that TAF is superior than TDF. New onset CKD or AKI through 96 weeks, this study has been also seen, and in this, there were 3 people with TAF regimen, they had problem, and 17 people with TDF had a problem with kidneys. So TAF in renal impairment, study 112, which was seen in suppressed adults who were already virologically suppressed, and impairment was seen with the switch from TDF to TAF. And in HIV suppressed individuals with GFR rate between, which was compromised between 30 to 69, and when it was switched, the results were seen that they were virologically, they remain same, and virologically failure also or success also, it was non-inferior. In bone marrow, bone mineral density or BMD, change from baseline has been studied, TAF versus TDF, and it was seen that there has been a major gain in TAF. There is also some gain in TDF, but gain with the TAF is much more. However, despite all these things, we have challenges with TAF, and which we need to address over the years. It may not be addressed immediately. Availability. Currently, it is not available. When it is available, again, we'll have some problem with our DCGI getting a clearance to be marketed in India. Sometimes they may ask to do Indian studies. Then, when it is available, what will be the cost? Whether it will be cost effective? Because somehow we feel that by continuous cost reduction, our patients are expecting that that the cost should be on par with the previous cost. In 1995-96, patients were buying very expensive drugs. But same people who were buying the expensive drug at that time, they do not want to escalate another 10 or 20% in newer drugs. Drug-drug interaction, especially with anti-tuberculosis drug, rifampicin. And we just heard Jaideep also telling about it. In India, a lot of patients with HIV have HIV-TB co-infection. And sometimes it may be subclinical infection, which we are not aware. So under this situation, whether to use rifampicin or not, or sometimes we should use TAF or not, we need to look at it. In long-term adverse effect need to be studied because all these studies are 48 weeks, 96 weeks, and we are yet to reach third year. Combinations, whether it will be available in all the combinations. Like in India, we prefer combination with lamivudine than emtricitabine because we find less dyslipidemia with 3-TC or lamivudine. A TAF for PrEP is not ready yet, especially there were studies that in animal studies it was successful, but in human studies, in women studies, they found it little bit not so successful. And also its role in microbicide, whether tenofovir jelly which is used, can there be TAF jelly also. Often whenever newer product come, and sometimes our government is in rush and they sign some pact with the European Union, etc. on patents, and then we see that fight is between patent versus patients. So I think this kind of scenario should not arise, and I'm glad that Gilead is one of the multinational companies which is pro-patients and pro-developing countries, and they bring molecules easily. We heard yesterday on MPP, there has been an international movement how to bring newer molecules at affordable range to people, particularly in the second or third level countries. And in this situation, a patent is donated by a patent owner to MPP, that is Medicine Patent Pool, and from there they sub-license to the other companies or generic companies where it can be sold at lower cost, but that product cannot reach to the patented those countries which follow patent regimen. So this MPP role is a great role in bringing TAF. So we don't have to doubt much about how fast it will be available. I think whenever it is available, within a couple of months it will be made available in India. Thank you.
Now I invite Dr. Ed Wilkins from United Kingdom, and he'll be speaking on non-HIV related comorbidities, CVD, CKD, and bone newer ARVs.
Thanks very much. It's lovely to be here. Thank you for the invite. Oh, there you are. Thank you for the invite, Dr. Gilada. One of the great things about when you're invited to this is you're asked what you'd like to speak on. And I gave 4 possible topics, and I always get asked to speak on something different. But anyhow, I don't want to go over what's been said before because I also got sent a very similar slide set. And so I think I'm going to use this as a general talk about comorbidities you get as you get older, and also just touch on TAF. Now, given I'm a fair old age now, little did I know when I saw my first patient in '82, which is around 35 years ago, that what we had then, when everybody was presenting with opportunistic infections, and their average life expectancy in those early days pre-AZT was around a year, that we would have the situation we have now, where patients can live a pretty normal lifespan. And what we're dealing with is the comorbidities of aging in the heart, the kidneys, the liver, the brain, and this is what we spend our time being concerned about. And of course, about half the patients who come and sit opposite the desk in the consultation room that see me are now over 50, and a considerable portion are actually older than me. And also, it's difficult to believe that, you know, that early time when AZT came along, and I remember the AZT rep coming to see me, that we would have the drug then that very quickly realized that resistance was just occurred very easily because it was a very promiscuous virus in its reverse transcriptase activity, to the situation we have now with the drugs that even with the person with the most multi-resistant virus, we can get their viral load undetectable as long as they take their drugs. So it's that incredible situation from having one drug where you always saw resistance they're giving a combination of drugs now that are highly active even against very resistant virus. You know, if one picture can tell 1,000 words, then for me, this is the picture. And this is America, it's young people, and it's the way that the death rate from AIDS climbed through all the other mortality rates to become the top killing disease in patients who are aged 25 to 45, or young adults who are aged 25 to 45 in the USA. And the impact of heart can be equally shown, and how quickly this death rate came down as a result of drugs. And this is one of those times in life where I was there, and I remember that Vancouver conference, and I remember how exciting the data was. So many conferences you go to now, and really there's not very much. But that Vancouver conference was a real milestone, and at the same time, of course, you got viral load estimation. And we all know that the drugs then caused a lot of problems, especially with cosmetic from the thymidine toxicity and Crick's belly, which was indinavir belly or protease belly from the protease inhibitors. Now treatments are so much easier. We just have a combination tablet. There are now 5 single tablet regimens that you can give. And so adherence is much improved from that. And all we've got here in this slide, on the left-hand side, we've got the age of patients who present now with HIV, and you can see the number of people who are getting older and older is increasing, and the number of diagnoses that are younger and then patients who are seen in clinic is getting less frequent because so many patients are living longer on their heart. And now the life expectancy for someone who's HIV positive where they don't inject drugs, they don't have a lifestyle which puts them at risk of comorbidities such as recreational drugs, they're not hepatitis C positive, and they take their drugs, their life expectancy is pretty much the same as someone who is HIV negative. And they looked at that data using the SMART and the ESPRI studies. And what they showed is if you had a viral load that was undetectable and a CD4 count that was over 500, then your life expectancy was, using mathematical modeling, was equal to that of a person who is HIV negative. So if somebody takes their medication and achieves a high CD4 count, and you're more likely to do that if you start treatment earlier, then your lifespan should be normal. I'll just leave that out. And this is something we all know when it comes to dealing and preventing the comorbidities that we see so often now in our patients, is implementing the known interventional techniques we have to hand. And that, say, this is the DAD data, on top of which somebody has put what happens if you stop somebody smoking, what happens if you control their blood pressure and control their lipids. And you can see how you can produce a significant decrease in the incidence of a cardiovascular event. So here we go on to what I'm meant to be talking about, which is the comorbidities in HIV. So looking at a lot of studies, and this is a meta-analysis looking at studies, even where everything is controlled for, smoking, blood pressure, cholesterol, the drugs a patient is taking, the antiretroviral agents a patient is taking, you still see that patients with HIV have around a 1.5 times increased rate of having a cardiovascular event compared to somebody who's HIV negative. If you take patients and look at their renal comorbidities, somebody who has HIV is 3 times more likely to have chronic kidney disease when it's untreated HIV than somebody without HIV. And where you have somebody being treated for their HIV successfully and compare it to somebody who's not being treated, then again you are 3 times more likely to have chronic kidney disease. So treating somebody with HIV effectively is going to reduce the incidence of chronic kidney disease. So you have that impact on kidneys as well as you do on heart. And the same is true on bone. Systematic analysis have looked at the incidence of osteoporosis and the incidence of bone fracture, and they are increased in patients with HIV compared to those without HIV, again, irrespective of whether they're taking HIV treatment, and matched in every other way. What about the impact of drugs? Now, a lot of people have made up their minds about the abacavir story, but there is no doubt that many of the cohort analyses have shown that if you take abacavir recently, you are more likely to have a myocardial infarction, whereas the cumulative effect of abacavir is nowhere near so significant. Now, although there have been other cohort analyses apart from DAD, which have supported that, there have also been cohort analyses which have refuted it. And so one can always say that the jury is out, but there is no question that some cohort studies have shown that if you have a high risk of cardiovascular disease already, then you increase that risk even more if somebody receives abacavir. But we're all using abacavir in clinical practice, and I think with the advent of Triamec, with dolutegravir and Carvexa, I think the use of abacavir has gone up considerably. The same, we're concerned, all of us, when we're practicing, we're concerned about tenofovir and renal toxicity. And we all look at patients, we've been following them up for years, and you can see that eGFR is falling slightly, their protein-creatinine ratio is increasing slightly, and we have this sort of impression it is tenofovir, but they're aging, they may have developed hypertension and diabetes, and it's quite difficult to tease out what is in fact related to the drug and what is just the comorbidity that the patient is suffering from. But again, many studies have shown that tenofovir is associated with osteoporosis and is associated with an increased risk of bone fracture. What about kidneys? Now again, there's a concern that you see, and I know the sort of talk I was giving to the slide, they were the wrong way around, and that was to the renal and the dropping GFR, but the same is true for the kidneys. And you can see here that with time, this is a Eurocedar study, and they defined people in a slightly complicated way, in that patients who started with a GFR that was above 60 on 2 occasions, and if it dropped to below 60, then that was evidence that the patient was developing chronic kidney disease or had progressed. Or if the patient had a GFR below 60 when they started this cohort analysis, and it dropped by 25%. That defined progressive chronic kidney disease. And what you see here at the bottom on the right is you can see that tenofovir, there was a significant association between taking tenofovir and progression of your renal disease. So for the drugs, the obvious implications we've all known about: kidneys and bone with relation to tenofovir, and heart with relation to abacavir. And when you look at overall at a study comparing HIV negative and HIV positive patients, and look at the comorbidities that you see in those patient groups, and this study from Italy looked at 5 particular comorbidities: heart, hypertension, diabetes, type 2 diabetes, that is, and osteoporosis. On the left-hand side, you've got the HIV positive, and on the right, the HIV negative, and blue is where you have no age-related comorbidity, and you can see how many more patients in the HIV positive greater than 60 year histogram bar have comorbidities than they do in those that are HIV negative. You can see only a small percentage have no comorbidities aged over 60 years of age, whereas over half do in the HIV negative. So let's move on now to TAF, which again was something I was asked to talk about. Tenofovir, the problem with tenofovir is that once it's absorbed, it gets into the plasma, and in the plasma it's at a high level, and then it gets into the target cell, and then it has an action against HIV. Now, tenofovir alafenamide, TAF, goes into the plasma, and in the plasma it doesn't get converted to tenofovir, or very little. and then that gets into the cell, and then it's converted to tenofovir. So the levels that you have in the bloodstream are much less. And so in this slide, looking at the top part of it, you have with TAF, and this is in the form of Genvoya, with elvitegravir, cobicistat, and I've forgotten which drug it is, emtricitabine. Then you have, with patients with an eGFR of 30 to 59. So these are patients with diminished renal function and defined as having chronic kidney disease. You can see the TAF level there, or the tenofovir level in the plasma, is 670, and you compare that in situations with patients with normal renal function who receive tenofovir, and you can see how they're about 4 or 5 times more. So you take a population who are receiving TAF, who have diminished renal function, and still their level of plasma tenofovir is about a quarter of that with patients with normal renal function who are receiving other combinations. So the studies have been gone through by Dr. Gilada, and I'm not going to go through them again. Suffice it to say that there are 3 studies which are proper blinded control studies, and then you have the switch study looking at patients who've got renal compromise, and they have a GFR which is between 30 to 69, and the patients are switched to Genvoya, which is elvitegravir, cobicistat, TAF, and FTC. So 104, 111 is Stribal against Genvoya, and I know you may know them as different names here, but one is elvitegravir with TAF, the other is elvitegravir with tenofovir. Then you have the switch, and patients on a third agent being switched to Genvoya with TAF or continuing on their other regimens. And with all these 3 studies, you can see there's no difference in the viral efficacy. They're all highly effective studies when you're comparing Genvoya to Stribal, or you're looking at a TAF-based regimen in Genvoya. They're equally effective. And you've seen this before. It's more protective on the kidneys. It's more protective on the bone, so you don't get the degree of bone loss that you see with tenofovir. So that's summarizing what's already been said. A higher GFR is seen, less proteinuria, and no cases of proximal renal tubulopathy or Fanconi had been reported, although there have now been a couple of cases. The study design 112, I've gone over my time, so I'm coming to my end, was the one where, and you've seen this slide before, patients with existing impaired renal function were switched. And the one thing that can be said, it's not that the GFR improved, it's that the protein loss in the urine and the tubular markers improved. So what are you going to do? How are you going to choose between these backbones? All of them have single tablet regimens. This is Carvexa, tenofovir, and TAF. Patients with high cardiovascular risk, you're not going to give them abacavir. Patients with high viral load, you would only give them abacavir if it's with dolutegravir. Obviously, if they're HLA-B57 positive, you're not going to give it there. If they have osteopenia or osteoporosis, you wouldn't give tenofovir, but you can give TAF. I've moved on quickly there. And if the patient has renal impairment, then you're not going to use tenofovir. You can use abacavir and 3TC, but a reduced dose of 3TC. So the question I ask to you in the audience and to the panel is, are you looking at using TAF with FTC, which is Descovy, in all patients who are on Truvada at the moment, just switching them over? Are you going to leave it? Are you only going to do it in patients with established chronic kidney disease or osteoporosis? Or are you looking at patients with the potential for chronic kidney disease, like older patients and who have maybe osteopenia at the moment, do not have established osteoporosis? So I'll finish there just to say that for the UK, this is what we face, the cost of drugs, given that it's about £500 million every year that we're spending on our drugs. Thank you very much.
Thank you, Wilkinson. It's a very fine and what we call it as a razor shave presentation. Please come. In fact, in earlier days, we had a blade for shaving that was very famous in India. You must be having in UK also, Wilkinson's, right? Yes. Do you make or any one of your any disclosure about Wilkinson's? Thank you very much.
I have lots of disclosures.
Next speaker is Dr. Akash Shukla from Mumbai. Another important topic is HIV HCV co-infection, please. Dr. Akash Shukla.
Thank you very much. I thank the organizers for inviting me and giving me this opportunity to share. I happen to share Bazare, and we manage these patients together. So we know that hepatitis C is the most common blood-borne infection all over the world, and we have a huge population, around 2% of the world, who is hepatitis C positive. In India, we estimate around 1% of the population to be hepatitis C positive. We need to know the genotypes still because we don't have Alpha-Tocevir yet in India, and therefore, all over the world, genotype 1 is the most predominant genotype, whereas in India, the predominant genotype is genotype 3, and only 20 to 30% of patients are actually genotype 1 in India. If you look at overall, around 4.5 million persons are estimated to have the co-infection. This is much less in India, and we estimate probably around 50,000 people to be co-infected with the two viruses in India. Let's see what is the incidence of HCV infection in HIV-infected MSM. A long follow-up study, 1984 to 2011, and they found that the HCV incidence rate was almost 8.5 times higher amongst HIV-infected versus HIV-uninfected men. So HIV-infected was 4.22 per 1,000 person years, as compared to HIV-negative, which was 0.5 per 1,000 person years. IV drug abuse had a very high risk, so was sexual exposure, and delayed enrollment, that is in the 2000 and beyond, as compared to those who were enrolled in the 1980s and 90s. So this basically tells us that the percutaneous mode of transmission and HIV co-infection are associated with a higher risk of transmission of hepatitis C virus. We know that the mortality is going down because of HIV. At the same time, in USA, the HCV-related mortality is going up. The number of transplants required because of hepatitis C is going up. The watershed period was around 2005-06 in the USA, where we saw that the mortality equaled because of hepatitis C and HIV. In India, we are reaching probably now the stage where the mortality is equal because of hep C and HIV. Probably another 10 years and we'll have more mortality due to HCV than HIV. So when you have somebody who has HIV, what should we do? We should be screening everybody for hepatitis C antibody. That's the anti-HCV antibody in the blood. Those who are negative, they should be annually screened for HCV by anti-HCV antibodies. Those who are positive, we always do a HCV RNA to confirm the presence of active infection. And to plan the therapy, we need to do a genotyping and we need to stage the disease. By staging, we mean the stage of fibrosis. We can estimate this clinically if there are obvious signs of cirrhosis, like very low platelet counts, less than 1.5 lakhs, if the patient has obvious decompensation, if the patient has high bilirubin, low albumin, abnormal PTINR, abnormalities of liver synthetic function, it's a clear-cut case of advanced fibrosis or cirrhosis. Whereas for other patients, it may be a little difficult, where you can rely on non-invasive markers like fibrotest, fibrometer, or fibroscan, or MR elastography, depending on what is available at your local place. All patients who have tested for HCV positive and have HIV should also be tested for hepatitis B, and vaccination for hepatitis B must be given to all who are negative for hepatitis B. These patients should also be on HCC surveillance. because the co-infection is associated with almost 8 times higher risk of HCC as compared to HCV monoinfection. So when we think of management of patients with HCV, HIV co-infection, what are the guiding principles that we have? So the benefits of ART outweigh the concerns regarding the drug-induced liver injury. So ART should be initiated regardless of CD4 count, including patients with hepatitis C-related cirrhosis. Although ART should be initiated in the co-infected patients regardless of CD4 count, in ART-naive patients with more than 500 CD4 count, some may choose to defer ART until HCV treatment is completed. This has definitely become easier now because of the shorter durations of therapy, with just 3 months of therapy for most patients for hepatitis C. For those who have a CD4 count of less than 200, ART is of course initiated expeditiously, and we may decide to defer the hepatitis C therapy until the patient is stable. The initial ARV regimens are the same as those for patients without HCV infection, and concurrent treatment of HIV, HCV is feasible, but may be complicated by pill burden, drug toxicities, and drug interactions. And I'll be talking about some of these drug interactions in the next few slides. So the guiding principle is they should be treated or retreated the same as people without HIV infection after recognizing and managing interactions with antiretroviral drugs. So we had sofosbuvir, which was approved in April 2014 with us. This is how the different DAs work, and sofosbuvir in India forms the backbone of all therapeutic regimens involving hepatitis C therapy. This is something which is extremely important for us. It is a potent drug which is pan-genotypic. It has a high barrier to resistance. It is basically a 5A inhibitor, so it inhibits the polymerase formation. It's effective against the drugs. It is effective against the virus which are resistant to the NS5A variants, drugs. So all the presence of RAVs to NS5A drugs is not a contraindication to use of sofosbuvir. The advantage is it doesn't have any interaction with food. It is renally cleared, doesn't have a CYP450 metabolism, and has few drug interactions. But the drug interactions which are there, we must be aware of to prevent complications. The beauty of the drug is it is a prodrug, it is inert, unless it reaches inside the hepatocytes. Once it is inside the hepatocytes, inside the liver cells, it becomes activated to GS461203, which is then within the hepatocyte again converted to the inactive circulating metabolite, which is GS331007. So the circulating form in the blood is actually the inert form. And that is why this drug is very well tolerated. Renal clearance is the major elimination pathway. However, patients with moderate renal impairment, anybody with a GFR of more than 30, can tolerate normal doses of the drug. No dose adjustment is required for patients with any degree of hepatic impairment. No impact of HCV patient characteristics such BMI, sex, or presence of cirrhosis on exposure or side effects have been noticed, and there is no effect on the QTC interval. It has to be always used with other drugs. It should never be used as a monotherapy. It has been indicated for all genotypes of hepatitis C. It has also been approved for use in patients with hepatocellular carcinoma awaiting liver transplantation because of hepatitis C, and in HCV HIV-1 co-infection. When we use it along with the antiretroviral drugs, do the pharmacokinetics change? As you can see here, across the drugs, whether on the left side, you can look at the 4 drugs which are commonly used, and on the right side, you can look at the 7 drugs which are commonly used, and the therapeutic levels are very much constant across the different drugs, and they do not go out of the therapeutic window that we have. So these data support potential use of 400 milligrams of sofosbuvir with most commonly used antiretroviral regimens in patients who have co-infection. The co-administration with tiprenavir is not recommended since soft exposures are expected to be decreased due to the PGP inducing effect. This was the pivotal study of genotype 1 to 4, where they gave 12 to 24 weeks of therapy. Most of the commonly used drugs were included, and we found more than 80% SVR rates, which are cure rates. For genotype 3, the cure rates with 24 weeks were more than 90%. This was with just SOF and ribavirin. However, it did not do well in patients who had cirrhosis, where the rates came down to around 60%. Similar thing was seen in genotype 3, where in patients who were previously treated and not responded, the success of the therapy in patients with cirrhosis came down to 80%. So sofosbuvir was good for patients who are naive and did not have cirrhosis for 12-week regimen with ribavirin alone. When they looked at role of SOF plus ribavirin with or without pegylated interferon in co-infected patients, the results were comparable in all the genotypes and across the cirrhosis status. More importantly, it was very well tolerated. The rate of grade 3 to 4 adverse events was less than 10%. Then we had the combination of SOF ledipasvir, which is a once daily oral 90 milligram tablet of ledipasvir combined with 400 milligrams of sofosbuvir, once a day, fixed dose combination tablet, which can be administered irrespective of the food, very good pharmacodynamic and pharmacokinetic profile, 8 to 12 weeks of therapy for most indications for genotype 1. In co-infected patients, in this study, majority of the patients actually were cured, more than 95% cure rate with just 12 weeks of once a day, one tablet. This was the IN4 study. Again, if you look at patients with high viral load, 7 logs HCV RNA, the usually used HIV regimens, and you see again more than 95% of patients, irrespective of their previous treatment status, achieved cure rate. Irrespective of cirrhosis, the cure rates were more than 95%. Irrespective of their CD4 count, the cure rates were more than 95%. So across the different profiles, patients were achieving more than 95% cure rates with SOF ledipasvir in genotype 1. Same thing, but more importantly, the safety. Very well tolerated. Treatment discontinuation due to adverse events was 0. Death was 1, which was less than 1%. The most common adverse events that we also face in clinical practice are headache and feeling of tiredness. This is especially common in people who have previously headaches and history of migraine. There was no compromise of renal function, even in patients who were put on tenofovir therapy. So in co-infected patients, now we have evolved to such a stage where we can achieve cure rates of almost 90%. Of course, there's a problem with the concomitant use of tenofovir because of the involvement of the pharmacokinetics, because of want of time, I can't go into the details. But what we have to realize is, in patients who are on ritonavir boosted PIs, use of SOF-LEDI does increase the levels of tenofovir, and this can give rise to toxicity, and therefore, these patients should be very closely monitored. So to summarize the drug interaction profile of SOF-LEDI, no clinically significant drug interactions with most of the ART drugs, but it increases tenofovir exposure, especially in patients who are on LEDI-SOF and on ritonavir boosted regimens, and concomitant administration of SOF-LEDI is not recommended with tiprenavir or elbitagravir, cobicistat, FTC tenofovir combination. So they say that the recommendation is ARV drugs, which is when needed, should be done in collaboration with HIV practitioner, and for HIV, ARV, HCV, DA combinations not addressed below, expert consultation is recommended. So what is the recommendation? Because leadbelasvir increases tenofovir levels, concomitant use mandates consideration of creat clearance and should be avoided in those with creat clearance less than 60 ml per minute. So again, declotazevir is available for genotype 3, similar dosage regimen, once a day for around 3 months, excellent results with 12 weeks, more than 95% cure rates across genotypes in patients with HIV co-infection. Again, we have to be wary of the side effects and the drug interactions. Declotazevir is very well tolerated, but it has very similar drug interactions to sofosbuvir, and it should be used, its dose has to be adjusted in patients who have got either enzyme-inducing activities or enzyme reduction activities. So to summarize, HCV therapy is safe and effective in patients who have co-infection with HIV with directly acting antiviral agents. Soft-LEDI is the treatment of choice for genotype 1, and soft-DACLA is the treatment of choice for genotype 3. ART treatment interruption to allow HCV therapy is not recommended. Monitoring for tenofovir side effects is warranted when we use these drugs. Soft-LEDI should not be used with cobicistat and elvitegravir, pending further data. And soft or leadbelasvir sofosbuvir should not be used with tiprenavir. Thank you very much.
Thank you. Thank you, Dr. Shukla. Please come and join.
For discussion for a few questions. Anybody?
My question is to Dr. Kumarasamy sir. So when a patient is tested positive and we are doing viral load, if it comes more than 1,000, we can start ART. If it comes as undetectable, should we start on ART or not?
Okay. I'm sure everyone would have understood the question. Today the WHO guideline recommendation is put everyone on treatment. Right? So as part of the WHO guideline, there's no recommendation to do a viral load at baseline. So many people in public health will not know this, right? But again, so your question is very valid. So today in the US, DHS's guidelines, so what they've used is anyone who has got a detectable viremia, start on treatment. In those regions, detectable viremia is not 400 copies or 150 copies. They can even further go down, 50, 20, even in some of those institutions, they even have 2-copy assays. That is also been detectable, right? Anyone who is having detection, you have to start on treatment. So we have a very small proportion. I think our group have earlier published from Chennai, especially on these elite controllers. It's a very small group of population who are HIV positive, having continuously undetectable viral load. So these are something where, we are looking at this viral load at the plasma. So we are not sure about whether they have certain types of viral strains where our primers are not picking up. We do not know, all those questions. At this time, if you ask me, I will start everyone on treatment. Because to find one such elite controller, you have to keep doing viral load for thousands and thousands of people to get that. Again, today in the WHO guideline, is not been recommended to put viral load for everybody. So, but on monitoring, you do this. So your question is, I think I'll start treatment for everybody.
Actually, I'm having a patient. She is positive for the past 3 years. I'm looking for CD4 count and viral load once in 6 months. Her viral load is even now it's undetectable for the past 3 years, and the CD4 count is more than 1,500. So I am in a dilemma: should I start or not?
Same thing in our settings. There are a few cases. These are cases when you put on treatment, we have got no idea how to monitor them. They already have undetectable viral load, but there are enormous benefits, right? This patient has got HIV. Somewhere. I showed this morning. The HIV can be in the tissues. There are reservoirs setting up. It can go in the glands. It can be the gut, in the genital tissue, where there will be residual viremia, which will induce a lot of non-AIDS complication, evolution of liver disease and kidney disease. I think putting on treatment early, there will be effect. So there are no data to show this, but at this time, I think I'll start treatment. But there are groups like Jay Levy, the legend from California. He'll say, if he asks, he said, don't start on treatment. There are a lot of different groups have this now with the currently available data. We do not know the transmission question of this person, right? So whether this person will transmit HIV to somebody else, we do not know all those questions. I think since we don't have perfect answer, I'll start on treatment.
My question is to Dr. Gilada sir and Kumar Swami sir. In Indian scenario, we are using efavirenz with a dose of 600 milligram. In your practice, what percentage of patients you have to stop efavirenz because of suicidal tendencies? I would like to know, sir. Thank you.
At least in my practice for last several years, I have been using efavirenz in low dose. Only problem comes is it increases pill burden. Because if you give 200 milligram, 2 tablets, then they have to take 3 tablets. And sometimes they are not willing to take, and we ask them, one day you take 1 tablet, one day you take half tablet. And some of the smart patients, they started taking half tablets and their viral load is suppressed. So I think we need to again look at even tenofovir and lamivudine doses also. Because lamivudine, 100 milligram, it works in hepatitis B. Why we require 300 milligram in HIV? So we need to look at all these issues, and somehow we are not able to publish it, but probably in next couple of months we'll publish the data.
So coming to the question on proportion of the people in our cohort, 7 to 10% of them, they complain of some CNS toxicity, not all on suicidal tendency. Many of them don't complain about suicidal tendency to any of us, right? Only when you keep counsel them, sometimes they open up to one of the counselors. So we don't have the perfect data for that, but we have that from the ENCORE study and from the START study, which has been significantly, much higher. So coming to these, lowering the dosage, in India, we don't have what is called TLE 400, efavirenz, a fixed dose tablet. So we have to use 200 efavirenz, which is a high pill burden. So individuals who have got CNS toxicities because of efavirenz, if we can't use other drugs, we had reduced the dosage by giving 2 different 200 milligrams, they all had suppressed viral load. So only thing is today, in the WHO guidelines, we are not recommending that for patients who have got TB, who have got rifampicin, where rifampicin 400 is not recommended, as well as we don't have enough data for pregnancy.
Question for Dr. Akash. What is the cost of soft lady or soft decline in Indian full treatment for the Indian persons?
I think very, very valid question, and the cost of therapy of sofosbuvir, ledipasvir in India is now down to around 35,000 to 40,000 rupees for the full therapy of 3 months. Soft decla would also cost more or less the same, which is actually less than 0.1% of the cost in the United States. And that's because of the transfer of technology by Gilead Sciences, where now they have actually transferred and given the rights of manufacturing to Indian companies who are manufacturing the hepatitis C drugs. And therefore, the whole therapy is now costing less than 40,000 rupees.
Yeah, this is just Kumar. Thank you for the response that you gave regarding lead controllers. This is one of these situations where the patient is, that's how we manage it. The patient is given the option. If they're in a serodiscordant relationship, we press and say, I think you should be started on treatment. But if they're already positive, the partner is positive, we tend to leave the option to the patient because as regards elite controllers, there is no data. So that's just an add-on to what you've already said.
Agree, absolutely.
Yuti, I would say there is treatment, and it's all a question of, the data that came out of START with regard to the numbers needed to treat is what I inform patients with, and I think this has been said earlier. Have I got the wrong? Oh. They can hear me, yes. No, you can hear me. So if you have a young person with a good CD4 count and an undetectable viral load, the likelihood that they're going to progress over a period of time and get a clinical event is so extremely low that it's part of the equation when you talk to the patient and they can balance it up and make a decision, of their own, and they can easily leave it. And I'm quite comfortable if the patient decides to leave. But if you have an older person and their viral load is higher and their CD4 count is coming down, then it's a different circumstance, and you can put some more muscle into your argument when you're talking with the patient. But I would say that data on the inflammatory effect of having HIV with an undetectable viral load and being an elite controller, there is still evidence of inflammation. And inflammation has to be a bad thing. So we want to dampen it down by giving treatment.
This question was for Dr. Akash Shukla. This
scenario which I'm probably trying to describe may not be very common in Bombay, but let us see if it is somewhere in the northeast in India. A person who is treated with the HCV virus, maybe a co-infection or whatever, and he gets the virus again because of a reinfection, because of a needle stick injury, continuing to use those. So would you be able to use the same sort of therapy? But is there a testing available for resistance, or what is the scenario in that situation?
I think very, very pertinent question. We know that there is no lasting immunity with the antiretroviral drugs that we're using for hepatitis C, the antiviral drugs that we're using for hepatitis C. And there is a possibility of reinfection, especially in IV drug users. And we'll have to treat them as fresh infections. The RAV testing, especially for NS5 inhibitors, is right now not available in India. Having said that, do we really need it? If we are sure that this is a reinfection, then we really don't need to test them for RAVs for NS5 inhibitors. The problem would be if there is a recurrence or relapse, because we really have very limited options here in India. We have just 3 drugs available to us for hepatitis C, soft, ledipasvir, and declotazevir. We don't have the every 3-day regimen. We don't have the Previrs. So we really have constrained resources. And therefore, when you're treating the hepatitis C for the first time, we have to treat the right drug at the right dosage and for the right duration to minimize the chances of relapses. Because if you get a relapse, the risk of the treatment options are really limited for us. Practically for us, if we have given adequate dosage for the first time and if we have a relapse, you'll probably have to go back to interferon-based regimens, the triple therapy.
I am having a remark and a question for Dr. Kumaraswamy. The guidelines are changing very frequently. Only very few HIV patients are attending and updating themselves. Many people still they are thinking and starting the CD4 count 250, 350 is the marker for initiating HIV therapy. What we are going to do to reach them, that is one thing. That's not a question. Another thing, WHO 2016 guidelines is saying that is viral load estimation is mandatory, yes, accepted, but how frequently we have to do, once in 6 months or once in a year? We are doing once in a year because of cost factor. Whether it is useful to pick up the mutations or viral failure, virological failure, whether it could be once in a year is sufficient or not. That's what my question.
I think I'll answer your second question quickly because easier. So today the recommendation is you do a viral load at 6 months after starting treatment, and if suppressed, do it at the 12th month. Then after that, it's suppressed every 12 months. So this is a current recommendation. So can we further reduce, like rather than doing every year, every other year? Right now, we won't recommend because viral load is very important, especially for even age 90 by 90 by 90, and also is a very important indicator for adherence and as well as for transmission-related questions. But on the other hand, the new WHO guideline also says you can do away with the CD4 monitoring. So once you start someone at a higher CD4, and if they're virologically suppressed, and if they have adequate CD4 or more than 350, it has got no value. So you can even either do it or even do it away with the CD4. But viral load, I won't do that. I'll keep doing because that has got a lot of benefit. So to your question, why few doctors are attending, I think we keep organizing regional meetings. I think if we can get the telephone, a number of all the HIV doctors, we can send a text message of a WHO 2016 in a small shot. So SMS message so that at least they'll get updated on that. So we are looking at several ways how we can give information to doctors, especially on HIV updates.
I want to add on hepatitis C reinfection or recurrence. Already we are having those who have used sofosbuvir in cirrhotic, having attained SVR12. And we just have to test, we just tested after 24 weeks and we found the virus again. So we think that this is a recurrence, not reinfection, even among the injecting drug users. And especially in Northeast, most of the people are not sharing syringes. So they are using safe syringes. Then in that also we have found recurrence. Then especially in cirrhotics. So what we do is we repeat treatment, including ribavirin, especially in cirrhotics. And they are responding again. It's already 6 months now. So we have had some cases on that.
I think that's a very valid point. In patients who have cirrhosis and genotype 3, it is a good idea to start ribavirin right from the beginning. So these are the cohort of patients who have a tendency to relapse. So genotype 3, cirrhotics, either extend therapy or use ribavirin. I think that is the guiding principle for genotype 3. Coming back to your first point, that if the patient has achieved SVR12 and has again detectable RNA at 24 weeks, is this a recurrence or is this a fresh infection? The studies have shown that if you have achieved SVR12, almost 99.8% of these patients will have SVR48. So the chances of a relapse happening beyond 12 weeks is 0.2%. So it's really rare. I would presume if somebody is getting a detectable RNA subsequently, there are two possibilities. One is the method which was used to detect the RNA at 12 weeks was probably not appropriate.
We'll discuss later.
And the second is it's a reinfection rather than a recurrence.
I request the chairpersons to kindly felicitate the speakers. Dr. Mathur to Dr. Wilkins. Doctor. Dr. Sankarnathan.
Good afternoon to everybody, respected chairman and all the audience. As you know that this is really a fag end of the day and it is very difficult to digest the strategy and policy at this time. I know, but I will just try to just make my presentation in such a way. As you know very well that TB is one of the very important public health problem in the country itself. It is one of the having a lot of devastating effect on not only on the individuals but also on the family. And it is mainly related to the social determinants, related to the poverty, and also you know that the poverty related problem like overcrowding, malnutrition, migrants, laborers. These are mainly the groups where the TB is affected. So whenever we are just treating the TB or managing the TB, we should always be think that the TB is not only a medical problem, but is a social problem, and we have to deal in that way. TB is one of the highest burden of the country if you see India is having highest burden of TB. About 25% of the India burden of the TB is in India itself. If a global report of 2015, if you see that India is also contributing 23% and India is having incidence about 2.2 million. If you just compare the TB with the global situation in India, if about estimated incidence is about 96%, and estimated incidence in India itself is 22 lakh. That itself shows that it is 25% of the global contribution is there. One of the deadly combination, as you know, the TB and HIV is having a deadly combination and also a comorbidity very highly. Everybody knows that. The HIV associated TB in India itself 1.1 lakh, and multi-drug resistance is a big challenge in India, which is about 71,000 cases are notified amongst all TB cases. As far as the notification and estimated number of cases, if you see that it is estimated and reported cases, there is a large number of gap is there, and that gap is about 0.8 million, and that gap is mainly we have to a big public health challenge, and we have to see that this gap has to be bridged, and we have to see that how we can just go to these missing cases which is already in the vulnerable populations and the community, and that is a big challenge. The TB has already, MGD goals has already been achieved in 2015 itself, and if you see the incidence has been declined more than 50%, more than 38%, and if you see the mortality itself is declined more than 50% drop in mortality itself. And this shows that we already achieved the goal of MGD goal in 2015 itself. But still, if you see, there is a huge number of deaths and huge number of cases are there in India itself, and that is a big cause of concern in India itself. About of 9.6 million people in India, about 22 lakhs cases are there in India itself, and that is a great cause of concern. According to that, the National Strategic Plan of TB has been already been developed in country, that is 2012 to 17, which is aligned with our NTB strategy. The vision is India TB free India, and goal, as you know, the universal access to the TB. Each and every person of the TB, whether it is a poor or it is a rich, or whether he is living in a hilly area or geographic, he should get a quality treatment in the TB as well as the diagnostic services. The objectives are early diagnosis and high quality treatment and scale up of the DRTB, that is drug resistance TB, which is a big challenge in the country itself, and also reduce the morbidity and mortality due to the TB HIV infection itself, and which is already very great combinations and comorbidities there. India is already endorsed and also a signatory for the Sustainable Development Goal, and third goal, if you see, is the NTB is epidemic of ending the epidemic of HIV, TB, and malaria. That is one of the third goal of the Sustainable Development Goal, and that out of 13 goals, third goal is that. But if you see that in spite of the other goal, which is reduce the child neonatal mortality, reduce the maternal mortality, reduce the poverty and all, if you see that all the goals are related to the TB itself, because TB itself is having a lot of social inclusions and social support are determinants which is affecting the TB, and that's why we have to see that when we have to take the opportunity of the sustainable development with other department, and which will be interministerial coordination has to be developed, and we have to see that TB, we have to achieve the goal of the NTB strategy and the sustainable development goal by 2030. India is committed for the NTB strategy into a World Health Assembly 2040. India is already moving toward this direction. We are in the transition stage this year. In 2016, we are just transition from Stop TB to NTB strategy. We are from Millennium Development Goal to Sustainable Development Goal. And this year is a very, very important year for just starting a baseline data for the NTB strategy itself, and which we saw Government of India is already committed to for the NTB strategy by 2030. For this, NTB strategy is having three major pillars and four principles. The mainly pillar one is concentrating mainly on the patient-centric. Instead of the target, we are patient-centric and mainly concentrating on the diagnostic and treatment of the HIV, TB patient and MDR cases, which is for which the program has already chalked a lot of intervention for that. And second pillar is mainly concentrating on the bold policies and supportive system. The Government of India has already started more or less in a state government a supportive system for the TB patient, like nutritional support, insurance, and also giving the travel vouchers to the patient and universal access to the TB patient. And pillar 3 is mainly intensifying on the research. Intensive research is required for a TB. Unless the research on the vaccines, research on the point of care is not there, we cannot achieve the goal of TB by 2035. Apart from these four principles, which mainly the government accountability is very much important, and also the building the strong relation with the civil society, because civil societies also play a very important role in the community for the social mobilization that we have seen in the polio, where the social mobilization and social civil societies and NGOs plays a very important role from bringing the patient. Protecting and promoting the human right and ethnic activity, because it's a social cause, and as you know, the social determinants are affecting to the TB patient, and so it is one of the social cause we can say, and it is a matter of social justice. and we have already adopted in India itself in this particular thing. Adoption of the strategy and target level and greater collaboration with the international community for the ending the TB itself. These are the some 4 principles which is based on the NTB strategy. We are having the Geneva SM 2014 and we are endorsed for this NTB strategy and Government of India is one of them. We have developed the mission, vision, goals and target for the NTB strategy. Our main vision is that to world-free TB and the goal is the end TB epidemics, for which the goal has already been chalked out and we have developed that reduction in the mortality by TB itself is by 2003, that is sustainable development goal by 90% and by NTB strategy which is in the 2035 by 95%, reduction in incidence by 80% and most important third vision goal is the catastrophic cost effect on the families and the individuals. That is a very, very important goal because this goal required a lot of inter-ministerial help and also support from the other ministry like women, child, education and all these things where the poverty-related problems are there and out-of-pocket expenditure for the TB should be reduced. That was the very important goal itself. India's incidence for the TB is declining very, very slowly. That is only 2% are declining by per year, but if you just go in the same speed, we will not able to achieve the goal of NTB strategy, and it will take around 2000 to 2121 next century itself, and that's why we required, if you want to achieve this goal by targeting 10 per lakh population, we have to make the strategy very cohesive and also a more optimize the current tool and pursue universal access to the health as well as the public-private partnership is very, very important. And for that, the government has already have developed some strategy. There is a need of new vaccines and new diagnostic with the TB control program and also point of care. Then only we'll able to reach to the goal of this NTB strategy by reducing the around 70% of the incidence per year. We have changed our policies and evaluating the strategy. Initially, we were mainly depending upon the patients who are coming to the hospitals are symptomatic. But now we are intensified to, and it is, we have intensified our activity for the key population, comorbidity like HIV, TB, tobacco, and also the linkages with the various comorbidity, diabetes, and all these things. So we intensify, we find that more and more cases are there in that particular population. And we have to take the opportunity to screen that population. Now we are going beyond to that, that is active case finding, and that was one of the very important aspects in the program itself. We are going to the campaign mode and active case finding in some of the slums, migrants and communities, and especially where we required to go for a campaign mode. And that is the next strategic plan. We are developing very actively case findings in that particular area. The program is having the diagnostic services like we are having the 13,000 DMC, that is designated microscopic centers where the sputum microscopies are being conducted. Government of India recently have purchased the 500 CBNAT, that is a gene expert, which detect the TB within the 2 hours itself, as well as rifampicin resistance. And we are already, every district is attached with the CBNAT. At the same time, we are having the 6 national reference laboratories and 28 ILRs, IRLs, and about 66 culture and sensitivity labs, and also 25 second-line DST for the follow-up of the patient of the MD application. And we are having well network of the diagnosis system in the country itself. CBNAT, if you see that in 2012, we are only having the 18, but now in 2016, we are having 623, and Government of India taken that this molecular test should be available at each and every district level. And with this test, we will identify the more and more MDR cases. And if you see in the second quarter itself, we got a more than what expected cases are there in identify by this particular test itself. We are having the another gene expert Omni, which is also in the pipeline itself, which also give the HIV viral load, and which is also will be coming very soon, and validation is going on, and which we can take a battery operated and portable system where we can just detect the TB within 2 hours itself in community and more reliable test. Another important thing about I would like to tell about DRTB case finding and treatment. MDR PMDT is a program where program management for drug resistance TB, where it is started in 2007 and it is 18. Entire country has been already been covered for the MDR cases for diagnostic purpose and also the case findings and also the treating the patient itself. If you see the curves itself, which shows that there is a complete rise, very high rise of the services in the country itself, and we case detection about in 2015 itself is 29,000 and 27,000 has been put on the treatment itself, and this shows that there is a gap between, there is a very small gap between the diagnosis and the treatment, but there is a still gap of 38 to 40% from the diagnosis, diagnostic gaps are there, which is in the community, and that gap we want to fulfill very soon, and we have seen that now the gene expert is already there in the community. We can just use that particular use for the detection of the MDR cases in the community, and that diagnostic gap will also reduce. But the treatment and the diagnostic and treatment gap is definitely reduced. Program has already started bedaquiline, as you know, in the 6th center. Bedaquiline is a new drug which started in the country in a 6th center under a CAP, that is the Conditional Access Program. In the Delhi, the 2 centers, Mumbai is there, Shivri Hospital, one is in the Tamil Nadu, that is Chennai, and one is in the Assam Guwahati Medical College. This 6th center has already started this particular drug, and drugs has already, first drug has been started, a bedaquiline DR patient in Guwahati in 6th June. Because last year only the Minister of Health has already rolled out this particular program. In 2016 it is rolled out in March 2016 is rolled out, and in June 2016 till today we are having the more than 50 patients on the bedaquiline, and these drugs are already, we are just doing under a conditional access program and give the good results. WHO has already recommended the molecular line probe assay for second line second line LPA. That has already been recommended by WHO to use in the country itself, and also the short regime for the MDR-TB, where MDR-TB we required a 2 year of treatment, but in a short regime is a 9 month, which team study has already been done and clinical trials has been done, and India is already, government of India is also thinking over to start this short regime for MDR-TB patient with 7 drugs and with 6 months of intensive therapy and then 5 month continuous therapy with a high dose of moxi, and that details I will, if we want, we can just give it, but with the time span we can't use, I can't give them detail. We are already, Government of India has done the anti-tubercular drug resistance survey. The National Institute of TB, Bangalore, has already, with the WHO, has already started in 2014. It is one of the biggest and largest survey in the world itself, and with 5,200 patients from the 120 TB units across the country has been chosen, and a representative sample has been taken, and all the 13 anti-TB drug susceptibility test has been conducted, and results is awaited in December. These results will definitely help for the program to chalk out or design the MDR TB cases in the program, and how the MDR TB epidemic is going on in the different part of the country itself. So which will definitely help in designing the program itself. Intensify case finding is already, you know, the 30I project, which is for the TB HIV, where the high ART center, high burden ART center in the 6 states, which are high burden states, we have just piloted this, and we found that these are the very results are very encouraging, and we have seen that about 13,000 PLHIV tested by CB9, that is expert, and 1,000 diagnostic as a TB, and 86 diagnosed as a MDR TB. And with these studies itself, and Dr. Sachdeva is also there, and on the basis of this evidence, we have just started the upfronting these HIV TB patient for the CB9 itself, and already this particular study has already been published in the PLOS, and Dr. Sachdeva is one of the authors for that. And we have seen that all these activities that which enumerated that single intensify case finding, pharmacovigilance, use the new technology of treatment like 99 dots has been used in this.
Doctor, can we conclude?
Yeah, sure. Rollout of the daily regimes. The government of India is also having the daily regimes in 100 and phase-wise we are starting. First phase we are starting in Himachal, Bihar, Sikkim and Maharashtra and Kerala, and subsequently in the entire country we will start this particular regime. Oh, sorry. Another is a 99 dots, which is a adherence system, which is also supporting the program for the adherence system, is also been under, we are using in the program itself. Another very important part is the providers engaging the provider, because unless you engage the provider it's very difficult, because most of the cases in the TB are going to the private sector, and how to engage this private sector is very important. And government is not only the sole program user, but it is the enabler who can just take the resources from the various providers and use in the program for universal access. We are having the guideline for the partnerships, like which are 22 schemes are there: advocacy, diagnostic, and TB. Whenever it is a well-placed partnership guidelines are there, which can be used. Private sector engagement, one of the best example is the IPAC, where the Clinton Foundation has already negotiated with the companies, and also the private lab, where the VR affiliated labs are there, where the win-win situation for the patient, manufacturer, and also for the laboratories are there. The public sector, private sector notification is also very, 2012 we have just make it mandatory, and with the accessibility of that standard for TB care, every private or public private patient should be used the standard for TB care, and that is, we have seen that there is definite increase in the private sector notification after this, after the mandatory notification, as well as after the electronic tools we are developed as Nikshay, which is one of the very important tools for us for the case-based, web-based notification system. And this paradigmic shift from the program itself, that is government is not sole responsible, but enabler, and we have to use the standard for TB care for the notification. Universal access for TB, which is already done started in the country. And last slide is that Pragati is a high, actually it is a political will is there at highest level. Even Prime Ministers have already reviewed this particular program with the chief secretaries of the countries, and they have said that high priority is to be given, and we have to identify the certain high priority districts and take the intervention accordingly. And according to that, we have just launched a new initiative in the World TB Days, which are already CBNAT, bedaquiline, and release the most of the guideline, and which is show the picture itself. With this, we have to see that how we have to get together or get for the NTB strategy, and that was the slogan, unite together for the NTB strategy, then only will success to achieve this particular goal. Thank you very much.
Good evening, everyone. We've heard from Dr. Kapade about the WHO's NTB strategy, and that has made the role of laboratory very crucial, because we are the providers of early diagnosis. However, in population that is HIV infected and we need to diagnose TB in them, it's a real challenge for the laboratory person because of the porcine bacillary nature of the sputum, more of extrapulmonary lesions, and also that multi-drug resistant tuberculosis is twice as common in this population. And therefore, the main need is for early diagnosis and treatment. In an HIV-infected population for TB diagnosis, the modalities that are commonly used are sputum smear microscopy, culture, expert MTB-RIF assay, and urine LAM assay. What I like to emphasize here that it is not only important to detect tuberculosis, but simultaneously also detect drug resistance. The currently available molecular assays tell us information about anti-TB drugs that should not be used, but that is not enough, and therefore we still need to rely on culture DST, that is the conventional liquid culture DST, to find out which drugs can be used. The conventional methods of diagnosis by using acid-fast staining sputum smear microscopy is a very rapid test and very reliable test. However, it has a very low sensitivity. It requires at least 10,000 organisms per mil of sputum to detect it positive, whereas the culture is highly sensitive, but it takes a long time for the reports to come because the organisms are very slow growing. But also it has an advantage that it provides the isolate for drug susceptibility testing. So in 2011, WHO gave a policy guidance on replacing conventional sputum microscopy, and in a large setup where there is fluorescence microscopy being done to be replaced by what is called as light emitting diode microscopy. This which works on the principle of fluorescence microscopy, and it has advised that it be phased in and provide an alternative to conventional ZN microscopy. Our experience at KEM also showed us that it was very sensitive and specific. Coming to culture, there are various liquid culture methods available, but the only one that is recommended for drug susceptibility testing by WHO is the MIDGET 960. When should one do culture? Culture should be requested in all retreatment cases, be it relapse, be it failure, or be it return after default, and also in all new cases, and all retreatment pulmonary TB cases where the smear is positive at the end of the intensive phase of treatment, also in symptomatic contacts of the known MDR cases, and in all extrapulmonary TB cases. A very useful assay which has become available over the last 5 years is urine LAM assay. The LAM is a lipoarabinomannan. It's a polysaccharide which is a part of the mycobacterial cell wall, and it is released from the bacterial cells and excreted in urine. And several studies have shown that it is present only in people who are having active TB disease. So there is a point of care assay which has now commercially become available and which has shown useful diagnostic accuracy. The assay looks something like this. The principle is immunochromatography, and the results are available within 30 minutes. The assay has about varying sensitivity in several studies. It has shown to vary from 38 to 100%, and the specificity also has been shown to vary from 50 to 95%. But when the results of LAM assay are combined with sputum microscopy or with expert assay, the sensitivity has shown a remarkable increase. Similarly, in patients with lower CD4 counts, it has shown an inverse proportion. That is, in people with lower CD4 counts, the sensitivity has been shown to be very high, whereas the specificity remains same at all CD4 levels. So therefore, the test is useful in seriously ill patients who are unable to bring out sputum, and where other tests of TB are not possible to do, this test is going to be very useful. Advantage over sputum microscopy which is used is that urine is easy to collect and store, and also the infection control risks are not there. Coming to molecular assays, we have been using expert assays for the last 5 years. It's the preferred initial diagnostic test in all MDR TB cases, in all HIV infected patients, and in children. It detects not only Mycobacterium tuberculosis, but also detects resistance to rifamycin. And the line probe assay is also WHO recommended for all smear positive cases, and it can detect resistance to both rifamycin and INH. So expert TB assay is a closed cartridge-based nucleic acid amplification assay, and the results are available within 2 hours, and it can be directly performed on the sputum sample. And the results are available in the form of either MTB detected, not detected, and if it is detected, what is the concentration, like very high, high, low, or very low. And in addition, whether the RIF sensitivity is also given, that is rifampicin resistance detected or not detected. The sensitivity and specificity of this assay when compared to culture is high in case of sputum smear positive samples as compared to smear negative. So in HIV infected patients, mostly it would be smear negative. So it is advisable to do more than one sample testing by the same assay, which improves the sensitivity. As you can see in the lower one, you can see that as the study was done, where there were 3 sputum specimens tested and the sensitivity markedly improved. This was our experience with expert assay on extrapulmonary samples, and we found 84% sensitivity and 97% specificity with the expert assay, and we could pick up almost 25% of CSF samples. And all these were smear negatives. Similarly, for pulmonary TB, we had done a study as a part of my postgraduate students' dissertation, and what we found that the sensitivity was 77.78% and the specificity was 96.8%. The sensitivity in smear positive, culture positive cases was 100%, and the sensitivity in smear negative culture positive cases was around 62%. Under the program, under the RNTCP, from Jan 15, we started testing all HIV infected patients as the first initial test, and so far we have done 278 tests, of which 21% were detected as Mycobacterium tuberculosis, and almost 1/4 of them was RIF resistant. And all of these were smear negative. Line probe assay is the recommended molecular test by WHO for smear positive cases only, but there are studies available in literature where this assay has shown equivocal results even with the sputum negative samples. The assay strip looks something like this. You can see mutations in various genes, and when you see the RPOB gene mutation, it indicates RIF resistance. When you see mutation in the CATG or the INHA region, it indicates INH resistance. So when you have a mutation in the INHA region, it indicates low-level resistance, meaning thereby you can continue INH in the regimen, but you have to use a higher dose. Whereas if you see a mutation in the CATG region, that means it's a high-level resistance, and therefore you cannot use INH in the treating regimen, and it should be replaced by prothionamide. In May 2006, WHO issued a policy guidance wherein it recommended the use of second-line LPA as the initial diagnostic test, replacing the conventional liquid phenotypic DST test to detect resistance to fluoroquinolones and second-line injectable drugs. And this test can be performed directly on the sputum sample, or it could be on a mycobacterial isolate. And the only hitch here is what mutations you see in this assay are not very well correlated phenotypically for 2 drugs, that is moxifloxacin and gatifloxacin. And therefore, for these drugs, you need to confirm susceptibility by the conventional culture DST. So conventional culture DST can still be used in the evaluation of patients with a negative second-line LPA. For the drug resistance, there are some important considerations which I would like to bring to your notice. The first one being that whatever molecular methods we use for drug resistance detection, they are the ones which detect genes which are encoding for resistance in specific resistance determining regions, and which are the indirect measures of phenotypic resistance. And as of now, we do not have knowledge of all the mechanisms which bring about drug resistance. And we know of certain silent mutations. That is, we see the mutations in the genetic region, but actually phenotypically the drug is useful. And therefore, we must remember that molecular diagnostics, as they are available in the current form, they can only provide information about anti-TB drugs that should not be used. And except for rifampicin, a susceptible result by a molecular platform has to be confirmed by conventional liquid culture DST. So how do you overcome this situation? In future, there are studies showing which are trying to find out whole genomes of the organism by whole genome sequences. There has been a lot of progress in this. They started with doing pyrosequences, then they went on to do next generation, and now is the time for whole genome sequences. So let us hope that this is what will give us a comprehensive picture to predict the phenotypic susceptibility. So to summarize, in HIV infected, expert is the first test that should be used for TB diagnosis. And if we detect RIF resistance, we should start WHO recommended regimen for drug-resistant TB, simultaneously do a baseline liquid culture DST for pyrazinamide, ethambutol, second-line drugs. And then when the DST results become available, if necessary, modify your treatment regimen. And in seriously ill patients, you can make use of the urine lam assay. And since current diagnostic methods such as DST take longer time and targeted molecular tests examine only a limited number of target regions, faster, more comprehensive diagnostics like the whole genome sequences are the need of the hour. Thank you very much.
Dignitaries on the dais, off the dais, friends and colleagues. Much of my task has been made simpler by earlier two speakers. I'll just fill in the gaps wherever they are needed. So this slide talks of the global distribution of estimated TB incidence, and we see India is in absolute numbers the highest TB burden country, but as far as rates are concerned, we are not the highest. We are among, I think, at number 14 in the world, but when we consider it on a population basis, we turn out to be the highest TB burden country in the world. Within the region, Southeast Asia region is the highest TB burden region in the world. And this now we'll talk about the estimated HIV incidence or HIV TB coincidence, total co-infection in the globe. And as you see, India is not one of the countries where we have a high rate of HIV TB co-infection. The highest rates are seen in the African continent. India, the rates are quite modest, around 5 to 6%. So having said that, even with this, when you translate that into the absolute numbers, we become the second highest TB HIV co-infected country in the world. This slide, Dr. Khapade already alluded to. Suffice here to say, number 1 country for TB, number 2 country for TB and HIV co-infected patients. And again, the highest MDR TB burden in the world. TB being the most common opportunistic infection in the HIV infected patients, the TB HIV collaborative activity started way back in the year 2001. Gradually, they were scaled up. Initially, these activities were confined to only those patients who had a history of high risk for HIV, and all TB patients who had a high risk behavior were earlier screened for HIV, and all HIV was, those who were at high risk for TB were screened for TB. But later on in the year 2007 and 2008, the policy was changed wherein all HIV patients were being subjected to TB screening, and all TB patients were being subjected to HIV screening. So that policy came around in the year 2008, and now the entire country now practices this bilateral screening of both TB and HIV. We have gone a step further, which I think Dr. Ganga Ketkar at one said when he was delivering his talk. He brought out the need to reach out to more, diagnose more and more HIV cases in the community. So now even TB suspects are also being screened for HIV. So TB suspects is also considered as a high-risk group for HIV infection. Within the TB HIV collaborative strategies, there are broadly 3 principles which are used. One is to establish and strengthen the mechanism of delivering integrated TB and HIV care in the country. The second is to reduce burden of HIV in TB patients, and third is to reduce burden of TB in HIV patients. So the country is implementing all those activities which are articulated in the global document, except the INH prophylactic therapy, which is being rolled out from next month onwards. So what is this joint TB-HIV collaboration talks of? So it talks about a coordination mechanism at the national level, the state level, and the district level. It also talks about joint training modules, standard recording and reporting formats, joint supervision and monitoring and evaluation of both the TB and the HIV programs. I've already alluded to that these coordination mechanisms exist at the national level, the state level, and also at the district and the sub-district level. The approaches in the coordination talk about prevention aspects, which is the INH preventive therapy for all PL-HIV who do not have TB. Then the airborne infection control at all HIV care settings, so that if they have TB, they do not transmit tuberculosis to other HIV patients who are immunocompromised, and also then raising awareness among the general people and the patients and other stakeholders in particular. The second is early detection of TB or stroke HIV, which I just alluded to earlier. And then the prompt TB treatment of both TB as well as HIV, and starting both treatment as early as possible within a maximum gap of, say, about 2 weeks to 2 months. And management of TB HIV in special cases. Within PL-HIV, we talk of a strategy which is known as a 3I strategy, which talks of intensified case finding in HIV patients, intensified case finding for TB in HIV patients, airborne infection control in HIV care settings, and INH prophylactic therapy. So all these 3 components of 3I strategies are now being implemented by the national programs. This is what has been the achievement so far, and as you can see, these achievements have not come in a day. Gradually these activities have been scaled up, and now, as you can see, almost 85% of TB patients now know their HIV status, which means that almost close to nearly all TB patients are now screened for HIV. Similarly, the second is offering cotrimoxazole preventive therapy to these patients. So close to 95% of patients are having access to the cotrimoxazole preventive therapy. Similarly, the HIV-infected patient, TB patient who receive antiretroviral therapy has been scaled up in the past 5 or 6 years from a level as low as about 40% to current level of about 95%. So again, this is what the coordination mechanism has brought about. Having said that, the mortality within TB-HIV still remains high, and to address those concerns, certain policy decisions have been taken. And again, my earlier speaker have alluded to some of these policy decisions. One is offering a rapid TB diagnostic, molecular-based TB diagnostic test known as GeneXpert or cartridge-based nucleic acid amplification test as a generic name to all HIV-positive patients from the beginning. Giving daily regimen to TB HIV co-infected patients. As you know, the currently TB program offers intermittent therapy to all their patients. Again, the program itself is also now shifting to a daily therapy. But this daily therapy is being already implemented for TB HIV co-infected patients. Then intensified case finding, special functionaries called care coordinators have been appointed by the national programs to bring about these intensified case findings. Then there are standardized electronic training modules, and there is also a risk assessment for airborne infection control in HIV care settings. This policy decision has already been talked about, offering gene expert to all HIV positive TB patients for early all HIV patients for early diagnosis of TB. The program, as Dr. Khapade had shown, now the country has about 628 these gene experts machines in the country, and practically all districts have been linked to availability of these machines. So in whichever district these machines are not there, their sample is corrected and transported to the nearest district for diagnosis of TB. Airborne infection control, again, the baseline assessment of all ART centers has been completed, and this has been, all elements of airborne infection controls are now being implemented within the national programs. Daily therapy, again, I've already alluded to, and my earlier presenter also showed that within the daily therapy for TB, HIV co-infected patients have already been rolled out in the year 2015 itself, currently being scaled up to the entire country, and daily therapy for TB is now also being initiated for all TB patients irrespective of their HIV status. INH prophylactic therapy, earlier having accepted this as a policy decision, there were some constraints in rolling this out. The programs have now sorted out those challenges and constraints. Trainings of all healthcare providers on how to initiate INH prophylactic therapy has just been completed last month, and from next month onwards, the country will be rolling out IPT in the entire country. This is a project which, again, I have already alluded, Dr. Khapade also alluded, wherein the TB, HIV co-infected patients were offered daily therapy. This was rolled out in the year 2015. It's more than a year and a half now, and we have good results. About close to 15,000 TB HIV co-infected patients that already have received daily therapy. There are encouraging results on the use of daily therapy in TB HIV co-infected patients. The mortality is on the decline. And within that daily therapy, to substitute so-called the directly observed therapy, which is the mainstay of TB program, they have introduced an innovative technology which is called 99 dots. Again, my earlier speaker alluded to this, wherein you just have to, patient just have to give a missed call if you consume a drug. So direct observation in reality may not be necessary. You can dispense patients and treat a missed call as a close proxy to having consumed drugs in your presence. So this talks about how to consume those drugs and what has been the outcomes of this. And the study has shown that it's called 99 dots because 99% of the times when a patient gives a missed call, he has actually consumed those drugs. Again, this we have already talked about for awareness generation. There's a strategy which is developed, combined by both TB and HIV programs. There is a training platform which is now electronic based. There are various guidance documents which have been jointly developed by both the programs and also available on the websites of both the programs. The operational manuals for healthcare workers are also available. Also, they can be downloaded from the websites of both the programs. India has been cited as a best practice in the TB HIV co-infection rollout in the WHO documents, and this is just to showcase that. So the priorities in the now coming years are scaling up use of daily regimen in the TB HIV co-infected patients, scaling up intensified TB case finding in all ART care settings, rollout of INH preventive therapy, focusing on delivering quality services and intensified supervision and monitoring, and provider-initiated testing and counseling of presumptive TB patients or patients who are suspected of TB, and implementation of airborne infection control in all HIV care settings. So having said that, thanks for your attention.
The organizers as well as to all of you and to the respected chairpersons for giving me this opportunity. And before I begin, let me make it very, as my disclosure, that I am a infectious disease physician and practicing in a tertiary care center, and most of my cases are not pulmonary, they are extrapulmonary, chiefly CNS TB, and my remarks this afternoon should be with these 3 points in mind. Okay, so we already know that what is the problem of this drug-resistant TB, and basically the harder you look for, the more and more will you find the incidence of TB. And that's what is shown by. कहीं नहीं चला तेरे? क्यों प्रॉब्लम हो रहा है? ऊपर जाना? Okay, so much so that if you use more and more sensitive tests, it doesn't come as a surprise that implementation of expert MTB RIF has led to an increased detection of RIF resistance by over 5-fold, and these are figures from my previous speaker, Dr. Sachdeva. So my outline is as follows. We'll talk about a use of an individualized tailored regimen, and as I'm telling you that my perspective is not of the program, we use every bit of clinical and lab information that might be available to us, some which is apparent, some which is somewhat hidden. And also we like to optimize the doses and do source control whenever possible. Okay, look at this girl. She's a 14-year-old girl who has had this axillary lymph node TB and has been on a first-line ATD for a long time, but apparently has been failing. And she is on this regimen, which is of 9 different drugs, but all of them have been on with suboptimal doses for 1 year. Obviously, there was no relief, and she presented to us. We did a culture, and this is the susceptibility, which tells you it's resistant to RIF, INH, ethambutol, and pyrazinamide, and obviously streptomycin. So what might be used for treatment? So there has been a notion that even when you have resistance to the first-line treatment, you may keep the first-line drugs on board. I'll sort of differ on this point because we know that there are lots of interactions between rifampin along with others. So giving rifampin and INH as along with the second-line drugs, I'll submit to you, is not a good option. Rifampin increases the efflux of ofloxacin in RIF-resistant organisms. It also reduces, so this is a dynamic interaction, and there is also a kinetic interaction because of induction of enzymes. So rifampin reduces the levels of moxifloxacin, which is such a valuable second-line drug, by as much as 30%. Even INH might reduce the tissue penetration of clofazimine, which to my mind is a very important drug. So optimizing any of these doses of 9 drugs which were failing is definitely not a good option, obviously due to toxicity, interactions, and the expense. So we use a regimen with kanamycin, moxifloxacin, ethionamide, PAS, and clofazimine based on the DST. But I'll also tell you that this empirical choice, once the DST comes, and as Preeti told us that it would take more than maybe 8 weeks for that result to come. So what can the clinician do? And so the clinician must know what is the prevalence of mutations to the injectable second-line agents as well as to the oral second-line agents in his local area. And that is, we did a study on this, and everyone should know what is the likelihood of resistance or susceptibility to all these agents even before the DST returns. Also, I'll remind you that this treatment is very toxic, it is prolonged, and it's expensive. And therefore, the physician must consider as if this is the last chance to cure the patient. Don't hold back any drugs for various reasons. Expense is definitely an important problem, but then let me put it this way, it's a question whether we can afford to, but whether we can afford not to treat. Because when you don't treat, how many more problems are going to come up with that? This is our study which we did, which we called as a successful management of highly drug-resistant TB with individualized drug susceptibility testing. And a few salient points about these were, although we may focus on XDR and even more grades of resistance, is what is MDR plus and pre-XDR forms a very large chunk of the population. And let me tell you that the options for these patients are also almost equally compromised as those for XDR. So we tried to devise regimens using PAS, clofazimine, linezolid, and so on, and these as the other drugs which would be useful. WHO till now has always been telling that the reproducibility, reliability, and the clinical relevance of the DSTs of these oral second-line agents is still under question. So we tried to show that this, if you devise a regimen using all this DST information, you can still get a good result. And if you look at this, we had 49 out of 52 patients had a good outcome. However, 34 different regimens had to be used to treat these 52 patients. What does it mean to us? That an empirically, widely applicable programmatic regimen is very, very difficult to have. Okay, so it's that is something which we need to think about. Then the clinician should make it a point to use every bit of clinical and lab information. And I'll give you an example of this. Now, this is a 19-year-old girl again who had fever, and as you can see has miliary TB on an HRCT done before and was started on HRZE. The fever reduced, but she remained unwell. Then the doses were increased because she wasn't doing too well. She also had severe arachnoiditis, as you can see there, and paraplegia and sphincter involvement also. So at that stage, her treatment was, she was referred for an ID opinion. The sputum as well as CSF was negative for expert MTB as well as, so far the midget cultures were awaited. So what do you think can be the immediate option for the clinician? Would it be to change because the patient is now developing more and more arachnoiditis and a paraplegia to a second line treatment, or increase steroids or add fluoroquinolones, or none of the above? And you are with me if you would say none of the above, because this previous imaging was a HRCT, which is not with contrast. So what we did is just looked at the corresponding X-ray chest, and as you can see there is a bump in the right paratracheal region, which is a necrotic mediastinal mass, as you can see on the new CT which was done. So there was an opportunity to do a CT guided biopsy of that lesion, and that showed that it was MTB detected was very low and RIF resistance was detected. So at that stage, we know that the biopsy is now showing RIF resistance and INH resistance by inference. At that stage, if we do an LPA or a DST on this sample, will it help? Again, the LPA second line has always been in a question, but it will inform resistance to fluoroquinolones, injectable agents, and ethambutol within a short time frame. It is not even enough to just go by the final report of the LPA, because the final report, if you find some bands in the some bands for the fluoroquinolones, it will be reported by the LPA as resistance, but we must know which of those bands are going to really produce a high grade of resistance to the fluoroquinolones. So examination of these specific bands can also reveal more information. And we did a small study on this. For example, Preeti just told us about the various wild types and the mutant 1, 2, and all those things for fluoroquinolones. And what we had found is, if you find that there is a mutant 3B, then it correlates with resistance to high level moxifloxacin. So moxifloxacin can be tested at a critical concentration of 0.5 as well as 2. And if you find a mutant 3B, it generally indicates that even there would be resistance to moxifloxacin even using a critical concentration of 2. So in those situations, probably even giving a high dose moxifloxacin may not help. Now in this patient also we had asked for a DST because it is always essential, and Preeti has emphasized that point, that even if you have any number of good molecular tests, you still need the final DST, and I'm going to argue saying that even DST is not the final thing. Now if you have a lymph node midget culture coming positive, the full DST should
be asked for. And again, I'm telling you from a perspective of a tertiary care sort of treatment. It's not basically for everyone, but whenever you can, you should do it. And especially when the MTB load is very low. Please remember that there is going to be a little bit of a reduction of the specificity of rifampin resistance, and that is because of the instability of the probe wild type complex, and therefore amplicon probe complex, and therefore you might get a little misleading RIF resistance if the bacterial load is reported as very low. Also, we must remember this polydrug resistance. That means some of the resistance to, say, only clofazimine, which is not very common, but to PAS or ethionamide is also prevalent. And therefore, it's very important for us to know that. Finally, the patient may go on to develop some toxicity, and you might want to change or fine-tune his regimen because of his toxicity. And if you don't have the full information which the DST can give you, it might be difficult to actually optimize the treatment. Now look at this 30-year-old lady. She presented with features of tuberculous meningitis, and as you can see, there's a tuberculoma as well. And in this situation, the expert from the CSF, as Preeti again said, that the sensitivity of CSF is not that great. You know, if you get it, it's fine, but otherwise it's not that great. So expert MTB RIF was negative in this situation. TB midget culture was awaited, and the patient was not doing well on the primary line of treatment. And here this pyrosequencing can help us. So here we found that there is a CATG mutation which tells you that you can neither use low or high dose of INH, but INH promoter mutation was not there. So perhaps this patient can do well with ethionamide, which also has good early bactericidal activity in the CNS. So it becomes an important drug in the tuberculous meningitis group. There were no other mutations. There were some silent mutations for rifampin, and therefore the pyrosequencing report would tell us that you would have to rely on the DST in this particular situation. My last point is about optimizing doses and source control whenever possible. So this was a girl with TB meningitis which was highly resistant. It was like a pre-XDR or XDR. And while on treatment, just see what has happened to the moxifloxacin. It was susceptible at 0.5, but 1 year later she wasn't doing too well. Of course, she developed multiple infarcts and was on steroids and so on. But when a repeat culture was done 1 year later, the moxifloxacin had now become resistant at 0.5, but it was susceptible at 2. So what could have been the reason? Could it be that the AUC-MIC, which is the pharmacokinetic dynamic parameter which is required for efficacy of fluoroquinolones, that was not achieved in the CSF? Or that the critical concentrations in DST are not really clinical breakpoints? Or there could be reduced penetration into CSF because of the dose of steroids which was impossible to reduce, and maybe all of the above. And I think it might be all of the above. So although we know that AUC over MIC of 25 is optimally kills MTB, and I'm talking of quinolones, we must remember that this particular PK/PD parameter also readily amplifies resistance. And hence AUC-MIC of 53 is probably the optimal PK/PD target for MTB and fluoroquinolones. And if you look at this simple chart which tells you that only 70% of moxifloxacin gets into the CNS, you will find that you cannot actually achieve AUC-MIC of 53 in the CNS if the MIC is greater than 0.5. If it is 0.5, you can go up to 90 if you use a dose of 800. But if you look at a MIC of 1, then you are not going to achieve that. In other words, you cannot achieve the pharmacokinetic PK/PD parameter in CSF despite the highest doses. And we also know that there are bacterial populations with differences in resistance and fitness which are obtained in serial samples from the same patient. So although it might not be a big issue in the lungs, because lungs are very well vascularized and perfused, so the mutant selection may not occur in the lungs, but it might go on in the CNS despite using the highest possible doses of moxi, which are like maybe 800. My last point is about, we just rate at the moment because that is the gold standard, considering that we are using DST in liquid TB midget and all that. However, I'll submit to you that even that may not be correct. The drug resistance which is defined in DSTs is not defined by clinical breakpoints but by critical concentrations, and these critical concentrations are based on ECOFs, that is epidemiological cutoffs. If you're not familiar with this, it's more of a laboratory epidemiological value which separates the MICs of wild type strains from MICs of those with mutations. Okay, it doesn't tell you whether that can be achieved at the site of infection, that concentration, and where there's going to be differences in the geographical distribution of various organisms and so on. It doesn't tell you whether by achieving that level you are going to get a cure, unlike the clinical breakpoints in bacterial and other fungal organisms. It has also been said that the current concentrations or critical concentrations are over optimistic and they should be set lower. And what would really happen if that is done? The MDR rates would be actually 4-fold higher. So what we are currently calling as susceptible to RIF, if you use a CC of 1, versus there is a move to make that CC of 0.25. In other words, there will be so many more RIF-resistant organisms which will be reported by the lab if that is adopted. Traditionally, we have always been told to use the least effective dose rather than the highest tolerated dose. Please understand what I'm trying to say. Okay, so that has been the traditional way of treating every infection or every disease for that matter. However, that may not be the right thing to do, and we may have to really try and give the highest tolerated dose rather than the least effective dose as far as dealing with tough organisms like this. And for that, you have various simulation studies such as this Monte Carlo simulation. If you're interested, I'll tell you about it a little later on, which tells you what is the dose which gives you a 90% probability of target achievement. Okay, so it's a sort of a simulation of organisms and patients which tells you that. And let me tell you again that there are great perils of using smaller doses because these sub-inhibitory levels actually increase mutation rates. Fluoroquinolones, where are they acting? They are acting on the DNA coiling and supercoiling. So they are going to produce more and more errors in the copying process. Fluoroquinolones also induce efflux, can produce cross tolerance. There are certain strains which may have this S531L mutation, and they will develop more and more mutations in RPO A and C, which is not even checked by the expert. And these can increase the transmission fitness as well as fitness of these organisms. And all this time it has been told to us that basically the resistance is evolving in the patient under exposure to drugs which is suboptimal. However, let me tell you one thing, that in areas of high transmission, it is the transmitted resistance which is driving the epidemic of MDR-TB in high incidence settings. It was always believed, all this as medical students they have told us, that you need 10⁹ or more organisms to have that one mutant. However, that's also not correctly thought to be true. It was thought to be a single step mutation. However, we now realize that it begins with stepwise acquisition of mutations, which starting with ones that only increase MIC slightly, and therefore they would be even missed by the DST using the current critical concentrations. Also remember, they are defined that when you say susceptibility, it means that 90% of that population is susceptible. It's not talking about that 10% which might grow on to replace the whole bacterial population. In other words, full resistance is just the tip of the iceberg. Now this question I would pose to myself and to all of you. Will new drugs, bedaquiline or whichever other ones come, will they solve the problem? We certainly need new drugs, I'm not saying that, but merely having new drugs is not going to solve the problem. There was a time, friends, when we had effective drugs, we had susceptible organisms, and we are still grappling with the problem, and the whole idea is it's there because of poor implementation. We have to do something about that too. As a private practitioner, I would just say that a tailored regimen is actually required for each and every patient. How it will be done, it's beyond me, but that's what I think we should be doing. Fluoroquinolones, linezolid, and injectable agents should be used exclusively for resistant TB. I can't think of any particular indication in the bacterial infections world where you really need only these drugs and no other. There is always something else which you can use. You shouldn't use fluoroquinolones for treating community-acquired pneumonia and such things. Linezolid also is not necessary to be used. There can be some other drugs. And most importantly, transmission has to be curtailed. So if I have to summarize, I must say that a physician who is starting treatment for MDR, XDR is undertaking a public health responsibility. So he must know that. He should suspect drug resistance if disease progression is occurring more than 1 month on so-called effective optimized treatment. we must look at every bit of information from all the molecular tests as well as the DSTs. You should never add a single drug, and all these recommendations are already known. And finally, we should treat the patient as if this is the last chance. And with this, I'll stop here and just say that new drugs are there, new tests are there, and most of all, new awareness is there. And I think that all these things might sort of shine a new light in this dark and depressing landscape of TB. Thank you very much.
As usual, it was one of the fantastic presentations. Everything. So you might be thinking that treating MDR is very, very easy, but it is not. There is a lot of dedication, efforts, and the commitment which he is having. It's required. So now the topic is open for the discussion.
India did a lot of mistakes in treating their patients with TB. This was right from the beginning when we started DOTS. When the DOTS, we started only one drug for a failing regimen. We are trying to follow INH prophylactic therapy for patients with HIV and preventing that. The data coming from South Africa and African countries where there was significant decrease in terms of mortality, where even though there was no TB, just adding an INH and early treatment of ART helped those patients with mortality. I do not know the ratio of the primary INH resistance in Africa, but probably in India it may be about 10% or more. Probably people may be able to tell me more. But in a situation like that, do we think that by adding INH single drug therapy will be creating more drug resistance even to INH further and further? Could be answered by the Dr. Sachdev and maybe then Dr. Raju Suman.
So the levels of INH drug resistance which are seen on a programmatic basis, I mean, which was, we were doing drug susceptibility on phenotypic methods about few years back. Now we have switched to molecular DST. So based on the little data which is available in the year 2007, 8, 9, the levels of INH drug resistance in the primary INH drug resistance is about, again, 10%. It varies between 10 to 15% or so. Having said that, that issue remains a challenge, whether the patients who are having TB and when you put them on INH prophylactic therapy, are you likely to generate more resistance or not? That issue is not solved as yet, but yes, the IPT remains one of the recommendations the world over, and our INH, primary INH resistance are not very different from most of the other countries. Still, the last word on IPT is not out. How successful the IPT is, what should be the ideal duration of IPT, is 6 months enough to protect, how long will it protect? But what has been seen is that 6 months of IPT at least gives you some protection for about 2 to 5 years, and it has shown a decline in TB incidence in countries where it has been implemented. The last word on IPT is still not out. The research needs to be carried out, and South Africa is one of the countries which is leading this research. Yes, please.
Dr. Soman first.
Yeah, although, I mean, I entirely agree that the rates of monoresistance to INH are roughly 10%. Here we are dealing with a person who's not having an actively multiplying bacterial population. Okay, so it may not be that important, because this 10% is in patients who have full-blown disease, and therefore the chances of those people having latently infected ones with INH resistance becomes somewhat less. The other major problem, as I see it, is you hardly have a patient who's not got active TB. You know, at least I can't remember too many patients who have presented, who have come to me for HIV and do not have active TB at that stage. And therefore, in my practice, to use IPT has become a major challenge. Now, those people, like they said that they were going to train the medical doctors, the medical officers and so on for implementing this. See, it becomes even more important responsibility of the doctor to see that he has to change when there is an evidence of active disease. You put somebody on IPT, he comes, you have to very, very closely monitor whether he's getting an active TB disease somewhere, because otherwise it's a sin to continue with that active IPT while he has already developed a reactivation disease somewhere. So these challenges are extremely important, and all these things we need to carefully consider whether when we sort of jump onto this IPT.
Yeah, so basically my question was the same thing, that in a country like India, just following a data from South Africa where we had a good response to IPT, whether India should be taking up the lead in taking this, because see, this was even previously being done for cancer patients, for other patients where immunosuppressive therapies were being given, and they were given single drug INH prophylaxis. But now most people who are doing transplant program on a regular basis don't put them on a INH prophylaxis. Most patients who treat their patients with immunological disorders don't put them on INH prophylaxis. So whether here is going to be a huge, large population where we are going to put them on an INH prophylactic therapy, is it a really good idea, or whether we should really be waiting? And
again, I'm saying the same thing. If you ask me, there won't be so many patients like this.
So can I
There
add?
will be, most patients will have active TB disease when they come to medical attention.
So,
So the chances of, that's what I feel. Anyway,
Let me add, the data from program is different, the data coming from tertiary care institutions. There is a data and studies available. The 4 symptom screen which the program uses is almost 95% more than sensitive and specific. So if you not have one of those 4 symptoms, there is 98% chances that you will not be having tuberculosis. So IPT is only offered once you rule out active TB. The data coming from program is when you screen HIV positive from patients on those symptoms, around 5% of them report those symptoms on any day of screening. Of those 5% who report with symptoms when they are tested for HIV, for tuberculosis by any method, around 1/5 of them will be positive for TB. So it's about 1% who actually turn up positive for TB at any point of time. They are at risk at all points of time. So that screening has to continue continuously. So the data from tertiary care institutions and the what we see in the community is much different. Dr. Khapade can add on more. Yeah.
Recently, the WHO has given the recommendations for this particular thing, IPT. That is the rifabutin plus INH. That is a 6-week therapy, and that is not a 6-month like INH. We are giving the single drug for IPT as a 6-month for children and HIV patient as a IPT. But that is really a very large, because most of the people for 6 months is just like a therapy itself. So it is very difficult to, now the WHO have come with recommendations for the rifabutin plus INH for only for 6 week doses, and that is not a daily doses also, once in a week. So that type of combination of therapy which is already been recommended by WHO, and that is really a very good for immunoprophylactic, IPT purpose.
Sir, first of all, thank you for such a wonderful presentation about tuberculosis from all the experts on the panel. Here, more than a question, I have a suggestion that many doctors, the doctors who are in the field of HIV, they know, they have a little better knowledge about treating tuberculosis, but in general, the proper diagnosis of tuberculosis, we seem to be lacking in the general physicians community, general doctors community, which is the reason, as Dr. Suman has said, that though we had good, efficient regimen, we could not control this disease as it is expected. So having the national authorities on board, it is a humble request to strengthen the public-private partnership and education of the private sector's doctors in terms of diagnosing and treating the tuberculosis.
Thank you. Lav, you want to comment? Thank you. A pertinent point, and I think also in terms of the national strategies on TB, we have a lot of learnings also to do towards HIV on this public-private sector partnership that should be there. So I thank Dr. Sunil, Dr. Mehta, Dr. Sachdeva, and Dr. Rajiv for their presentation. Maybe we can have the...
Yeah, I request the chairpersons to kindly felicitate the speakers. Dr. Preeti Mehta. Dr. K. Sachdeva. Dr. Rajiv Soman.
What I would like you to do is get into your Asicon apps, if you can please do so, and press the quiz area, the quiz button, and hopefully we would go, there are some questions that I would like you to answer. They come right through the talk today, so just keep your eyes open when I say please vote, please vote. Does that make sense? And just submit it. Don't just vote and not submit it. All right? Are you okay with that? Yeah? I want a loud yes or no. Yeah? Thank you. Thank you, Ed. And should we start off?
Right, I was just saying, I don't know if you had the Duracell battery handle over here, which we have in the UK. But it goes on about staying power. I don't know how you do it. I mean, you've been here since 8:30 this morning, and no tea breaks. Tea breaks were cancelled. So it's fantastic testimony to your desire to learn more. Anyhow, this is going to be a quick session, which Jyoti and I are going to do a little dual act on. And so I'll get straight into the first patient. And some of the questions are very easy. And I'm going to do a little bit of review in the middle of it quite quickly, because it's so late. But we have a 37-year-old man who came from sub-Saharan Africa, and he was perfectly well. He had a focal fit. And at that time, he'd been having fevers, he had a headache, and he went to his GP, and the GP was on the ball, urgent CT scan the same day, and got the phone message back saying, this shows what I think is a glioma from the radiologist. She then organized a rapid appointment with the neurologist, but the patient thought, hang on a moment, I come from Africa, there's a real risk I might have HIV. So he nipped down to the sexual health clinic and got himself an HIV test, which was positive. Went back to his GP and said, does that change things? And she said yes, and was admitted under my care. So on examination, the only additional feature to the fact the patient had a fever is that they had some weakness in the left lower limb. And you've got a CT scan there, which you can see. And so we move on to the first question. Oh, I do that. What is your diagnosis? And here are the options. You can read them. All right. Toxo, meningitis, TB, tuberculoma, basically, primary CNS lymphoma, a cryptococcoma, PML, or something else.
Please vote.
So you have, I'll count down from 10. So 10, 9, 8, 7, 6, like blast off, isn't it? 5, 4, 3, 2, 1, half, 0. So can you?
Yeah, well, I don't know. Is anything, it's there, yeah.
Oh no.
Tarun?
Do we know the answer? So does it come up? Ah, well, anyhow, good fun voting. Is there any way it can?
Tarun?
No, it's
No?
just information.
Okay, let's move on.
Jyoti and I thought something else might happen, but anyhow. So you all know the answer. You think it's cerebral toxoplasmosis. So the next question is, what are we going to do about this? Are we just going to go straight in and treat and organize an MR scan? Are we going to hold off with the treatment and organize the MR scan?
Are we going to, we were going to vote here as well.
Yeah.
Is it possible, Tarun, at all? Okay, let them...
Read it.
No, let them vote while you're reading it, please.
Ah,
Oh.
right,
Oh,
excellent.
my God.
Does that come up?
Yes.
Success. I can't read it, though.
Okay.
Okay, let's just go back. I think
most people have voted for
tuberculosis. Well, I mean, it's common here, so I can understand that. And I think we get another chance having a look at the MR scan in a moment. Toxoplasmosis, I see, is the third likelihood, which is surprising. But you don't have a CD4 count, and, you know, I can understand that. But it is the most common cause of somebody with a focal fit and a fever and a short history if they have a space-occupying lesion, which the CT scan shows they obviously do. Okay, so the next question I said to you was, what are you going to do? Are you going to treat for toxo, organize an MR? Are you going to wait before you start treatment for toxo, still organize the MR? You've got the questions up there. Are you going to treat for TB and try and confirm the diagnosis, maybe a CSF? Are you going to treat for toxo but only get an MR scan if the patient deteriorates or something else? So vote now. So when everybody's had a chance, okay, let's get the answers. Do they come up pretty quickly this time?
Tarun?
Wow, excellent.
Excellent.
Okay, nothing I can teach you. So there you go, there's the MR scan. You can see a large amount of edema around on this cut, a single enhancing lesion. It's not classic ring enhancing, but it's certainly enhancing a lot. And the edema, which is prominent, and that is pushing the midline across, so you have midline shift. The patient was started on antitoxoplasma therapy, and the patient responded. So the clinical challenges are diagnosis. How do we diagnose it the most accurate way, if we can? Optimal treatment, when to use steroids, when to biopsy, what to do about persistent changes. Or to put that around the other way, how long do you wait before you consider getting a biopsy if you have persistent changes despite the patient getting better? When to start HART? You start it immediately at 2 weeks, at 6 weeks. When do you start? And when you get that situation, when you started HART and they get a relapse of their symptoms, how do you distinguish iris from an actual relapse of the infection? So I think you know this. Toxo, typically you have fever, focal neurology and confusion. About a third of them have fits. It's a shorter history than, say, you get with primary CNS lymphoma, and certainly against progressive multifocal leukoencephalopathy. CD4 count usually under 100. Rarely do you see retinitis. I've never seen encephalitis coexisting. But the MR scan is critical, and the MR often is the way you make the diagnosis. But it makes no difference if you have a space-occupying lesion or multiple space-occupying lesions. You would normally start with treatment for toxo as you try and confirm the others, because it is the most common. So toxo on scan, usually it's multiple lesions you see. It's prominent ring enhancing, and I've got another scan here of the cortex of a lesion there, and you can see the enormous amount of edema, and you can see the ring enhancement, classic ring enhancement. You also get them in the basal ganglia and the brainstem commonly. You can get them anywhere. Normally you see 3 or 4 lesions. This patient I've just described only had the single lesion. And compared to a CNS lymphoma, they are usually homogeneous in their enhancement. They are usually periventricular, as you can see here. They can be anywhere in the brain, but they are, as I say, usually against the ventricle wall. Here's what happened to our patient. You can see after 2 weeks treatment, there's been a significant reduction in the edema, although the lesion looks pretty similar. And this is somebody with primary CNS lymphoma, which I just showed you. And after 2 weeks toxoplasma therapy, there's no change at all in the enhancement. So just one other thing to say, that the CD4 count can be really useful. Now, in that first patient, the CD4, I think, was about 100. This patient had a CD4 count of 870. So that is not going to be toxoplasmosis. And when this Zimbabwean lady, when we actually get to getting her serology results back, she has cysticercosis with very strongly positive TNA solium serology. So the important thing is the CD4 count. So use that whenever you can, because that's going to rule out certain possibilities. TB was the one that was thought as being the most likely, and of course TB can occur at any CD4 count at all. When do you get CSF? Well, you get it when it's safe to get. The first patient had midline shift, so you wouldn't do it then, but we just speak to the radiologists and confirm with them whether it is safe to get one or not. The actual PCR, Toxoplasma PCR, which I'm sure you can get here, has about a 95% sensitivity and about a 95% specificity. So if you have it, it's a good chance that the patient has toxoplasmosis. But also the reason to get a CSF is because you can exclude other diagnoses, especially primary CNS lymphoma. What is the place of steroids? Steroids you're going to have to give if there is midline shift or tentorial shift. But you try and avoid it if you can, because it can muddy the waters. Because a patient with primary CNS lymphoma also has a lot of edema. The edema will settle, but of course the patient still has the lymphoma. And you get the misimpression that the patient is actually improving when they're not. So what about a biopsy? When do you do a biopsy? When therapy has failed, when there's a reliable history, the patient's been taking their Cetrin, when you take away the steroids and the lesion sort of comes back or the symptoms come back, when there's one lesion and it's atypical, and when you have a high CD4 count. So this patient had a CD4 count of 333. I'm not going to spend much time with it, but there's a lesion there which is atypical for toxoplasma. Her CD4 count is high. It's in an atypical area. And the second MR scan was no smaller, it was bigger, it was biopsied, and it was aspergillus. So do biopsy if things don't seem right. Don't assume it's toxoplasma. And of course, with tuberculosis being so common, it could be tuberculoma, but that is very big for a tuberculoma. But if there is a possible tuberculoma, you would be doing a CSF, you'd be looking for tuberculosis. And usually they are multiple. So what is the optimal treatment for toxo? There have been several studies, but nothing recently. So it's either sulfonamide, which is sulfadiazine with pyrimethamine, or clindamycin with pyrimethamine are the number 1 and number 2. And pyrimethamine, when you give it with sulfadiazine, is more active in the studies, but it causes more side effects. On an intent to treat analysis, there is no difference between the two treatments. And if you look here at one of these, you can see that their mortality, it's the probability of disease progression, is much greater if you use clindamycin with pyrimethamine than it is if you use sulfadiazine. But the number of side effects that you get with the sulfadiazine means, as I say in an ITT analysis, they come out the same. I would always use sulfadiazine with pyrimethamine as my first choice, and only switch if there is a problem. Cotrimoxazole is a useful alternative to sulfadiazine or clindamycin with pyrimethamine. And you should get improvement within about 5 days, although the scan may not improve for a couple of weeks. What about the persistent scan? So this is a patient who was referred to us when they made the diagnosis some time after they treated him for a bacterial abscess. And you can see that over a period of 4 and 8 and then 6 months, there was very little change in the actual lesion, the periventricular lesion. So the point here is the scan can remain abnormal for a prolonged period of time. And when it's a lesion as big as this, it can remain abnormal for life. So here's the next question. When would you start ART in somebody who's got cerebral toxoplasmosis? Immediately when the patient has been diagnosed, and they come in with a space-occupying lesion, would you start them then, as you start them with toxoplasma treatment and you sort out an MR scan? When they're established on their toxoplasma therapy, about 2 weeks or around 2 weeks, so I think B, once they're on in the first week, then around 2 weeks, not much between B and C there, and D, when you've completed toxoplasma treatment at 6 weeks, and E, not before 3 months. So why don't you vote now?
Vote, please.
Vote, please. It's not long, all right? First case is nearly finished. Okay, let's have a look. Oh, hasn't come up yet. We're ready? So around 2 weeks, and I don't think I'd treat immediately, all right? I think starting out, when you have somebody with a lump in their head, or you have cryptococcal meningitis or TB meningitis, I think you regard the possibility of RS and the damage that RS can cause if you start them at the same time as being much more significant if it's a CNS problem. And so for cryptococcal meningitis, I think all of you would say, well, you'd wait probably 4 weeks, 3 to 4 weeks. And for cerebral toxo, I would always wait at least 1 to 2 weeks before starting treatment, but not give it immediately. And also, you're giving a lot of drugs at the same time. RS, very difficult to distinguish what is RS from a relapse of their infection. You've got somebody here with pre-treatment, week 1 with the edema settling, and then week 6 when they've come back and you can see a bit more midline shift. If somebody has had good adherence, if they haven't had a rapid CD4 count increase, and if there is significant edema, quite often that is related to RS, but you may need to do a biopsy. And that's it. I don't know if there are any questions regarding that case history. Please, any comments? I know it's terribly late.
Any questions that anybody wants to ask regarding this case? Last slide.
You want to ask later?
No, the last slide. Can you go back to your last slide, Ed, please? What about the last slide? Sorry, would you like to come to the mic and tell us?
Actually, toxo-RS is uncommon. It's not like other CNS diseases, not like tuberculosis, for instance, where it's much more common.
Rapid CD4 rise.
Rapid CD4 rise. Well, that's true of all RS. It's what's been found in sort of observational studies. I don't think it's a strong predictor, but it is a predictor.
Any other question? Sorry? Speaker.
Okay, you still with us?
Still with us? Okay.
Do you want one more?
Next case?
Okay.
Yes.
Do you want to do your hepatitis?
All right, do it quickly.
A 42-year-old single female, no significant past medical history, fever, sweats, generalized lymphadenopathy, chest X-ray normal, CT thorax, I'll show you, and CT abdomen, I'll show you. And you can see the millet-like seeds on a chest X-ray, so the miliary pattern there, you'll take my word for it, she's got big abdominal lymph nodes. And you do not have to be a rocket scientist to work out what's going on. Terribly anxious lady, and didn't want to have an HIV test, but she did agree in the end. And it was positive, CD4 count 147, high viral load, wild-type virus, and Hep B and Hep C negative. That's important because we're going to talk about what treatment to start her on. TB screen shows induced sputum positive for AFB, and the MTB probe is positive, and it's rifampicin and isoniazid probe negative. So this lady went on to standard anti-tuberculosis quadruple therapy. She'd started cotrimoxazole for PCP prophylaxis before then. Then she starts a RHZE, and then 7 days later, she goes on to efavirenz, tenofovir, and 3TC as a single tablet regimen. So 1 week after commencing the HIV treatment and 2 weeks after the TB treatment, she gets a rash, she spikes a fever, she gets hepatitis with the ALT going up to 2.5 times the upper limit of normal, and for us that's about 100. She has mild eosinophilia, having previously been normal, and her chest X-ray shows much worse miliary changes, which were not visible on the initial chest X-ray when it was only seen on the CT scan. So the question is, what is causing this rash, this eosinophilia, and this hepatitis? Is it the TB treatment? Is it the HIV treatment? Is it the Cetrin? Or is it the RS? Vote now. So you've answered already. Is that C and D. TB or D? We're going to get a vote.
Go on, vote,
mainly
vote,
Iris.
guys, vote. It's not working.
Right. Well, would Iris give you a rash like this? And when you say Iris, what do you mean? You mean Iris to the TB? I mean, that's what you're talking about, aren't you? Would you get a rash? Yes, hepatitis. Yes, fever. So you think it's a cotrimopsazole rash and Iris causing the okay, and the eosinophilia again is due to the septrin. Good, I've got it. We'll carry on, perfectly reasonable. So which of the TB drugs, if it was just one thing and the TB drugs, who's going to shout out what the most likely drug is, and you know this better than I do, that is likely to give you a rash of isoniazid, rifampicin, ethambutol, and pyrazinamide? In the studies, which is associated with the rash most? Anyone? No, it's ethambutol, actually. Rifampicin is least likely to give you a rash. And I know it's flipping confusing. So TB drugs and hepatotoxicity, all right, we know that INH is the most likely. Rifampicin obviously gives you elevations. Quite often alphos is elevated mildly. ALT, yes, but INH is the one that's most likely to give you a rip-roaring hepatitis. And the most important thing when it comes to reinstituting drugs is ethambutol is rarely the cause of the hepatitis. So the rash is ethambutol the most likely, rifampicin the least likely, but remember you can get a good going Stevens-Johnson or DRESS syndrome with any one of these antituberculous drugs. And if you get that, you're not going to be using any of these drugs again because it would be too dangerous. So the HIV drugs, which one? It's obvious, isn't it? Efavirenz is the most likely drug to give you a rash, to give you hepatitis, and it could give you eosinophilia. So what would you do? Well, this is what I did, just to speed things up. That's all right. It's a long day. We all got to let off a bit of chat. Septrin was stopped, agreeing with the lady there. She was switched to a tovaquone, not giving her dapsone. We gave her some antihistamines. We stopped the efavirenz, or I stopped it, but for the moment, I continued the tenofovir and 3TC to provide antiviral cover. Efavirenz was going to be in her body for some time. I initially continued first-line TB drugs and did LFTs daily. This was 2.5 times the upper limit of normal, but that was the wrong thing to do. Her ALT and AST increased, so they had gone up to 5 times normal, which is about 150, 160, and she had to stop therapy, her TB therapy. So I stopped TB treatment. The efavirenz, I didn't feel I could reintroduce because of the possibility it was the cause of this. So once her LFT settled, she went on to raltegravir, double dose, and with the tenofovir and 3TC. She got amikacin and moxifloxacin, were started at the same time. Then ethambutol was reintroduced, then pyrazinamide. Her LFTs remained below the upper limit of normal. Amikacin she had for 8 weeks, and then she continued on the others for 6 months. Now, that isn't the standard way of reintroducing drugs by any means, but this was in somebody with hepatitis. But this is somebody who had a rash and eosinophilia too. So I think there was danger in just restarting drugs. Septrin could have been the cause of the rash and the eosinophilia. One would never know. So I suppose, if anything else, the little discussion we've had indicates how difficult it is sometimes to tease out what is the cause of a reaction, a hypersensitivity reaction. And septrin, of course, could be the cause of everything in this lady. All right, then, I'll stop there. It's 5 to 7.
Do you think that's adequate?
Are we... Yeah, I mean, I know that the really enthusiastic people say, carry on. Yeah,
Okay. Do you want me to do the next one then?
No, I just got to text the person I'm meeting at 7. I'll do that at a question. Okay, this was a chap who was so sick when he came in. He was 38, 1 week of fevers, cough, dyspnea. He was in jail, and he collapsed, and he had to be intubated straight away. He was acidotic. Now, he was your typical sort of man who ends up in prison, I'm afraid to say. I mean, he wasn't, you know, one of these dealers who'd made millions on the market. He was a cocaine abuser, frequent prisoner, visits to prisons, no TB, HIV positive, Hep C negative, cotrimoxazole prophylaxis had been started as soon as he came in, CD4 count 2, and not on heart. And there's his x-ray, and my golly, you'll have these when you go to clinic tomorrow. His initial, as you can imagine, AFB 4 pluses out of 3. Sputum was PCP negative, so despite being started on cotrimoxazole and prednisolone, that was stopped, and it didn't look like PCP, great cavities. He started parenteral anti-TB drugs that we had, INH, RIF, levofloxacin, and amikacin. He was extubated after 4 days. He was switched to oral treatment. The probe was RIF and INA sensitive, and you see him in the TB clinic and HIV clinic. His current TB treatment then was 5 days a week by DOT, which was being organized, going back to a hostel and not the prison. He got himself much cleaner, they mostly do in hospital, and he had some heart concerns, but he'd had heart previously, a little bit of it, efavirenz, 3-TC, and tenofovir, viral load suppression, but then he stopped taking it. So he had this history of taking standard efavirenz, 3-TC, and tenofovir, and then stopped. So you have no access to a resistance test. Now, you do have access to a resistance test. It costs a lot of money, equivalent of about $150. And so I do suppose that a lot of you are faced with this situation and you can't get a rapid resistance test. Even though you might be able to get one, it's not going to be rapid. So what would you prescribe? Would you prescribe efavirenz, given that he may well have NNRTI resistance from poor adherence? It's not going to be any good. But of course, efavirenz is the easiest thing to give when you're giving rifampicin, because you just get normal, the likelihood of getting viral load success is the same if you're giving rifampicin, giving efavirenz without rifampicin or efavirenz with rifampicin, although you do get a reduction of about 30% because of induction, and you can give a little bit extra in view of that. So we used to give 800 milligrams to people over 60 kilograms in weight, but we don't do that now. Raltegravir or dolutegravir in double dose is an option. In the last patient, that's what we did. We doubled up the raltegravir dose. Boosted PI, but then the interactions with rifampicin, and you have to use rifabutin. And this is just, you know, the DDIs between rifampicin and rifabutin showing you if you can't use rifampicin, then it's a real problem. And I don't know what the accessibility to rifabutin is here, but I'm sure it's not so easy. And of course, you can't give combined anti-TB medication, you know, single tablet regimens. So there are no questions with this. We did get the genotype back. It was 103N, so that was the efavirenz, and 184V. And the patient was successfully treated with rifabutin-based regimen, and in fact got Kaletra, tenofovir, and AZT. And we heard about resistance, and if you fail tenofovir, the possibility of having a K65. AZT is a particularly active drug. So I'm going to stop there because it's definitely 7 o'clock, 1 minute past. And are there any questions?
Any questions? No? Do you want me to?
I do think you've had a very long day. You know, it's 11 and a half hours or something, no, 10 and a half hours you've been at it. And so those of you who are still on your seat.
Ed, can I do the last one? I'll do the last one.
Yes, I'm going to go because I've got to meet
Let me do the
somebody for
last
dinner.
one.
So thank you very much for listening. And
That's all right, I'll do the last one with them. Right. 37, you better not forget your stuff. 37-year-old woman, known to be HIV positive. She has a CD4 count of 157. She was referred from somewhere else, presented to the infectious disease department, and she informed them she was diagnosed about 6 weeks ago, and all her tests and her baselines were normal. So as was routine, then she was commenced on efavirenz, tenofovir, that's your Atripla, as a single treatment regimen. And you can see that there was, an effect. Her viral load decreased from 780,000 to 12,000. That means over a 6-week period. But then this rebounded. Okay, we expect up to 2 log drop within 4 weeks. Okay, but in 6 weeks, there was still some virus around. What are the possible reasons for a viral load rebound? You can just shout, you don't need to. So what are the possible reasons? Say that again. Adherence, brilliant. Something else? Failure, yeah? Anything else? Because remember, we don't have she just said the baselines were normal, okay? Poor compliance, poor absorption, possibly some interaction. She already had a resistant virus. Concerns about pregnancy. What does that tell you? Why has this been put down? And maybe something else. Say that again? Yes. See, there was this for a long period of time, and I mean, efavirenz, Atripla, causes teratogenicity. And I've had several women who have wanted to conceive, and they haven't told us that they're stopping their drugs. They conceive, and then they turn up 8 weeks, 10 weeks pregnant. It's too late anyway. So I've left them on Atripla, even though they had concerns, regarding the drug. So that could be one of the reasons. And therefore, it's imperative that when we start someone, a female on treatment, we ask them, are they planning a family? And if they are, you do have to talk about Atripla with them. Anyway, what had happened really with this lady was she'd lost her job, her partner had left her, she had no money, she was moving in with her sister, and her sister was unaware of her diagnosis, and therefore she'd, sort of taking it on a sort of irregular period. But now, she said that she's moved into a new flat, okay, and she's committed to taking her tablets. Okay, so therefore with this patient, you have to guess a resistance pattern. What would you do? Okay, there are 2 options here. Restart efavirenz, you can vote on this. Restart efavirenz as a single tablet with tenofovir 3TC, or switch her to a second line. Please vote. Okay. Tarun, do we have any luck there? Okay, so this is, so what do we have here? Switch to second line, yeah? So most of you, who said restart? Okay, do you want to save yourself? Sorry? Okay. As a single tablet, why would we restart efavirenz? It has its advantages, okay? Playing safe is the second option, that is second line treatment PI, because it's a forgiving drug, and you're not going to get wrong with it. But remember, she's promised that she's moved to a flat now, she has her own home, she's going to be compliant, and she's going to stick to her medication. Do you trust her? Yeah? I probably would. And the advantage is that you can monitor her viral load within 3 months. Rather than giving her a 6-month appointment, which we normally do, I'd probably bring her back early and see what her viral load has done, okay? The benefits with efavirenz is that the drug may still be active, you're saving your second line, which is your PI, and maybe she had side effects. Remember the presentation earlier where they talked about efavirenz causing a lot of suicidality in meta-analysis. And it's surprising the number of people, once you switch them to another drug, and they say, I mean, my patients use the word spaced out. I was totally spaced out. I didn't realize I was having side effects with efavirenz. It's a much more common side effect than people talk about. So, did she have side effects and she stopped it? Possibility, that has to be taken into account. And again, boosted PI, we are sort of certain of its activity. So there are benefits for both treatment regimens, whichever one you decide to go for. Now, which NRTI, if you were going to switch to a PI, would you use an AZT? Yes, probably yes, because it retains its hypersusceptibility even in the presence of a case 6-5R. It's easy to give AZT3TC as a BD dose and monitor its, and probably it has fewer side effects or adverse events. Tenofovir, unlikely case 6-5R because the viral load the patient has had treatment for only 6 weeks, remember? And you looked at their viral load. The M184 we know works better in the presence of tenofovir. It's a single tablet again, and it's well tolerated. So again, there is some advantage with option 2 using an NRTI. That's it, basically. Well, thank you for your patience and your, sitting here with us. Enjoy your evening. We'll see you tomorrow.